Hello. Check, 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 sound check, 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 sound check. Hello. Hey, hey. Check, sound check, 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 check. Hello. Sound check, 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 check. Hello. Sound check, 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 check. Hello. 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 Check, sound check. આમાં આવી ગયો છે. Hello. Check, sound check. Hello. Check, 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 sound check. 1, 2, 3, 4, 5, 6, 7, 8. Check, sound check. Okay. કયો? Hello. Check, sound check. Check, 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 sound check. Check. હા છે ને? Check, sound check. એક જ મિનિટ ઉભા રહેજો. Hello. Check, 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 check. જો check, 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 check. Check, 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 check. Check, 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 check. Check, 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 check. Check, 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 check. Check, check, check. Check, 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 check. Check. વધારું? Check, sound check. બરોબર? હાલો ચેક 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 સાઉન્ડ ચેક. બરોબર ને?
લેકર હલો ચેક બરાબર હે. ચેક હલો ચેક હલો ચેક વધારે નહીં હલો ચેક હલો ચેક ચેક હલો ચેક હલો ઠીક છે
Good morning, everyone. Welcome to the first session in Hall B. So, the session is focused on MSK MRI. We have chairpersons with us, Dr. Kalpesh Shah and Dr. Dipali Shah. So, I'll be taking the first talk. So, this is my introductory slide. You can just read it. Okay. So, the topic of my presentation is spinal ligamentous injury in trauma, MRI markers of instability which you cannot miss. So, in this whole presentation, we'll be seeing how to recognize unstable spine beyond fractures. So, we'll see how the ligaments are important for spinal stability. So, why ligaments matter? It's because bone heals, but missed ligamentous injuries often lead to deformity, delayed instability, neurological deterioration, and failed fixation. So, it is very important to look for ligaments and injuries affecting them. So, previously, this three-column concept was proposed by Dennis, and according to this three-column concept, the spine is divided in three columns. Anterior column consists of anterior two-thirds of the vertebra, intervertebral disc, and anterior longitudinal ligament. Then we have the middle column, which consists of posterior one-third of the vertebral body, intervertebral disc, and PLL. Then we have the posterior column, which consists of the posterior elements, ligamentum flavum, and the interspinous and supraspinous ligaments. So previously it was believed that fractures which affect more than one column are unstable and they should be treated surgically. But now the concept is modified and ligamentous injury, ligaments, they have taken the central stage, and even if the fracture is involving more than one column but ligaments are intact, they can be treated conservatively. Now let us look at the important ligaments that we have. First, the cervical spine. So this is the sag picture of the cervical spine where we can see the important ligaments. First is the anterior atlanto-occipital membrane. Then we have posterior atlanto-occipital membrane. Here is the anterior longitudinal ligament which covers the anterior surface of the vertebral bodies. Then we have posterior longitudinal ligament which covers the posterior surface of the vertebral body and intervertebral disc. Then we have ligamentum flavum which connect the lamina of vertebrae. Then we have interspinous and supraspinous ligament, and nuchal ligament is basically it is confined to the cervical spine only. So we have this nuchal ligament posteriorly in the midline. At the CVJ, cervicovertebral junction, we have apical ligament of dens which connect the tip of dens with the occiput. Then we have cruciform ligament which has longitudinal and transverse component. Then we have tectorial membrane which covers the posterior surface of the cruciform ligament, and it downwards it continues as PLL. Looking at the cross section, this is the anterior atlanto-occipital membrane. Then we have posterior atlanto-occipital membrane. These are alar ligaments. Then we have cruciform ligament, the transverse as well as the longitudinal component, and the tectorial membrane which covers the posterior aspect of the cruciform ligament. So this is cruciform ligament and these are alar ligaments. So these are important ligaments in the craniovertebral junction. Coming to the thoracolumbar spine, here we have anterior longitudinal ligament, PLL, ligamentum flavum, interspinous and supraspinous ligament. So when we speak of these three ligaments in the posterior ligamentous complex, the two most important ligaments are ligamentum flavum and supraspinous ligament. Coming to spine trauma topography, so looking at the whole spine, we can divide the whole spine in four parts. First is the CVJ, C1 and C2 vertebra. Then we have subaxial cervical spine. Then we have thoracolumbar spine and sacral spine. So there are two areas which are more prone to trauma because of change in curvature. So here cervical lordotic curvature converts into thoracic kyphotic curvature, and at this junction, this area is more prone to injury. Similarly, at thoracolumbar junction, again, there is change in curvature, and this area is more prone to injury. Now, let us look at this MRI video, and we'll have a look at how the normal ligaments look like. So we are going from cranial to caudal, and here is the tectorial membrane. Then we have, so this is the dens, and here we have cruciform ligament. These black parts are the alar ligament. As we go down, you can see the anterior longitudinal ligament, posterior longitudinal ligament, and ligamentum flavum. And we can also have a look at the facet joint. The facet joint capsule, they also form an important part of the ligamentous complex. And between these spines, these black structures are basically interspinous ligament. And posteriorly, we have supraspinous ligament and nuchal ligament. Looking at the sagittal plane, so here you can see how the facet joints articulate with each other, and this is how the normal facet joint anatomy should look like on parasagittal plane. Then we have posterior and anterior longitudinal ligament, and this black stripe is the ligamentum flavum. Then we have interspinous, and this black whole thick structure is the supraspinous and nuchal ligament. And at the cervicovertebral junction, we have our important ligaments of the CVJ. This is the coronal plane, where we can see again alar ligament. This is PLL. Then we have ligamentum flavum, and posteriorly we have interspinous ligament, supraspinous ligament, and nuchal ligament. Now coming to the different modes of injuries. So we can divide spinal trauma mechanism into three parts: compression injury, distraction, and translation injury. In compression injury, it can involve either one end plate, or it can involve end plate with posterior vertebral border, which is basically incomplete burst fracture. And when it involves both end plates as well as posterior border, it is complete burst fracture. In pure compression injuries, generally ligaments are relatively intact. Posterior ligamentous complex is not that involved. When it comes to distraction injury, this is a severe kind of injury. There are two types of distraction injury. It can be hyperflexion or hyperextension. So this is the hyperflexion injury, and this is the hyperextension injury. Then we have translation injury, where one vertebral body, it translates over the another vertebral body. There is either anterior translation or posterior translation. It can be medial or lateral, and it is often associated with injuries to ligamentous complex and facet joints. Coming to distraction injuries, first is the hyperflexion injury, where there is flexion of the spine and distraction of the posterior column. It can be purely osseous injury, like in cases of chance fracture, which is basically fracture which traverses from body to the posterior element. So this is chance fracture dislocation. In pure osseous trauma, ligaments are not involved, but mostly they are mixed type, so they involve bone as well as ligaments. So here we can see a radiograph of chance fracture. So this appearance is known as empty vertebra sign. So you can see a kind of radiolucency in the vertebral body. So that is empty vertebra sign in a case of chance fracture. Here you can see again fracture which is involving the posterior part of vertebral body as well as the posterior element. This is the CT of the same case, and this is the MR. There is also rupture of posterior supraspinous ligament here, and so it happens because of hyperflexion, normally seen in in road traffic accidents in the rear passengers where they have only the lap seat belt. So this is known as lap seat belt injury. Next is when it involves not only bones but also ligaments. So rarely we see pure chance fracture. Mostly they are associated with ligamentous injuries. So here we can see a fracture dislocation in the 11 vertebra, and there is cord contusion. Plus you can see this black strip discontinuity. So this ligamentum flavum is discontinuous over here. There is injury in the ligamentum flavum as well as in the supraspinous ligament and in the interspinous ligament. Plus we can also see ALL and PLL rupture. So this is a severe kind of fracture dislocation which is involving ligaments as well. Moving to hyperextension injury, where there is hyperextension of the spine, there will be rupture of anterior longitudinal ligament. Normally it happens in stiff spine in cases of ankylosing spondylitis where there is bamboo spine kind of appearance. So here you can see a case of bamboo spine in ankylosing spondylitis and hyperextension fracture, which is involving the different ligamentous complex ALL as well as PLL. Next is translation injury. So it is a severe kind of injury and it almost always involves the ligamentous complex. So here you can see an example of translation injury where one cervical vertebra is moving above the inferior cervical vertebra. There is cord contusion and there is rupture of ALL as well as PLL and ligamentum flavum, plus there is injury in the interspinous and supraspinous ligament. There are different scoring systems for spinal trauma classification for recommendation of the management. And first is this TLIX and SLIX system, so thoracolumbar, and this is for cervical spine. And both these classification system, they have this score for ligamentous complex. So that's how the ligamentous complex are so important, that they are given so much importance in the classification system as well. So we have posterior ligamentous complex integrity in TLIX score, and in SLIX score we have discoligamentous complex. So both of them are very important in spinal stability. Recently this AO spine classification system, they have also put an importance to tension band injury, anterior as well as posterior. The examples which I have shown, in hyperextension anterior tension band is gone, and in hyperflexion injury posterior tension band is gone. So these ligamentous injuries, they have given due importance in different classification system as well. Now coming to different cases, let us look at this case, a 35-year-old male who presented with road traffic accident. So what you can see here, there is anterior translation of one vertebra over the another, plus there is cord contusion, there is rupture of anterior longitudinal ligament PLL and ligamentum flavum, plus the interspinous and supraspinous ligament. Besides that, when you look at the parasagittal sequence, you get to see there is dislocation of the facet joint. So facet joints are very important, especially in cases of cervical spine, and facet joint capsules, they are quite important in stabilizing the spine. And in cervical spine we can either get jumped facet or cervical facet dislocation, which can be unilateral or bilateral, and they require surgery. So it is very important not to miss them. So here you can see facet joint dislocation, and this is the appearance on CT. So what is this appearance on CT known as? This appearance, basically there is a name for this. This is normally cervical facets, they look like burger, but when there is facet dislocation in axial sections, when you look at them, this is reverse hamburger sign. In the same patient also had vertebral artery thrombosis and patient had infarct. So it is also important to look at the flow voids in the vertebral artery, and if you can also image the brain. Next case. So this is the CT, where we can see compression fracture, plus there is dislocation of fracture fragment in the spinal canal. So on CT we cannot look at the ligaments as such like we see in MR, but there are some indirect indicators of ligamentous injury on CT. These are like spinous process fracture, lamina fracture. So you need to look at these fractures, and if these fractures are present, there are high chances that ligamentous injury is also present. So in the same case, when we did MRI, this is plain T2. Again, plain T2 is not very great sequence when you want to see edema. But here you can see the findings which we were seeing on CT, plus cord compression is also there, and there are fractures in the cervical as well as dorsal spinous process. In stir sequence or T2 fat set sequence, where we can see a lot of edema in the interspinous ligaments and supraspinous ligament, plus there is black stripe discontinuity. So this black stripe discontinuity is very important when we look at ligamentum flavum and the other ligaments along the spinous process. This is post fixation. So patient underwent surgery and surgeon took care of this unstable spine. This is a case of, again, chance fracture dislocation. And in same case, again, we got this black stripe discontinuity. There is rupture of ligamentum flavum and supraspinous ligament. So if you don't see any, if you find this black stripe continuous, supraspinous ligament continuous, only some edema in the interspinous area, there are high chances that the ligamentous complex is intact. And so you need to look for the black stripe discontinuity. This is post-op CT. This is the cervical spine, where we can see rupture of anterior atlanto-occipital membrane and alar and apical ligament. And again here rupture of alar ligament, and there is involvement of occipital condyles as well. So posterior ligamentous complex is very important, and for the stability of thoracolumbar spine and cervical spine. And MRI, especially fat saturated T2 weighted sequence, they are highly sensitive and specific for evaluating PLC. Yeah. So take home message is spinal trauma and ligamentous injury are quite important for making the treatment plan. And a normal or minimally abnormal CT does not exclude spinal instability, and STIR is the most sensitive sequence. Thank you.
Thank you, Dr. Salman. We have started 10 minutes late, so request all faculties to remain within the time. Can we have the band 1 minute earlier, please, so that they get 1 minute? Anybody, why it is known as ligamental flavum? So most of the ligaments are usually, as per the anatomy, anterior longitudinal, posterior longitudinal, or ligament. Why it is known as flavum? Anybody? Flavum in Latin is gold or yellow, and this ligament, because of the elasticity and protein contains, looks of that color. So that is how the name has come. Thank you. We will keep the questions at the end. So next we have Dr. Joshita Singh. She is speaking on glenohumeral joint instability from micro to macro instability.
Right. Good morning, everyone. Nice to see that the hall is not empty when there's a refresher course happening there. Okay, so we move to a simple topic that is glenohumeral joint instability. Now, this is something that we see frequently in our day-to-day practice. That is because the glenohumeral joint is the joint in the human body that dislocates maximally. This happens because the anatomy of the joint is such that it allows for wide range of movement, but this range of movement comes at the cost of stability at the joint. Stability at the glenohumeral joint is provided for by the bony articulation anatomy itself, which works on the concavity compression mechanism, by the negative intra-articular pressure, by static soft tissue stabilizers that include the labrum, the glenohumeral ligaments, and the joint capsule, and by the dynamic stabilizers that include the rotator cuff muscles, the elongated biceps tendon, and the periscapular muscles. Now, glenohumeral instability can be classified depending on the direction of instability into unidirectional, which can be anterior or posterior, or multidirectional. Depending on the etiology, it can be classified into traumatic or non-traumatic, and microtraumatic is what results in microinstability due to repetitive overuse injury. Just put that light off. Chronicity also allows us to classify this injury into acute first-time dislocations and chronic scenario with repeated dislocations and subluxations. For the purpose of this lecture, we'll basically be focusing on the MR imaging changes that we see in anterior instability, and then we'll quickly brush through the other clinical scenarios. So let's talk of anterior instability. Now, anterior instability is the most common type of instability that we see, and trauma is the etiology for over 90% of acute first-time dislocations. Just put that light off. It shines into my eye, and that's why I requested you to put that off, please. The younger the age of onset of this first-time dislocation, the higher is it likely to become a recurrent instability situation. Our job as radiologists in the scenario of anterior instability is to document what is the labroligamentous injuries and the osseous injuries that occur along the anteroinferior aspect of the glenoid and the posterolateral aspect of the humeral head. And apart from that, we also need to quantify the amount of bone loss and talk of whether this is an on-track or an off-track lesion. We'll see how we look at all of these situations. So the commonest soft tissue injury that you see in anterior instability is the classic Bankart lesion. This is avulsion of the labrum as well as a tear of the scapular periosteum. So what happens, because there's nothing to hold this labrum in place, this labrum is free to displace. So that is how you would identify your Bankart lesion. Now, since there's no intact scapular periosteum, this injury does not have a potential to heal on its own. The labrum itself can be normal in signal intensity, as you see in this case, or it can be markedly hyperintense, as you see in this case, and it can also be fragmented. The other lesions that you see are the Bankart variants, and we'll begin with the Perthes lesion, although this is not that commonly seen. Herein, what happens is that the labrum is torn, but the scapular periosteum is intact and just a wee bit stripped off the bone. So the labrum is then kept in its proper place. Now, because this is a normally placed labrum, sometimes it can be a little difficult to pick up this injury, and then doing imaging in the aber position will unmask this lesion. Also, since the scapular periosteum is intact, this injury has the potential to heal on its own. Then you have the Alpsa lesion, which is anterior labroligamentous periosteal sleeve avulsion. Herein, the labrum is avulsed, the scapular periosteum is intact but is widely stripped, and therefore this allows the labrum to displace from its normal position along the scapular neck. Since the scapular periosteum is intact, this labrum can heal in that position and scar down in that position. Sometimes it's difficult to pick up this scarred labrum in that displaced position, as in this case, you can just see a little bit of blunting of the anteroinferior labrum, but when you look here, that's the displaced labrum. So it's a good idea to, in your mental checklist while you're evaluating these cases, to do a careful look at this site. Then you can have the GLAD lesion or the glenolabral articular disruption. Here the labral tear is a small tear and it is associated with a cartilaginous defect. So you see here, there is a small labral tear that you can see only, there's just some fraying of the labrum there, and there is a cartilaginous defect here. Now, if this labral tear is small, sometimes these patients, instead of presenting with instability, can present with just pain from the osteochondral injury. It's not just the labrum, but also the glenohumeral ligament in the joint capsule that can tear, and that can tear anywhere, either from its glenoid attachment, as you see in this case. So you see that's the normal labrum, and that is the IGHL, which is torn from its attachment to the labrum. Or it can tear from its humeral attachment, as you see in this case. That's the IGHL, markedly hyperintense. You see edema on both sides of the ligament, and since there's a little bone flake that has come off, we know that this is not just a soft tissue Hagel, but a bony Hagel lesion. These injuries are best picked in the acute scenario when edema outlines the injury and depicts it well. As these injuries become more chronic and this edema settles down, then it's difficult to pick up these injuries. So this is an example here. This is a 58-year-old gentleman who had a fall from bike and presented to the ER with a deformity at the shoulder. That's the X-ray at the time of presentation. You can see an anteroinferior dislocation, and that's after reduction. We've done the MR imaging following the reduction, and what do you see here? You see that is the tone labroligamentous complex. That is, you can see the laxity of the IGHL there, and you see that more inferiorly there is a labral tear there, that which you can identify as a hyperintense labral tear. You also see the acute Hill-Sachs lesion and the bone marrow edema along with it. But what you also see is a rotator cuff lesion. There's a tear, insertional tear of the supraspinatus tendon, and rotator cuff lesions are associated injuries that occur more commonly in the older patients. So that was about the soft tissue injuries that you see in anterior instability. What are the bony lesions that you can see? You can have a bony Bankart lesion, which is a fracture of the anteroinferior bony glenoid. Now, when you identify this, what are you supposed to comment about? You're supposed to comment about the size and the number of these bony fragments, and whether the bony fragment is displaced or it's in close apposition to the parent bone. When it is in proximity of the parent bone, a bony Bankart lesion can heal in that position. When the fragments are small and they are displaced, then the bone fragments can also get resorbed. Then you have the Hill-Sachs lesion, which is a lot more commoner because it's the softer bone, and that is nothing but an impaction fracture of the posterolateral humeral head. The larger the size of the Hill-Sachs lesion, it can be flattened or a little bit more deep or angular. The more angular the lesion and the more medially placed the lesion, the more likely is this going to be an engaging Hill-Sachs lesion. So then the other thing that you have to comment upon in your reports is the amount of glenoid bone loss. Glenoid bone loss, what it does is it reduces the contact area of the glenoid and the humeral head, and this results in a cascade of further instability and further glenoid bone loss. When the glenoid bone loss is more than 13%, this is associated with an increased chance of frequency of dislocation. When it's more than 25%, then this would need a surgical modification, which means that now you can't just do a soft tissue Bankart repair. You would have to do a bone augmentation surgery, such as coracoid transfer, like in a Latharche surgery. How do you identify the glenoid bone loss? In the initial stages, you'll just see straightening of the anteroinferior margin, and then as it progresses, this becomes more concave, giving rise to an inverted pear appearance. You can use both CT and MR to quantify this bone loss. On CT, you have comparison of the contralateral normal side, and it is presumed that both sides are equal, so you can get from the contralateral normal side, you can quantify this. But on MR, since you don't have the normal side, you would use the best fit circle. So this is how you would do it. This is the normal side, and this is the affected side. You can see that the initial bone loss is just seen as a straightening along the anteroinferior cortex of the bony glenoid there. So first you drop a line from the supraglenoid tubercle to the inferior aspect of the glenoid, and then at right angles to this, you measure the width of the bony glenoid at its maximum width. And similarly, you measure on the side at the area of the glenoid bone loss. This minus this distance will give you the amount of bone that is lost. Divided by this into 100 will give you the glenoid bone loss in percentage. When you're using the best fit circle, this is how you would calculate it. You draw a best fit circle which goes through the posterior and the inferior margin of the bony glenoid. Line that we drew earlier. This total distance would be the glenoid width, and this distance from the anterior margin of the rim to the margin that you're visualizing, that is the amount of bone that is lost. So this distance by this distance into 100 would give you the quantified glenoid bone loss. Let's talk of the glenoid track. This is something that most surgeons want. So your report in an instability situation, an anterior instability, should include a note on glenoid track, whether it is asked or not asked for. The glenoid tract is the contact between the glenoid and the humeral head in when the patient goes in abduction and external rotation. We know that from cadaveric studies, we know that this is 83% of the glenoid width. So you calculate the glenoid tract by this formula, 0.83 into the glenoid width minus the bone loss that you have just calculated. And then you also calculate the Hill-Sachs index, which is the Hill-Sachs length and the bone bridge till the rotator cuff attachment. If the glenoid tract is more than the Hill-Sachs index, it's going to be a non-engaging or an on-track lesion. If it is lesser than the Hill-Sachs index, it is likely to be an engaging or an off-track lesion. So this is how you would calculate it, by the best fit circle method. So 0.83 into this distance, that is distance 2, minus this distance, that is distance 3, would give you the glenoid tract. And then you measure the Hill-Sachs index till the rotator cuff attachment. So that in this case, since you have a bony bridge there, you will measure the Hill-Sachs index plus that little bone bridge till the till the rotator cuff attachment. So that's how you would get your Hill-Sachs index, and then you can calculate whether it is on-track or off-track lesion. So this is a 30-year-old gentleman who's had a bank cart repair done about 4 years ago, but still has recurrent dislocations. Now, what do we see? We see those suture anchors from the prior surgery. You see that is the labrum, which is opposed to the bone, but you see a little fluid cleft separating that labrum. And when we've calculated the glenoid tract comes to 18.7, while the Hill-Sachs index comes to 19.1. So clearly this is an off-track lesion because the glenoid tract is more than the Hill-Sachs index. So this patient underwent a repeat surgery. They found at surgery that this labrum was not attached to the bone, so they did a revision bank cart repair and they did a remplissage, which means what they did is that they attached this infraspinatus tendon to this Hill-Sachs lesion, converting the Hill-Sachs lesion into now an extra-articular lesion. Therefore, the patient will not dislocate subsequently. Now quickly let's move to posterior instability. This is rarer than anterior instability and occurs when there is forceful adduction and internal rotation. The typical clinical scenario is a patient who presents with a convulsion or an electric shock or an high-speed road traffic accidents. On imaging, you would see similar injuries like you saw in anterior instability, just a little posterior. So posterior, just a mirror image of what you would see earlier. So an example here, this is a gentleman who's had a convulsion and posterior instability following that convulsion. What you're seeing is a reverse Hill-Sachs lesion there with an impaction fracture on the anteromedial humeral head. And you're seeing a tear of the postero-inferior labrum there. And as you go more inferiorly, roughly around the 6 o'clock position, you see that there is also a tear of the capsule which has been stripped off, and it takes away a chip of bone along with it. So you can have a combination injury pattern. Multidirectional instability, not much of a role of the radiologist here, just that you should know that this is instability with, in 2 or more directions. Often it is bilateral involvement, and usually there's some inferior instability that is part of the multidirectional instability. Occurs in young women with poor muscle stock, or in patients with congenital hyperlaxity. Your imaging can be normal, or you may just see a redundant joint capsule. Let's move quickly to microinstability. This is defined as any rotational or directional pathologic laxity that leads to abnormal biomechanics at the joint without an overt dislocation. Common in athletes who are doing the abduction and external rotation position, as in sports that are associated with throwing in activities, racket sports, or in swimming. What basically happens is that there's a shift in the contact point between the humeral head and the glenoid, and this can cause internal impingement. It can either be posterosuperior impingement or anterosuperior impingement. We'll just talk of the posterosuperior impingement. That is just 1 minute more, just one slide. That is the commoner of the two. Typically, these patients present with posterior pain or a sense of weakness during this throwing activity, and this happens because of a repetitive injury which can lead either to a laxity of the anterior joint capsule and thereby shifting the contact point between the humerus and the glenoid, Or the repetitive injury causes thickening of the posterior joint capsule and the posterior band of the glenohumeral ligament that allows this contact point between the humeral head and the bony glenoid to shift in a posterosuperior direction. And this then results in torsional forces at the biceps labral anchor, resulting in a posterosuperior labral lesion. Also, torsional forces at the rotator cuff result in articular-sided tears of this rotator cuff. Just an example here, this is a middle-aged gentleman who plays badminton, and he's been playing that for years now, and now he complains of pain during play. What you see is, this posterosuperior slap lesion, again well depicted on your sagittal oblique images and your axial images, and then you see a tendinosis of the articular surface of the supraspinatus tendon. So that kind of concludes my lecture. I'll just take a minute to invite you to the next two events that the MSS Society is doing, the annual conference in Calcutta and the cadaveric course at AIIMS Mangalgiri. Thank you.
Thank you, Dr. Josita. It was wonderful, micro to macro. Dr. Josita is from Pune and has been a regular faculty over the years. Does anybody would tell what is reverse shoulder? Any idea about reverse shoulder? The reverse shoulder joint is a total joint replacement surgery when the normal surgery fails or is not possible because of severe rotator cuff injury or because of the proximal humerus injury. So the cuff is on the humeral side and the socket is on the other side, and the center of gravity shifts. So the deltoid takes over the rotator cuff. So when rotator cuff is not able to work, a normal surgery would not be successful. As a radiologist of MSK, we should know what the surgeons are doing. Thank you. We move to the next one.
Now we have excellent talk on elbow MRI by Dr. Simran Kaur. She is a consultant MSK radiologist in UK.
Hi, morning everyone. How do I move this to my slide? Can I get my PowerPoint? Perfect. So over the next 15 minutes or so, we'll talk about thrower's elbow and findings that influence surgical decisions. I have no disclosures. Basically, I remember when I was starting radiology, one of my mentors told me, radiology is nothing but anatomy and pathology. You know your anatomy, you know your pathology, you sort it, you as good as you can be. So we'll I'll divide my talk into, we'll talk about anatomy first, then we go into biomechanics, because that is why you need to understand why you get injuries and what are the patterns of injuries depending on the biomechanics. Once you know that, everybody can identify the injury patterns, and then we move on to treatment. So this is overwhelmingly an American problem, not our problem, but this is predominantly seen in baseball players and mostly pitchers, but it's a problem where any event or any sporting activity that allows you, when you're doing overhead activity, overhead throwing movement, when your elbow is going into valgus and extension. So your forces are extensive valgus plus elbow extension. These two are responsible for the trauma and the pattern that we see in the subsequent slides. So you saw the glenohumeral joint, really nice joint, right? A concave surface, a convex surface, but elbow, come on. You have a distal humeral metaphysis, it flares into epicondyles, condyles, then you have the capitellum trochlea, peaks and troughs. It's not really a very simple articulation as compared to other joints that you have in your body. So it's only in extreme flexion. So when you are extremely flexing your elbow, what's coming? Your coronoid process comes into the anterior coronoid fossa, right? So bone locks. When you're extending your joint completely, what's happening? Your olecranon is coming into your olecranon fossa, complete lock. So that's the bony lock. But that happens only in extreme movements, extreme part of your flexion or extension. Mostly 20 to 120 degree of flexion,
you are reliant only on your soft tissue stabilizers and predominantly your medial ligament, which is the ulnar collateral ligament. Now, ulnar collateral ligament has 3 bundles. We'll talk about pertinent anatomy just for a minute or two. You have your anterior bundle, which is the main guy here, right? This is the one that's really important and prevents your valgus, it's the main restraint for your valgus force. It attaches from the medial epicondyle, goes anterolaterally, attaches to the sublime tubercle. Then you have this fan-shaped posterior bundle, again slightly posterior to the medial epicondyle, fans and attaches to the semilunar notch posteriorly. I don't know why this transverse ligament is there. It's just lying there. So it really doesn't contribute much. Why? Because for any ligament or tendon to contribute to stability, it has to traverse the joint. Your transverse ligament is between the olecranon and olecranon and coronoid. So it's not really doing much. We don't pay much attention to that. So look at the anatomy. Again, on the images now, if you see here the fan-shaped ligament, and then if you move from posterior to anterior, this is is there a pointer? Okay, fine, you can see. This is your anterior band, thick band, low signal intensity attaching to the sublime tubercle. If you look at the axials, you have the posterior band. So if you're looking at your axial images, find the ulnar neurovascular bundle, easy to find, not a big deal, and look at the flow. That is your posterior band of the ulnar collateral ligament. And of course, when there is injury here, always be mindful of the structures that are in the vicinity, right? Because your ligament is not going to fail on its entirety, and any problem there will result to problems where? To the medial epicondyle, which you have your flexor pronator mass attached, and your ulnar neurovascular bundle. So you have to look into the medial complex as an entire complex. You all know where the flexor tendons attach. It attaches from the medial epicondyle, and on the axial images directly overlies the anterior bundle of the ulnar collateral ligament. And then posteriorly, we discuss your ulnar nerve sits in the cubital tunnel, and your posterior band forms the flow. One important note, sometimes ulnar neuritis accompanies ulnar collateral ligament insufficiency. So in that case, if you just treat your nerve, your problems are not going to go because you have not treated the cause. You have to treat the ligament. Okay, so this is the extreme motion that we're talking about. See how the elbow, obviously so it's a complex kinetic chain. You need to understand the biomechanics of this movement. It starts in the foot. You have extreme forces. It starts in the foot, travels up from the torso and your core muscles, then to the shoulder, and then you have this valgus extension at the elbow, and it's released once you have released the ball. So you do realize there's a complex mechanism, and there's a lot of research and a lot of, a lot of mechanics going on here, and, the high athletes, just by how you put your stride, how much you rotate, how much movement of the trunk you're doing, you can actually alter the forces on your elbow and shoulder. So let's look at this baseball pitcher. Just look at the amount of valgus extension. This is supraphysiological. This is not what your body is made to do. This is one of those Iron Man high rocks, which is the new midlife crisis of our generation. So you do this, imagine the extension, imagine the valgus stress. Let's have a look at now what will happen. Simple, joint 3. So valgus stress, what's your main restraint? Medial collateral ligament. Once your elbow is going in valgus, what's happening? This is getting stretched. What will you get? Simple, you will get tearing there. It can be acute. If one of you tries to do that pitching, I'm sure you're going to snap everything. Then what happens? This side gets stretched. What's happening to the lateral side? Compression, the radius and capitellum squished against each other. So what will you get? Fractures either of the radius or of the capitellum. And then when the person releases the ball, towards the end, which is the deceleration phase, your elbow gets hyperextended. Once the throw is done, you have an hyperextension, and what happens? Your posteromedial olecranon impinges, right? And that's when you get this posteromedial osteophyte. These can break, you can have radiocapitellar joint, osteochondral injuries, which can result in loose bodies, instability, and so on. So you know this mechanism. So now you know what all can happen and what all you need to tell the surgeon and what the surgeon needs to do. Again, UCL tears. Again, we discussed what's in the vicinity of UCL, your flexor pronator mass. So you can have flexor pronator mass problems. You can have problems of the ulnar nerve. And lateral and posterior, we all discussed. Okay, this is your nice, everybody knows how the ligaments look. This is your nice low signal intensity ulnar collateral ligament. Now here, you don't see that low signal intensity band. You see this just thick, unhealthy looking, fragile, inflammatory granulation tissue. So it's a full thickness injury. This one, you have the ligament, the integrity is preserved, but there is high signal intensity. So you have this partial thickness proximal tear. And here, I'm sure everybody knows about this arthrographic T sign where you see this, sorry about that, where you see this partial thickness injury of the deep fibers. So you see, this is the sublime tubercle. Your ligaments had to attach here, but it's not attached there. So it's a partial thickness injury. In my center, we do a lot of arthrographies, and I think arthrographies, arthrograms have the highest sensitivity and specificity, especially when you want to differentiate between whether it's a high-grade partial or a full thickness tear. So that's what we use it for. Again, you see on the medial side, it's not really attaching at the sublime tubercle. And then on the, this is an arthrogram that we did. And on the radial head, you see this area is denuded. So it's a chondral injury, not an osteochondral injury, because your underlying bone is completely normal. Now this one was one of you who tried to do this pitching. Complete avulsion of everything. So no ligament. I think I have 5-6 more minutes, right? Yeah. So no ligament and complete, the entire flexor pronator mass is just torn off. So this is also that can happen, mostly in professional athletes, because obviously they've gone years and years of training and they're training this. You generally get chronic stuff, you know, chronic attrition, chronic problems, but this can also happen. Another case of just an osteochondral injury. Now this is osteochondral injury. Overlying cartilage has a fissure and there are changes in the subchondral bone, again involving the lateral. So what mechanism is this? This is compression, right? Your medial side had tensile force and your lateral side compressed, banged against each other. You can get these occult fractures. Again, posteromedial osteophyte formation because of the shearing strain that happens during the last phase, which is the deceleration phase. Another patient where we had this, you can see this olecranon stress fracture because there's a lot of shear happening there. You know, these are supraphysiological forces. This is not normal force that you get. So obviously you can, you know, if you need treatment, you can just put a nail in it. Now coming to children. Children are different, right? Children are different. And again, when you're looking at an MRI and you are reporting pediatrics, which is complex, always look at the site, which is the weakest link in the chain. So when your child is, you're presented with a child, they don't have big muscle mass. And the weakest point in them is the physis. So if they are these little boys, they are playing baseball, you're going to get apophysitis or fragmentation of the apophysis. Now this child grows up, gets adolescent, gets more muscle mass. So your muscles are now stronger. So what happens when they get injury, this muscle is stronger, it pulls. So what do you get? You get an avulsion. And of course, once it's fused, you're basically small adults and you get the same problems as you get in adults. So always, even when you're reporting trauma, you're reporting anything, look at the age and start reporting or start thinking, what's the weakest site in this link? What will fail first? That's how you report, or that's how you think. Again, just apophysitis, little league's elbow, we all know it's called that. Now coming to the treatment, of course, you know, if I develop an UCL injury, I'm not going to get a surgery. I'm just going to rest. But this is different for athletes who are high performance athletes. They need surgery. If, again, they also start with a non-operative management. We're doing PRPs for them. Again, the literature is varied. PRP is like a little bit of voodoo magic there. Some shows great results, some show not so great results. But then surgery, if you have failed conservative treatment or you have a full thickness tear, patient go for surgery. So now the first surgery was done by Job on Tommy Hunter, who was a pitcher in 1970s. So what he did, in order to get to the tendon, he basically detached the flexor pronator mass. As we discussed, the anterior band is just under that, and then he drilled holes, like 3 holes in the humerus, 3 holes in the olecranon, the proximal ulna. You know, like these are tiny bones. He drilled big holes and then used the graft and sutured it. That's how he did it. But now, obviously, after that, that was in the 70s, before any of you was born, except the first row. Then we got the modified Job reconstruction, where instead of basically you detaching, you split. The most anterior tendon there is flexor carpi ulnaris. You split the carpi ulnaris, saw the underlying ligament, treated the ligament, put in a graft, and then again, the same tunnels were made. Now, when you're doing this, your ulnar nerve is there in close proximity, and as we discussed, ulnar nerve can have ulnar neuritis, and also when you're drilling through the humerus and the proximal ulna, there's a high chance you will damage the nerve. So that was another reason they transposed the nerve. Now, Job, he actually transposed the nerve submuscularly, and subsequently, what the surgeons did, they started transposing the nerve, as you must have seen in your practice, in the subcutaneous thing. They did not do it submuscularly. Now, the docking technique, so in this, there were big holes made, a lot of bone. It took a lot of time for rehab. Docking technique was, we just tried to be a little bit less brutal, a single tunnel, and then sutures were tied over the bone. So this is the modified Job technique. You have the ulnar nerve, big tunnels were made. Then in the docking technique, instead of drilling big holes, you had tiny holes and you had sutures onto the ligament and then over the bone bridge. So again, the damage to the bone was less. And I'll just have 2 more slides. And it was less, the return to play was better. And again, you can repair. Now if you want to repair, you basically just suture it with a collagen-coated tape. And obviously, this is earliest recovery because you're not really doing much. But for this, you should have a good quality tendon, a partial thickness tear. You should not have a mid-substance tear. So you need some scaffold so that you can repair it, right? If a tendon is friable, you can't repair. So these are the 3 techniques. Just quickly showing these imaging. Again, just one thing. When you are looking at ligaments, tendon reconstruction, ligament reconstruction, always, they are very difficult to see on static images. Always follow them. It's impossible to show. That's why I had to put these videos. I cannot show you one image. You have to follow. So look at the tunnels, and then you have this low signal intensity medial collateral ligament or the ulnar collateral ligament, which is attaching. You can see this avulsed sublime tubercle. Similarly, on the axial images, you have big tunnels. You can see these tunnels in the distal humerus. Then you see the ligament. And in the next one, I can just quickly show you. Now, this one was more conservative, right? You don't see big tunnels. See, just one tunnel in the humerus rather than a lot of tunnels. See that tunnel coming out, that intermediate signal ligament because it was recent, and then attaching to the olecranon. And on the axial images, just one quick note. See where the ulnar nerve is. Can you guys follow the ulnar nerve? Yeah, perfect. And then you make a fascial sling, bring it to the subcutaneous plane. Where is it? It's out. It's not in the cubital tunnel. And then go follow. You see that tunnel in the humerus, and then it comes distally and comes there. Yeah, so always follow your ligaments. Look at the tunnels, look at the graft signal, look at the interface, any disruption, always follow them always basically follow them on consecutive images. Always look at the ulnar nerve, look at the signal of the ulnar nerve. Obviously, you'll have some artifacts and stuff, and you can correlate with valgus stress radiographs. I'll be honest, I've never done that. Thank you so much. Sorry for overrunning.
Thank you, ma'am. I think her lecture shows the passion and dedication of the work she has been doing, and we are lucky that she has shared her experience with us. Have you ever wondered about the different anatomical parts of the elbow? Something is like capitulum and medial epicondyle and lateral epicondyle. Why olecranon? What do you mean by olecranon? Does it sound something out of the place word? Anybody? So, whenever you can't answer, you should always go to Greek and Latin. Olecranon in Greek and Latin means head, top, vertex. So what is the head of elbow? The head of elbow is olecranon. That is how the name is come.
Thank you.
I'd like to call our next speaker, Dr. Bhanupriya Singh. She is Assistant Professor in Dr. Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And she will be talking on an interesting and important topic, that is carpal instability uncovered, critical anatomical insight for imaging.
Good morning, everybody. And let's start. First of all, I'd like to thank the organizers and the senior committee. And let's start with the topic of carpal instability. So while approaching a case, that doesn't happen, the instability doesn't happen in isolation. So we do have to take care of the whole wrist joint in toto. So we have to take care of the osseous structures, the articular surface and the joint capsule, tendons, the TFCC complex, the ligaments, and then evaluate for the instabilities and the also in the background we have to evaluate or keep in mind that the pathology can be in a little proximity and not really at the wrist, that is at the collateral ligament at first MCP, and also the carpal tunnel can the entrapment syndromes and in carpal tunnel or Guyon's canal. So the wrist joint space is composed of the distal radio-ulnar joint space, the radio-carpal joint space, the mid-carpal joint space, and the carpo-metacarpal joint space, right? And this on X-ray is evaluated by what we know as Gillia's arcs. So there are 3 arcs. So the proximal arc is formed by the convexity of scaphoid, lunate, and triquetral bone. The middle arc is formed by the concavities of the same above bones, and the distal arc is formed by the convexity of capitate and hamate bone. And if they are like this, X-ray shows a disruption of the arcs, and there's proximal migration of capitate. So the osseous structures, the adjacent articular cartilage and the alignment on coronal and sagittal is best evaluated. And then the alignment, so the alignment includes the orientation between the distal radius, the lunate, the capitate and scaphoid, and the carpometacarpal. Then again this basically helps us narrow down about the angulation deformities and the status of the distal radio-ulnar joint, the radiocarpal compartment, and we also, while evaluating, have to look for the common causes that cause instability. That includes fractures, most commonly of the scaphoid or the distal radius, and the avians of scaphoid or lunate. So this case again shows the kind of displaced fracture of scaphoid with subsequent avian of the scaphoid bone. And the reason is well known, that it has a retrograde supply. So most common trauma at the waist causes avian of the tip. Now variance. So variance is basically the orientation of the articular surface of radius with the convex head of ulna, and they are to be at the same level. And they can be plus minus up to 3 mm. If it's more than 3 mm, it's pathological, and if the ulna falls short, then it's negative ulnar variance. If the ulna protrudes further, then it's positive ulnar variance. So as expected, so lunate forms the center of these arcs that we discussed, and also the center of the biomechanical forces that are transmitted, and it has blood supply through end arteries. So when there's negative ulnar variance, the pressure dynamic is such that it compromises the blood supply here, and is generally related with avian of the lunate. When there's positive ulnar variance, so this is where the TFCC would be, right? So with positive ulnar variance, the TFCC would be damaged, and the ulna would literally abut the lunate and the triquetrum. So abutment syndromes are associated with it. Now this case shows the avian of the lunate, and with negative ulnar variants, like we just discussed. Now, positive ulnar variants with ulnar abutment, and we are also seeing some component of chondromalacia, in the lunate bone, right? And it's a painful condition, and the associations are malunited fracture of radius. Now we know the in anatomical aspect, the 6 dorsal tendon compartments and the volar tendon compartments, and you should trace if any pathology is expected there. Coming on to TFCC. So, a triangular fabulocartilage complex is the primary stabilizer of the distal radio-ulnar joint, and it's critical in weight bearing on the ulnar side of the wrist. And so coming on to its anatomy, so it has got a central component and a peripheral component. The central component is the TFCC disc proper, the ligaments between the radius and the ulna, so the dorsal and the volar radio-ulnar ligaments. Now, TFCC is much like a trampoline suspended on all the sides from attachment, and it's like this thick sheet, right? So laterally it is attaching by what is called as triangular ligament to the ulna. So this is styloid. So it has a styloid component, a foveal component, and between this is some amount of normal fat, and it is named as ligamentum subcruatum. Now there's laterally goes the ECU tendon, and ECU tendon sheath provides stability to the TFCC, and it is a component of TFCC. Now below the ECU tendon sheath there is capsular thickening, capsular thickening, and it is named as ulnar collateral ligament. Just adjacent to ulnar collateral ligament is a thick hypointense structure just like meniscus, and it's called meniscal homologue. And just like medial meniscus, actually this is fused. So these components, the meniscal homologue, ulnar collateral ligament, and ECU tendon sheath are tightly fused with the ulnar styloid and the triquetrum. Now the last component is the ulno-lunate and ulno-triquetral ligament. So we can see as the name suggests, from ulnar to lunate and triquetrum, but appreciate that actually they originate from the volar aspect of distal radio-ulnar ligament. So this ligament originates from ligament and attaches to a bone. So this image shows it better, that actually ulno-lunate and ulno-triquetral ligament arise from the volar distal radio-ulnar ligament and goes on to the bone. So this shows normal anatomy. So this so meniscal homologue, the some amount of sprain is there. So the disc proper, the styloid and the foveal attachment. Now this is lunotriquetral and scapholunate ligament. So this is not part of TFCC. And then this is the dorsal and volar radio-ulnar ligament. Now, so again, appreciate that the volar and dorsal component of radio-ulnar ligament and the central disc proper attaches directly to the radius, directly on the bone, and this is normal appearance. This is the radial articular cartilage. So it is not a recess, it is not a tear, it is actually the cartilage itself. Now, any tear is classified on Palmer classification of TFCC, and it goes like, so it can be traumatic or degenerative. Now, traumatic is basically it can have a central perforation, it can avulse from the radial end, from the distal end of the ulno-lunate or ulno-triquetral ligament, from the radial end, it can have a central perforation, or there can be a potential opening up of this space which is fused normally. So that is traumatic. Degenerative can be just TFCC wear and tear, so thinning, diffuse thinning you see. If that thinning is associated with ulnar or lunate chondromalacia, then more severe is TFCC frank perforation with the chondromalacia, then adds up to it is ligament perforation, and last is ulnocarpal arthritis sets in. So the central part of the disc We divide it into two because the treatment varies. So central part of the disc is avascular zone, and any frank injury there needs surgical repair and will not heal on its own, compared to peripheral part, which has good vascularity and is generally managed conservatively if not very severe. So this shows central tear, central degeneration in the TFCC complex, and here again we are seeing a central tear. So now this is a combined image. So ulno-lunate, ulno-triquetral, chondromalacia component of arthritis has set in, and there's a diffuse tear in the central as well as the peripheral portion. In this, we are only seeing the peripheral tear and some amount of sprain in the triangular ligament. Now, here we are seeing partial tear. So if the tear is complete or partial, and if it's partial, then it's along which surface, right? So it's along the articular surface. Now coming on to wrist ligaments. So there are intrinsic ligaments as well as extrinsic ligaments. Now extrinsic ligaments they have a complex anatomy and are named depending on the bones they connect, and generally they don't have, we are not supposed to report these but know them for normal anatomy. The intercarpal or the intrinsic ligaments is what is important to us. So the most important being scapholunate and lunotriquetral ligament in the carpal stability. So these both ligaments are like a sling. So they have a dorsal surface, a proximal portion, and a volar surface. So scapholunate, the dorsal component of the ligament is thicker. So this diagram shows it better, that the dorsal component of scapholunate is thicker. Then there is an intermediate surface, and then the volar surface. And the lunotriquetral, it's opposite. So the dorsal is thinner and the volar is thicker. And so this is how scapholunate, the dorsal is thicker, volar is thinner. So the normal scapholunate joint space is approximately 2 mm, and any widening can be further demonstrated with clenched fist view, and that increases. So this is the MRI showing the same, and this shows scapholunate again ligament, and it not only varies in thickness but also in shape. So you should not quickly call it tear but trace it. And then so here we are seeing the same ligaments in 3D orientation, and any laxity of it causes rotational instability of the carpal bones, and the most common being DISI and VISI. So the normal scapholunate angle is approximately 30 to 60, and the normal capitolunate is less than 30. So there's that's how you measure. So between so a vertical through the center of the lunate, and the vertical and a long axis through scaphoid. So it gives this angle. And in dorsal angulated, in instability where the lunate is dorsally angulated, the scapholunate angle becomes more than 70, and ulnocapitate angle becomes more than 30. So and the and it's nearly always associated with scapholunate ligament tear, which will be more than 3 mm. So this image shows, I think I'm a little short on time, so we'll be a little quicker. And then the next ligament is the lunotriquetral ligament, so which is opposite, so which is thicker on the volar aspect and thinner on the dorsal aspect. And any tear in this again is associated with VISI and TFCC tear. So here we are seeing the ulnolulate and ulnotriquetral are also commonly torn with the lunotriquetral ligament tear. So this is an axial image. Appreciate both the ligaments with their volar and the dorsal components. And now coming to VISI. So in VISI, the scapholunate angle becomes more, but the capitolunate angle decreases. And what it leads to is that this is capitate. So the capitate has a proximal migration. This joint space is opening up, so between lunate and triquetrum. So this ligament becomes lax, and thus capitate migrates proximally, and what it is called is scapholunate, basically it arthritis complex. So this is lunotriquetral ligament, and so scaphotrapeziotrapezoid ligament here is also also tone. We see some wavy ligament and instability, and here we are seeing a lunotriquetral ligament is tone, retracted, and we are seeing it's this, and there's a visci deformity. That now what it leads to is scapholunate advanced collapse that we just discussed, and there's reactionary or sequential arthritis that sets in the ligament. Now briefly on the types of instability, the carpal instability dissociative is when the instability occurs between the carpal bones in the same row. So here the carpal row is becoming dissociative. CIND or carpal instability non-dissociative. So here the instability is between the proximal or the middle row, or between the forearm bones and the proximal row, but the row itself remains intact. Now, mid-carpal instability is a sub-form of carpal instability dissociative. So, where the dissociation is between the proximal row and the mid row, which forms the mid-carpal joint space also. Carpal instability complex combined is when there is an overlap and both the features are present. And so apart from Gillia's arcs, so lunate forms the center of these biomechanical forces, and this is the trajectory through which any instability of lunate will alter the weight bearing along both the forearm bones, and the representative arcs can be sequentially damaged, like shown in this image. Now, carpal instability adaptive is also a common condition. So where the main pathology is not in the ligaments itself, but it's a sequelae to trauma, most likely. So there's a extrinsic, pathology, and the ligaments adjust themselves to the altered biomechanics, and as a result, there is instability among them. So, so this is the chart stating all. Now, scan or scaphoid non-union advanced collapse. So when it goes like we discussed, the avian progresses and it doesn't fuse, and there's a opening up of this space, and capitate undergoes yes. So these are the so this is the checklist, and these are the articles. Thank you.
Thank you for the comprehensive talk, Dr. Bhanupriya. So I just have a quick tip for the residents. Whenever you are assessing the case of carpal instability, look at the lateral radiograph or the mid-sagittal CT or MR section. You have to see for the three bones. I remember by the mnemonic CLR, capitate, lunate, and radius. They should be in the same line. If the lunate is tilted in a volar direction, it is BC, and if it is tilted in dorsal direction, then it is BC. Because in practical setting, it's impossible to measure these angles routinely, and we don't remember them. So this is a quick tip. Thank you.
Thank you, ma'am.
Now I would like to introduce Dr. Dharmendra Kumar Singh. He's an MSc radiologist from UK.
Not from UK, from India, ma'am. I'm from India, ma'am.
Oh, now it's India. Sorry.
Yes, ma'am.
And he's delivering a lecture on acute finger soft tissue injuries, a conceptual image approach.
Yeah. Thank you, ma'am, for kind introduction. Good morning, everyone. Coming to the straightforward to the topic. Okay, this is acute finger injury. I have no conflict of interest, nothing to disclose. The learning objective of my talk is the pattern of injury and multimodality imaging, and what are the management implications. The purpose of any radiologist is that the patient is getting the treatment or not, and that's the important. Whatever hyper you write, if it implicated to the patient's treatment, if your language is communicated to the surgeon, that only matters. So coming to the anatomy, we have developed from, not from dinosaur, we have developed from apes. So yeah, so our thumb is perpendicular on the perpendicular plane to the finger. So have you noticed, when you are taking the coronal section of the finger, you land up onto the sagittal section of the thumb. When you are taking the sagittal section of the finger, you land up into the coronal section of thumb, because the thumb is perpendicular to the finger. And why this matter, I will explain to you. Coming to the finger, basic anatomy recap. Okay, the new terminology, I will tell you what the surgeons tell. Okay, first, this tendon, this is called axial tendon. This axial tendon is flexor digitorum profundus, which starts from carpal tunnel, not starts from carpal tunnel means I'm tracing from carpal tunnel, and it follows, it is in the midline, it follows the curvature of the bone and attaches to the volar aspect of the proximal tip of the distal phalanx. Above this one, the flexor digitorum superficialis, so it is superficial, but here it divides, and it divides because it has to attach to the mid phalanx, and here is the chiasma formation that is called camper's chiasm. And you know, some surgeons know this camper's chiasm. So if you write in report at the camper's chiasm lesion, that's very useful for the surgeon. And you have noticed this point means the mid part of the proximal phalanx, we call it a ring point, not ring finger, ring point, where you put the ring, all the things in the finger divides at that point. Okay, so and at a joint level, to decrease the friction between the bone and the tendon, the god has given volar plates, and to keep the things in a tight compartment, we have the multiple pulley's. The easy to remember at the joint level, A1, A3 and A5, and non-joint level it is A2 and A4 pulley. So this is the basic structure you can see in the MRI. You can correlate this with MRI. Here it is not compartmentalized, here it is not compacted, so you can see the two tendons, but here it is compartmentalized, it is compressed, so it appears like a one tendon, but it's basically flexor digitorum superficialis and profundus. And when you go proximal, when you go distally, you can see here the attachment of the flexor digitorum superficialis here and flexor digitorum profundus continuing. And the similar things can be seen in the panoramic view with the ultrasound also. So the three things we have to remember in the flexor aspect: flexor tendon, volar plate and pulley. There is a zonal division also the surgeon wants to know, because it has a surgical implications. The zone 1 means only FDP injury. When the FDP is only injured, means at the site of, from the attachment of the FDP up to the site of attachment of the FDS. If this part is injured, this is zone 1. And why it is called important? Why? Because if you are telling that the patient has a zone 1 injury, surgeons are very happy, because the prognosis of the surgery, prognosis of the repair is very good. If you are telling that zone 2, so zone 2 is the no man's land in the 80s, I think sir must be remembering 80, which 80s sir. So you know, in zone 2, from the attachment of the FDS up to the A1 pulley, all things are compacted, so no surgeon wants to repair. And you know, if the patient comes to the surgeon explains, look, I am going to repair, but there are the high chances of adhesions. So that's why this is called no man's land, because no surgeon is happy to repair that one. Zone 3, here the tendons are free tendons, so no retinaculum here, but obviously there is the superficial and deep palmar arches, so more prone for the neurovascular bundle injury. And zone 4 is the carpal tunnel, obviously it's prone for the adhesion. If you see the axial anatomy, I'm going in the detail. I'm comparing the ultrasound with MRI also. Why? Because now we have to graduate from the imaging finding to the diagnosis. So everything should be multimodality. Like here, you can see the flexor digitorum superficialis, the profundus in the MRI and ultrasound. And here, here, can you see here? The superficial parts of the digitorum superficialis and profundus. Has the flexor FDS has divided or not? How to know that one? You trace the ventral surface. If it is smooth, the FDS is not divided. If you are finding a small cleft, that means FDS have divided. And you can correlate this with on ultrasound also. This the two FDS and FDP in between. When you go distally, you are finding the FDS is going side because it has to attach to the middle phalanx. So in the ultrasound, similarly you can see, and on the MRI, in the where here the site of attachment of the FDS and FDP in the midline, and in the distal part here only FDP at the zone 1, and this is the thing. So now, after this brief time, I'm very scared that I have to talk in the 5 minutes. I have so many slides, ma'am. I don't know how to do. Let's see, ma'am. Case 1, a 27-year-old basketball player, injury of the index finger. What we are finding? Yes, the FDS has evolved from FDP has evolved from here, and it is retracted up to the PIP level. No. The surgeon wants to know, don't want the PIP level. They wants to know the Poulet level. This FDP has retracted and is retracted up to the A3 Poulet level, because this Poulet holds, this Poulet does not allow this tendon, this tendon to retract. What about the FDS? In the parasagittal section, you are finding the one ulnar slip and radial slips are normal. Fine. So the two things the surgeon wants to know. This is zone 1 injury. Surgeon is very happy. FDP rupture and it is retracted up to the A3 level and FDS is intact. So this is called jersey finger or baseball finger. Another player I know this person with the avulsion injury, and here you are able to see the same retraction of the FDP up to the A3 pulley level. And because of the edema, we cannot make out the FDS is normal or not. So take the help of the ultrasound, because you are not the person with the imaging. You have to give the diagnosis to the patient, because you know this is the gold standard. Means you cannot do the biopsy to prove this one, this is tear not. Everyone knows that it's tear. So you have to take the help of ultrasound, and you know how to do the ultrasound of the finger, because in the many centers, in high volume centers like us, the ultrasound is one of the ultrasound is now considered one of the gold standard for finger injury. So on ultrasound, yes, you can see the FDS on the side, here the FDS, and it is nicely seeing on the sides, and it is attaching to the distally. So you can see the same findings, the FDP avulsion fracture with the reduction of the A3 pulley level, and this is the jersey finger. Why it is called jersey finger? Not because the color of the jersey, not because the jersey are good, no, because of this phenomenon. When the player entangle his finger in the jersey, and this jersey is not made of cotton, this jersey is made of a lycra, okay, so it stretches the pull and push mechanism, and that's why there is the FDP tear. And why it's important to write in the terms of retraction in the terms of the pulley, because the surgeons follow this Lady Packer classification. Easy to remember. If the tendon is retracted up to the A1 pulley, means the repair should be done within 1 week. If it is retracted up to the A3 pulley, means repair should be done within 3 weeks. If the tendon is retracted up to the A5 pulley, the repair should be done within the 5 weeks. And why? Because this tendon also needs the blood supply, and there is a small structures that are called vinculi, okay, and these vinculi are not visible to me on MRI, but some persons I know have microscope in their eye, they can see the vinculi on the MRI also. Fine. So if suppose if the whole tendon is retracted of the A1 pulley level, means all vinculi have been torn, so there are high chances of tendon degeneration. If the tendon is retracted of the A3 pulley, means these two vinculi are still attached, so vascular supply is maintained. We can wait up to the 3 weeks, and if it is retracted of the 5 pulley, you can tell the patient go home, apply cast. When the edema will reduce, come after 5 to 6 weeks, take the appointment, stand in queue in the government hospital, then we will do the surgery. Similarly, the 17-year female having chronic pain in the little finger, FDP is intact. FDS, yes, on FDS on parasagittal section it appears normal, but in axial section we will find a small hyperintensity in the ulnar aspect of the FDS. So isolated chronic tear of ulnar slip of FDS, very rare. In the last 8 years we have seen the first case which have the isolated FDS injury. So what are the points to remember in the flexor tendon? FDP is axial, means it always remain in the midline and opposed to bone. FDP is best evaluated in the sagittal MRI or longitudinal ultrasound. FDS is best evaluated on the axial plane. Torn FDP retraction must be reported up to the pulley level, because the surgeons wants to know the Lady Packer classification. The zone 1 and zone 2 injury must be differentiated. Why? Because then surgeon will communicate to the patient what will be the prognosis. Coming to the volar plate, it's only 5 minutes, I don't know what will happen. Okay, volar plate, so fine. So here the volar plate is covering this joint, and this volar plate attached to the accessory ligaments also, and this collateral ligament 40%. Why I will tell this, why this is 40% important, because this volar plate is called the eyelid of the joint. Why it is called eyelid? Have you seen your eyelid? You see your eyelid, not the जो तुम्हारे बगल में बैठा हुआ उसका मत देखो. You see your eyelid. Fine. If you see the eyelid has a broad structure. Fine. It is attached to the skin, but the lower part has the eyelashes. The similar is the structure of the volar plate. Okay, volar plate distally attached to the bone, but proximally it has the eyelashes, and that is called the chacrine ligaments. So If you see here, at the MCP level, at the PIP level, and the DIP level, you are finding the volar plate, and on the ultrasound it's nicely visible. Also, one thing to very important is that if you see here the volar plate, there is the under surface cutting of the volar plate. This is quite normal. If this under surface is reaching up to the surface or it is full thickness, then only it is called the volar plate injury. Like in this case here, 17-year female injury in the index finger here, and the surgeons calls it this is volar plate injury. So why you need MRI? Okay, fine. In MRI you can confirm. On the ultrasound, you can say here this is the contralateral normal part. Here the cleft is present up to here, but here it has it is a full thickness. That's why it's a volar plate injury. And this volar plate injury is also called the jammed finger. The avulsion tear of the distal volar plate less than 40% articular surface. Even even in a BG in a BG OPD, a sports surgeon see the X-ray and he tells, look, you have this volar plate injury. So why you need MRI? Yes, what you expect from MRI? MRI also wrote in, yes, there is that there is the turn of the, they want to know what amount of the articular surface is involved. So by X-ray only, yes, you can tell what amount. If you cross this is 50%, they less than 40%, and you must try it even in the X-ray because this is important. What is the clinical importance? I will show. They follow the item classification, means this 40% surface, if the 40%, if the avulsion fracture is more than 40%, means this collateral ligament is damaged. Once this collateral ligament is damaged, it is surgically repaired. Rest else, whatever the tear of the volar plate, even the dislocation of the joint, if the avulsion fracture is less than 40%, the surgeon is not going to repair. So this is the item classification, item 1, 2, 3A and 3B. So what is important to know? Once the avulsion fracture is more than 40% in case of volar plate, then the surgeon repairs. Otherwise, this is a simple volar plate injury. So coming to the pulley, yes, I think everyone knows about the pulley, so I don't know I to continue or not. Fine. So A1, A3 and A5 pulley, A2 and A4 at the non-joint level, and on MRI, yes, can you see? Yes, you can see at the small levels, or you can see. No, look, I can see this volar plate, I can see this pulley, but for me it's not visible. So how to see this volar plate? The volar plate is best seen in the axial plane. If the slips are visible on the axial plane, the ulnar or radial slips are visible on the ulnar on the axial plane. So A3, A1, A3 and A5 pulley are located at the joints and insert on the MCP, PIP, DIP volar plates respectively. That's why the volar plates at the joints are less prone to injury, and if it occurs at the joint level, it occurs with the volar plate injury associated with the volar plate. The A2 and A4 pulley are non-joint at the non-joint level and considered the most important biomechanically. Why? I will show you. 32-year female injury of the ring finger while lifting heavy object. What you are finding? Yes, rule 1, axial, the axial tendon, the flexor digitorum profundus is in the midline and follows the curvature of the bone. But here it is lifted from the bone, and on axial section you can find the tear of the pulley. On ultrasound, yes, you can see also. So how to know? This is called bowstringing. Okay, you all know bowstringing or read from the Google what is called bowstringing. So direct signs of the pulley rupture are not always apparent on MRI or ultrasound. Flexor tendon displacement of the bone greater than 2 mm is indicative of pulley injury, and A2 pulley injury is the most common injury. This is called climber's finger, because if you see the climbers, they hold the rock and they put the all body weight onto the fingers. The most important pulley that is under the stress is the A2 pulley. That's why the A2 pulley rupture is the most common, and that's called the climber's finger. The similar one, this person have a flexion deformity, and on dynamic ultrasound also you can see it is fixed, it is displaced, and because here we are finding the bowstringing, and the pulley this pulley rupture is at the A3 level or joint level, so the volar plate has also disrupted. So the two things too important to remember: if the pulley rupture is at the A2 level, that is most common pulley, and if the pulley occurs at the joint level, because the pulley attaches to the volar plate injury is also important. So these are the points to remember. Sir, should I continue or stop, sir? Time up. Okay. Thank you, sir. Thank you so much, sir. Thank you, sir. So, point is to, sir has given me the order, so I will continue. Fine. So, most common site of pulley rupture is the A2. Complete A2 pulley causes the bowstringing. The partial pulley does not cause the bowstringing. Look at this case here. There is no displacement. But if you see, the patient has a persistent pain. But if you see the MRI, okay, one side of the pulley is ruptured, one side not ruptured. So the bowstringing sign is the sign of complete pulley rupture, not the partial pulley rupture. If the partial pulley rupture, yes, you may miss first time on the sagittal section, but look at carefully in the axial sections. Coming to the dorsal aspect or extensor, this is one of the very tricky. But if you are working with a hand surgeon, they know all thing about the flexor, but on an extensor they depend upon you, and very small structures to see in ultrasound and MRI, and best to correlate this MRI with ultrasound. And how I will show you the simplified anatomy. Fine. Here the tendon goes, the extensor tendon, and it trifurcates at which level? Ring point, not ring finger. Ring point means mid part of the proximal phalanx is called ring point. I searched in the Google why the person, when a person proposes to anyone or marries to anyone, put the ring in the finger. I got the answer on a chat GPT, sir. Because this is called the ring point. This is a very important point. That's why, and then we realized, oh, that's why all tendons divides at the ring point. Okay, so the flexor tendon also divides at the ring point. The extensor tendon also divides at the ring point. So here it trifurcates. Here it trifurcates. Okay, the central part continues at the central slip, and it attaches to the mid phalanx, and the peripheral part, that lateral slips, that again become joined and attached to the terminal phalanx. Because it has been trifurcated, all the three tendons become very weak tendons. So God is very kind. So he has given the two supports, and that is called the lateral bands. And what is the lateral bands? These lateral bands join a hood like a structure, and that is called the extensor hood. And this extensor hood contains in the central part the central slip, and the lateral part it supports the lateral slips. And so, have you checked your extensor tendon? You can see the extensor tendon. If you bend this one, the extensor tendon have a natural tendency to partially subluxate towards the radial side. So I can okay, you can see in my hand I can see. I don't know about the other's hand, but you fine. So it has a tendency. It has tendency to subluxate. So what they have given? They have given the sagittal band, and this sagittal band tries to contain this extensor tendon in the midline, and this does only one thing also. Up to here you are able to see your extensor tendon in hand, but beyond that one you are not able to see your extensor tendon in the hand. So after the sagittal band converts this round extensor tendon into the flat extensor tendon, because why? I will show you in the MRI. So here on MRI, yes, the central slip attaches to the distal phalanx, and the terminal slip attaches to the terminal phalanx. In thin coronal sections, you are finding the two lateral slips also. You can see the ultrasound also. This ultrasound image is not okay, because I have taken the panoramic view, so it is not good, but in ultrasound it is very nicely seen. So what are the structures we have to see? Extensor tendon at the sagittal band, extensor hood, central slip, ulnar radial slips, and terminal slips. If you see the anatomy on the MRI and ultrasound here, okay, here, yeah, extensor tendon, when the extensor tendon is seen as a round, it is called extensor communis tendon. If you see at the sagittal band, you are finding the sagittal band vestibular hyper. At the extensor hood level, you are finding a hood-like structure in the MRI and the ultrasound also. And if you are finding the prominent digital artery, this appears like a open puppy sign. Okay, here you can see the eyes of the puppy, the nose of the puppy, and the open mouth of the puppy. So it appears on the ultrasound, and this is the extensor hood. And what it contains? In the lateral part, it contains lateral slip. In the central part, it contains the central slip. If you go more distally, yes, you are finding here the attachment of the central slip and the lateral slip on the either sides. Here, if you go above, you are finding here the two slips, that is the two lateral slips, and so on. So coming to the cases, a 29-year male having injury with the index finger while playing. Yes, sir. Yes, sir. I can understand. Yes. So, even in the dynamic ultrasound, it's better to see, there is the avulsion of the terminal tendon, avulsion of terminal tendon, and this is mallet finger. But what is important? The surgeon know this is mallet finger. They want to know what percentage of the bone surface is involved, and MRI is seldom needed in our institute to diagnose this mallet finger. The radiographs and dynamic ultrasound is more than sufficient. More than 30% surface involved, they require the surgery. Similar is here the center slipped here on the dynamic ultrasound also. Yes, you are finding uh, you're finding, yes, there's a tear and no excursion present on the MRI also. Here you can see. I want to show you this figure, like you can see here specifically, because at the hood level the central slip is torn, but you can see the lateral slips are intact. So this causes the botanist deformity. I am not going in the thumb, so I have a long list, sir, but I will conclude. Sir, 25 seconds. Okay. Okay, fine, sir. So, oh, sir, but, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Thank you, sir. Thank you, sir. Yeah, thank you, sir. Thank you, sir. Yeah, thank you, sir.
What is the meaning of word profundus?
Dr. Raj, do you know, what it means of profundus?
So I think we need to learn certain basic things rather than all these things. Which is the other muscle? It was excellent lecture. Once again, we clap for him. Our next speaker is Dr. Sandeep. He will be speaking on bone marrow. Dr. Sandeep has, his institute is not mentioned, but he has a Manipal student and he will be talking on the marrow part of it.
Yeah. Good morning, everyone. My topic is bone marrow edema syndrome surrounding the hip joint. So the scope of the talk is, first I would be going through the avascular necrosis, which is the half of the component. But the idea of the talk is to cover other bone marrow edema syndromes and how to differentiate from the avian. At the end, I'm including some pediatric disorders which has some clue through the bone marrow edema. So what are the sequences do you take for the hip joint normally? So T1, T2, coronal, axial, it can be customized according to your needs. Axial is less commonly taken. Axial, for this bone marrow edema, you don't need any axial obliques. When you find that the disease is unilateral, in the first screening, your two sequences, you can confine to the one joint with small field of view 16 into 16 centimeters, so that you can see the small structures, labrum and subchondral fracture very well. So let's start with the first half, avascular necrosis. It can be caused by traumatic and non-traumatic causes. Unlike brain infarct, which manifests within 4 minutes or 5 minutes, the bone infarct doesn't present by itself. Patient doesn't know that he had infarct today. After few weeks of the infarct, the healing process is the symptomatic one. So usually it is on the weight-bearing side. Anterior and superior is classical. Adjacent edema is important surrogate marker for the pain and risk of the collapse. So you need to mention the edema in the impression also. The lesion is usually geographic, like a map-like with serpentine border. Double line sign is very pathognomonic for avascular necrosis, usually in the anterior and superior. If you see edema in the inferior half and posterior half, think other than the avian. So this is checklist. You can take a screenshot. You first need to confirm avian or not. Look for all the clues. Next, you need to stage whatever the staging you are familiar and popular with the orthopedicians. Mention always the degree of percentage of involvement, either in the findings and the impression. Mention the location, which gives clue to diagnosis. Mention the status of the joint, which is necessary for the treatment planning. And edema, how bad it is, you need to mention. Always see opposite side of the joints, opposite joint as well as opposite side of the joint. Both sides you need to mention. Look for the etiology, what is exactly causing AVN. You need to look for whether it is just idiopathic or steroids or any marrow disorder which is leading to this one. So there are 6-7 classifications are there. This is modified Fickert-Arlett, everybody is following. Initially it was developed for the X-ray, later included MRI, that's why it's modified. Stage 0, there won't be any radiographic changes, only biopsy can reveal. First stage 1 is edema or small geographic lesion, that will convert into the geographic lesion with edema beyond the core. The third is collapse. Second to third differentiation is something clinician always insists us. Subchondral fracture and other things will come and collapse. Osteoarthrosis, fourth stage. So this is stage 1. It can be just edema, or it can be very well defined small lesion like this subarticularly. So some people believe that the edema is the one which is first thing which appears and later converts to the AVN like this, but there is no concrete evidence to say that it's still a controversial topic. And stage 2, what you see is classical double line, some core, obvious core showing various signals, and a marrow edema surrounding it. Double line sign is outside sclerotic inside granulation tissue, which is very pathognomonic. You need to see the head collapse in the sagittal preferably. Subchondral collapse you need to see. Slight alteration of the spherical shape also leads to stage 3. This is frank collapse, stage 3. Here you can see sclerosis as well as frank collapse. The last is secondary osteoarthrosis after long-term AVN. So this bilateral, second, it's early stage on the right side, advanced stage on the left side. So this is only surgical treatment available. So we have written an article in IJMSR, open source, heavily downloaded. You just go through that. Comprehensively, we have included everything about AVN classification, merits and demerits of each classification system. Next is mutual classification. When I was student, it was very popular. Gradually it is faded because there can be overlap of A and B, A and C, and it doesn't directly incorporate into your treatment planning. So let us see, because it's a marrow lecture, so let us see the changes. T1 bright, T2 bright, fat sat suppressed, it is fat. It's a stage A, which is considered to be one of the good one. So second one is T1 bright, T2 bright. Even if you take fats at T1, it would remain some part of it is bright, then it is blood. Usually we don't incorporate the T1 fats at, this is supposed to be. The C is edema, granulation tissue, whatever T1 hypointense and fluid sensitive sequences, it is hyperintense. The D is either fibrous tissue, hypointense on both T1 and T2, sclerosis, fibrous tissue whatsoever. So next important point is mentioned about the joint effusion and marrow edema. Sometimes it is just, there is no edema, there is edema up to the neck, edema up to the trochanteric region as well. This directly proportionate to the degree of the patient's symptoms. And also this is an indicator for rapid conversion towards stage 3, and this is also indicator for the treatment response, whatever treatment given. Any diagnosis, bilateral AVN, always search for the cause. Don't stop at the hip joint level. Look around. Marrow signal, always observe and mention. Sclerosis, heterogeneous sclerosis, and avascular necrosis. Marrow is diffusely hypointense, but not as bad as adjacent muscle. Always T1 signal has to be compared with the adjacent muscle, isointense, hypointense, and you need to mention. Gross hypointensity is abnormal sign. Multiple medullary infarct, same patient, H-shaped vertebra, small spleen. Yeah, all the clues. So you can diagnose everything here. So edema assessment doesn't stop with the pre-treatment. Post-treatment also, this patient has undergone core decompression. After 1 year of core decompression, there is a significant decrease in the symptoms, and there is a decrease in the marrow edema. So we finished with AVN. We are proceeding with other bone marrow edema syndromes which are very close to the AVN. So transient osteoporosis of the hip joint, this is relatively old term. It's nothing but bone marrow edema. There won't be any fracture line. First you take after first X-ray will be normal. After 6 weeks, significant osteoporosis. And if you take after 4 months, again there will be normal porosis, 8 to 10 weeks. Stress fracture, this is SIF, popularly subchondral insufficiency fracture, associated with elderly, osteoporotic, diabetic, and renal failure patients. Commonly you see there is a discrete hypointense line. When you have directly, you can write stress fracture or subchondral insufficiency fracture. Look for other fracture sites and stress fracture related areas. Transient bone marrow edema, there is no fracture line. When there is, this is same as a transient osteoporosis. It can be seen in simultaneously at other joints also. It can be synchronously or metachronously. This all will resolve within 8 weeks. So do you find any difference between this, all these entities? There are more or less same. All are stress response. What you see morphologically depends upon your modality. When at what time you are seeing, that depends upon your follow-up. You label it differently. We used to struggle a lot to differentiate one condition to another condition earlier days in the past decade, but it's all same stress response. For all these, MRI is modality of choice. Go for a fluid sensitive sequence. T1 is less sensitive, but T1 dirty, extremely dark signal should make suspicion of any infiltrative pathology, just not simple AVN. So use Dixon in phase and out of the phase. More than 20% drop of the signal is good marrow. In opposite phase, it indicates benign lesion. Less than 20% is concerning for the malignancy. If the more normal marrow is preserved, there will be more signal drop. So dual energy CT, I don't have a personal experience. I will show one image later. Has a very good diagnostic accuracy now for bone marrow edema, though it is difficulties to characterize, again, just like MRI. All these conditions other than AVN will involve only weight-bearing joints. AVN can come in the shoulder also, but not this stress fracture. Middle and old-aged men, pregnant, postpartum female, osteoporotic, these are the popular clinical groups. All are subchondral predominance edema and ill-defined margin. You cannot define very well. It all resolves in the follow-up. In case of doubt, the best simple thing is to do follow-up after 2 months. Some may proceed to the osteonecrosis, but as I told, there is no concrete evidence. Is there any abnormality in the hip joint? Right or left, which is bad? Left, osteoporosis, right? Check right side, left side, osteoporosis. And the same time, there is a bone marrow edema. You can't appreciate any fracture lines, obviously, in T1 and fat at T2. And this is transient bone marrow edema syndrome. Same patient, after 3 months, the osteoporosis is reduced now. You see, compare with the first one. This is nothing but same condition, transient osteoporosis of hip. Depends upon the X-ray you are reading or MRI you are reading. So this is a slightly different context where you can see obviously a hypointense line, subchondral insufficiency fracture associated with a large amount of marrow edema. So subchondral insufficiency fracture has to be differentiated from AVN, which comes in a different age groups, osteoporotic, elderly, renal failure. Low intensity crescent line will be there. This line is disconnected, not continuous, convex inferior border. The inferior border of this convex superior border, along with the cartilage, along with the joint margin, it is convex. There won't be any double line sign. On contrary, here the line will be away from the joint. Let me show in a picture. Here the convexity is away from the joint, that is avascular necrosis. Whereas in stress fracture, the fracture line will be along with the joint line, that is convexity towards joint line. So this is the difference between AVN line and stress fracture line. Stress phenomena sometimes can come beyond the head, femoral head. Here head is relatively normal, but this has come neck. It's much more common to have such neck fractures, stress fractures in the medial part of the neck. You can have stress fracture drug related or normal ones in the upper 1/3 of the femur as well. So don't confine always to AVN and other causes of edema. Look for actual pathology. That can be malignancy, that can be inflammation, that can be infection, that can be arthritis of systemic nature. Let me include some conditions along with this one, where the marrow edema serves as a clue. Let's go for 3 examples. Idiopathic chondrolysis of the hip joint. It comes in adolescent. Geographic area of the signal change, which comes in the middle 1/3. Very confidently you can diagnose with the pattern of edema. And later you will get ill-defined acetabular marrow as well, joint effusion and synovial hypertrophy. This is a bad condition, relatively treated condition. You have to separate from transient synovitis of the hip joint, which comes slightly early age, acute onset, just like a common cold to the nose. No signal change should be there to call transient synovitis. It's synovial thickening and effusion as well. Just only 2 findings. Septic arthritis, you can see both sides of marrow signal changes, decreased proportion of the head, rapid destruction of the cartilage. You will have a lot of systemic clues for septic arthritis in compared to these other 2. So this is infectious, this is classical appearance of infectious arthritis or inflammatory arthritis. You have to follow systemic markers. You have to do joint aspiration to get the diagnosis. This I have taken from one of the journal. I don't have much experience of doing dynamic studies for septic arthritis. They are insisting that if you do a dynamic study, only in septic arthritis you will have very poor perfused femoral head signal. All other conditions it will be normal. Try in your center. Transient synovitis just like this. There won't be any marrow signal in the acetabulum, just synovial thickening and effusion, which rapidly resolves within 8 weeks. Idiopathic chondrolysis, this is a classical pattern of marrow edema in the middle 1/3 and geographic signal changes. Later you will get acetabular signal changes. Capsulectomy is the treatment of choice for this one. This leaves significant morbidity. Perthes disease will have not only marrow edema but also morphological changes such as fragmentation sclerosis. It is never a focal marrow edema in the femoral head. It is always diffuse signal changes, both morphologically as well as signal changes, either hypointense in the later stages and earlier stages hyperintense and T2 weighted images. So quiz, rapid quiz, 4 cases. Rapid diagnosis, edema. Yeah, you can see some line, vague line in T1. Always look for the line before you write just transient bone marrow edema. This gives more confidence. Subchondral insufficiency fracture. Sometimes it is best seen in T2, sometimes it is best seen in T1, sometimes in PD fat SAT. Sometimes you will see that line in the follow-up. Anxiety patients and doctors who followed up after 2 weeks, sometimes I pick it up in the second time. I try to bring that doctor's example. I could not get that one. Anything abnormal in this case? Very, very difficult case. Classical subchondral fracture. There is hypointense marrow edema, which is in the posterior part, which is worrisome, which is dirty. ISO or hypointense to the muscle. PET CT scan, very intense foci. There is a lung carcinoma, and this is a proven case of metastasis. So both coexisting. So always look into the marrow. This is the only case I have taken from the net. This is juvenile energy CT scan. The marrow edema is evident on hyperintense, green color. Here you can see MRI shows marrow edema. They have done in phase and out phase. There is a tremendous loss of signal in the out of the phase, which is very good sign. There is no infiltration in this. It's just bone marrow edema. 8 weeks follow-up, complete resolving of edema. This is just like transient bone marrow edema syndrome. So if it is not suppressed the signal, then you might require a biopsy to see infiltration. The last example, periphyseal edema, bilateral symmetrical. This patient also had some knee joint problem 6 weeks back, limping on both knee, now at the hip joint pain. Bilateral symmetrical periphyseal edema. What could be the cause? Just like knee joint, this can be just FOP at that age group. It can come at any fusion areas, bilateral symmetrically, painful. But it's not always easy. You need to distinguish from all these conditions, especially other than knee joint, such as scurvy, where marrow edema is symmetrical, bilateral, metaphyseal, and with periosteal reaction. FOP will have classical sunburst pattern of edema. And you have to differentiate chronic non-bacterial osteomyelitis also, where lytic lesion, sclerotic lesion, hyperostosis, with some favorite areas like clavicle will be there. Leukemia, you need to differentiate. Extreme hypointensity you will see in the marrow. There won't be any sclerosis in the active stage. You can use all the Dixon techniques and other techniques to differentiate the marrow infiltration. My sincere acknowledgements to all these people who have contributed the case. You can download this one. This is freely downloadable article from IJMSR. Last year we published. And do come to Vijayawada. I am from Vijayawada. We are organizing a cadaveric hands-on course at AIIMS Mangalagiri since many years, this year also, in the first weekend of the December. Thank you very much. This is my contact. You can write any comments to this contact.
Thank you, sir, for such a wonderful talk and showing us so many beautiful cases. I'm sure the residents are enlightened by this talk. So, next.
Yeah.
I'd like to call our next speaker, Dr. Rakhi Kumar Prithvi. She is a chief radiologist and MSK lead in GBK Health Hub, Hyderabad. And she will be speaking on decoding posterior with pain, imaging algorithms and pitfalls.
Hi, good morning everyone. It's really good to see a full hall. My slides need to start, or do I have to start it myself? Okay. So let's talk about the posterior hip on continuing. So what I hope to cover is the anatomy, identify the location and narrow the differential, recognize the pathologies, avoiding pitfalls, and how we can have a practical diagnostic algorithm. So the posterior hip pain is the least common type of hip pain, and it's a combination of bony, ligamentous, muscular, and neurovascular structures. And patients often present with a very vague and deep-seated pain in the buttock, which can radiate to the posterior thigh, and it can mimic radiculopathy. And even the examination can be quite ambiguous. So then why talk about it? Because I think we radiologists are all, mystery solvers, right? We're all detectives and everybody wants answers from us. And you have to remember that the hip is not just one joint. There is a joint above and below, the lower limb and the spine. So any abnormality in one joint will lead to abnormality in the other joints. So the pain in the hip can come from several other joints. So you need to have a wild, your mind also needs to be open to find the cause. So these are all the several different, there are 13 areas that you can get your pain from. And when you look at the history, we are sitting in our rooms reporting, always look at the history, talk to the patients or teach your technicians how to take a history. You'll get an idea on what the diagnosis is. Ask for the duration, what is the trauma, what is the profession. If it's an IT guy sitting on their butt all day, they will have some kind of pain. So you can look at the, you can get a clue by just looking at the symptoms. So if the patient has a buttock pain, it can arise from the SI joint or the piriformis. A sitting pain can be because of a hamstring or ischial bursitis, so on and so forth. Also, it's nice, some orthopedicians, they do right, and sometimes look for these clues, like if it's patient, the doctor has written Faber test positive, then it likely means it's a sacroiliac joint. If it's a Fader test, which is a flexion, adduction, and internal rotation, that means it could be a labral tear. So learn to look at these clues, and you can identify what the site of pain is. So the anatomy. So the hip joint, we all know it's a ball socket joint with bony components, and it has this fibrous component also where we have the ligaments, which are very important. And when you look at the slide, you can see how many muscles are coming and attaching to one single point, right? So this is quite a narrow area, and that's why we have all these vague symptoms. So when we start with someone with posterior hip pain, the first and foremost, I think for any MSK, the rule applies, always start with the radiograph. It should be our first choice. Do an AP pelvis, they'll ask you for a lateral view. A 45-degree done view is really good to look for the bony outlines, and you can identify osseous lesions and anything which is, a bony pathology. If you identified something, go ahead with a CT. You can look for occult fractures, an FAI morphology, acetabular version, and you can find, of course, calcifications. If the pain is still persisting and there are no answers otherwise, go ahead with an MR. This is the gold standard, and you can identify all the structures. We all love MR. And along with that, we have the new sequences, a UTE, ultra low TE, or a ZTE, which is really good, and you can, I feel sometimes, skip the CT altogether. Very important is an ultrasound. You can go directly from a radiograph. If your clinical suspicion is high, go directly towards an ultrasound. You can identify the gluteal and the hamstrings attachment. You can identify the sciatic nerve beautifully, and you can also perform a dynamic assessment and also perform injections. So this is the standard. Dr. Sandeep already spoke about the protocols. You can tailor the protocol. There's nothing fixed that you can follow, that you have to follow. Several causes of pain that it can come from, and as so far, for me, the number one cause is this is the number one cause of posterior hip pain as of yesterday. So number one, this case, 24-year-old male came with pain in the buttock region, left more than the right side. And what are we seeing? An L5S1 disc. Remember, your lumbar spine referred pain is the number one cause of a hip pain, and patient can recreate this pain by flexion or extension of the lumbar spine, and you can have radicular symptoms traveling down the leg. Second patient, this was a physiotherapist, and he was having pain in both the hips, right more than left, and he had an abnormal gait, and they were suspecting a femoral acetabular impingement, and this is the prescription that we got. And if you see the radiograph, you can definitely start seeing, there is some abnormality in the hips, there is some lateralization, and you start seeing some cystic areas maybe here. The SI joints are not really good. They've done a lumbar spine lateral, so they've ruled out the spine, and this is the, the side, but patient had more pain on the right side. So patient came for an MRI, and as I scroll through the images, you can see there are already cystic changes, already degenerative changes, and there's a lot of edema in the hips, right? And there's a lot of fluid on the right side, which explains his pain also looked as like an abnormal morphology. It's looking like a mixed cam pincer type. But as this is an incidental lesion, and as I scroll, what am I seeing? I'm seeing bilateral sacroiliitis. There's already fat metaplasia. He's only 24 years old, so obviously he's been ignoring the pain. And we raised the possibility of an ankylosing spondylitis with adjacent inflammatory changes. This is a very nice UT image. This is a oblique image, and you can identify the erosions very nicely on the UTE. So causes of posterior hip morphology, correlate with tendon morphology, look for the edema, piriformis asymmetry, always correlate clinically. Do not miss the SI joint, always include a wild field, FOV to look at the joints. Do not miss stress fractures, always review your T1 like Dr. Sandeep said, and never forget the nerves. Nerves will make everyone else, very nervous. So this was an interesting case, ankylosing spondylitis. He was a known case and he had a resurfacing arthroplasty. And the patient came, he was having pain again on the left side. And the doctor was suspecting, is there some alveol going on, something? And as I traced, you can see there is some adductor edema. But then the patient also had a large testicular tumor. So, you have to look at all the things all the time. So quick imaging algorithm, patient presents with posterior hip pain, look at the clinical examination, always do it follow it up with an AP view. Is there any obvious lesion? Then go ahead with the CT, look for the bone morphology and the fracture. If it's normal or it's inconclusive or you're not able to, you want to investigate further, go ahead with an MRI, identify the bone, the labrum, the tendons, the muscles, and always the SI joints. So posterior hip pain is the least common type of pain, but it is the most troubling type of pain. And it's predominantly extra-articular. So always look at things around the hip joint. Review the prescription, the clinical details and examination, and evaluate all the structures in an organized manner. Follow your checklist method. Beyond the hip, look at the disc, look at the SI joint, look at the marrow edema if you're seeing marrow edema. Look at your hamstrings, identify your quadratus femoris, and of course, identify the sciatic nerve. We may not solve all mysteries. You may have a case, where it's normal. But rather than asking what abnormality is present, ask which abnormality explains the patient's pain. So treat the patient, not the image. Thank you. I think I'm first one to finish ahead of time. So I would like to invite you all to next year. Please register. There's an early bird registration, and Kolkata is a great city. Apart from the food, and you're going to have an amazing time over there. Trust me. Thank you.
Thank you, Dr. Rakhi, the only faculty to complete before 15 minutes. We sincerely acknowledge. As we have overstood almost 25 minutes, we will not have question answer session. We thank all the worthy faculties, Dr. Sonal for moderating, Dr. Dipali, Dr. Madhurima, and myself, Dr. Kalpesh Shah. We conclude the session here. We'll have a break and we come back here by 10:55 so as to start the session at 11. Yes, Dr. Joshita around? So what time you want to start?
start the session since we are running a little late. Is Dr. Mihir Pandya here? That's me, fine. Come. I'm joining you since the other chairperson is not here yet.
Hi, good morning everyone. Now we are starting with our session. The first topic today of this session will be cartilage and bone under stress, MRI of osteochondral unit, and the distinguished speaker with us on this is Dr. Prakash Sharma, who is a MD radiologist, professor in Institute Nepal, Manipal College of Medical Sciences. His special areas of interest is of course MSK radiology, and he has got many achievements. The major achievements of these include his editor-in-chief Nepalese Journal of Medical Sciences, his section editor of MSK in Nepalese Journal of Radiology. He has got more than 55 publications in national and international peer review journal. So we all are privileged to have him among with us. So without wasting any time, I will request Dr. Pankaj Sharma to start and share his knowledgeable. Dr. Prakash Sharma, sorry, पंकज से मिला था ना कल तो पंकज की आदत हो गई है. So Prakash Sharma to share his knowledge on this topic.
Thank you, Chairperson. Good morning, everyone. So for the next 15 minutes, I'll be discussing about the MRI of osteochondral unit. So osteochondral unit is a functional load-bearing complex of cartilage and subchondral bone. So the core components are articular cartilage, calcified cartilage with tide mark, subchondral bone plate, and trabecular bone. So osteochondral unit is composed of various layers. So starting from joint surface towards the marrow, we have the superficial zone. So here the thin collagen fibers, they are oriented tangentially, they are tightly packed, and the chondrocyte, they are flattened and are lying parallel to the surface. So the main function is to provide a smooth, low friction surface, and it resists shear force. So beneath this lies the transition zone or the middle zone. So here the collagen fibers, they are obliquely oriented. It has high water content. The chondrocytes are round, and the main function is the distribution of load evenly. So below this layer lies the deep or radial zone. Here the thick perpendicular collagen fibers, they are oriented perpendicularly, and the chondrocyte, they are arranged vertically. The main function is to resist the compression. So beneath this lies the calcified zone with tide mark. So the uncalcified and calcified cartilage, they are separated by the tide mark. So below this layer lies the subchondral plate and trabecular bone. So they provide mechanical support. So on routine MR, the articular cartilage should have a smooth articular surface, should have uniform thickness, and the signal intensity depends upon the sequence used. So it should have a continuous low signal subchondral bone, and there should not be any focal marrow edema, no cyst, no fracture line, or no collapse. So which sequence is best in evaluation of the articular cartilage? So ideally, we have to see the articular cartilage in all the sequences, in all the plane. But the PD fat set is the most important sequence. So in this sequence, we can evaluate the surface of the cartilage, the intensity of the cartilage, and the marrow edema. All these three things can be evaluated in one sequence. So T1 weighted image is best for evaluation of marrow, T2FS, and stir sequence. They are helpful in evaluation of the fluid, cyst, and bone marrow like lesions. So we have 3D sequences. So with this, we can evaluate the thickness of the cartilage. So beside these morphological sequences, we have the newest sequence that helps in the evaluation of the composition of the cartilage, like T2 mapping, T1 row imaging, and delayed gadolinium enhancement of the imaging. So while evaluating the osteochondral unit, so we have to follow a systematic approach. So we have to read every lesion in the same order. So we should start from the articular surface, whether we have to see whether it is smooth, fibrillated, or fissured. Then we have to see the thickness of the cartilage, so whether there is any focal defect or complete loss of cartilage. So next is we have to look at the internal signal intensity within the cartilage. Then we have to look at the osteochondral junction. So in this area, we have to look for the delamination. So beneath this, we have to look at the subchondral plate, so whether it is intact or not. So there may be depressed fracture. So we have to evaluate the subchondral plate. Then we have to see the marrow, look for any bone marrow like lesions, cyst, necrosis, insufficiency fractures, and other things in the joint like meniscus, ligament, synovium, etc. So cartilage injury can be graded according to modified outer bridge classification. So whenever available, so 3 Tesla MRI should be used in evaluation of the cartilage. So this is the MRI of knee showing the thickened swollen cartilage with increased signal intensity. The surface is intact, so this is grade 1 chondromalacia. So this is the MRI knee showing fissure involving less than 50% of the thickness of cartilage, so this is grade 2. Here the cleft involves more than 50% of the cartilage, so this is grade 3. And sometimes there may be partial or complete loss of cartilage, as in this case there is complete loss of cartilage with associated subchondral marrow edema, so this is grade 4. So normally this osteochondral junction is hypointense in all sequences. So if there is linear fluid signal intensity deep to the cartilage parallel to this surface, it is nothing but chondral delamination. So it can be surgically relevant even when the articular surface look intact. Sometimes there may be, we can see irregular fluid signal within the superficial surface of the cartilage, so this is nothing but the fibrillation. So they can be early marker of cartilage degeneration. So we can see linear cleft within the cartilage, so that is the fissure. So when this chondral delamination extend to the articular surface, it forms the flap. So they are unstable and they can be often symptomatic. Osteoarthritis involves the osteochondral unit and is characterized by cartilage loss, fissuring, subchondral bone marrow edema, subchondral plate thickening, subchondral cyst. So this is the MRI knee showing subchondral cyst. So here fluid signal intensity lesion is seen beneath the articular cartilage. So this is nothing but the subchondral cyst. Sometimes we can see subchondral sclerosis, so which appears as a uniform low signal intensity in all sequences, as shown here, which appears thickened. So there is thickening of subchondral plate, which appears low signal intensity in all sequences. So this is subchondral sclerosis. Sometimes we can see linear low signal intensity parallel to the articular surface. So these are the subchondral fracture, insufficiency fracture. So they are associated with extensive marrow edema. So they may progress to collapse, so if left untreated. So there may be avascular necrosis, which is characterized by geographic subchondral or medullary low signal intensity rim with serpentinous border and may show double line, and in the advanced case we can see collapse. Sometimes trauma may involve cartilage, bone plate and marrow simultaneously. So these are the osteochondral injury. So here the bone marrow pattern suggests the mechanism of injury. If the surface is violated, then it suggests osteochondral fracture. So if there is, in such case, we have to look for donor site and the loose body carefully. So while reporting, we have to answer one management question, that is the osteochondral fragment stable? So whenever there is fluid rim around the osteochondral lesion and there is cartilage bridge, or there might be sometimes cyst beneath the osteochondral lesion, and there may be high signal interface between the bone and the osteochondral lesion. These all indicate that the lesion is unstable. So in such case, we have to report the location, exact location, size, fragment integrity, mineralization, stability, and we have to talk about the loose body. So beside these morphological sequences, so we have quantitative sequences that can be used in evaluation of the articular cartilage. So T2 mapping, T1 row mapping, delayed gadolinium enhancement of MRI of cartilage, then UTA sequence. So as shown in this image, so these T2 mapping, they can detect biochemical changes before the morphological loss. So as in this case, so there is the increased signal intensity with a smooth surface. It looks like grade 1 lesion, but here on T2 mapping, we can see a defect involving more than 50% of the thickness. So this is grade 3. So this is the practical reporting checklist we have to follow. So what the orthopedic surgeon needs, we have to mention about the exact location of the lesion, the size of the lesion. We have to talk about the cartilage, with whether there is fissure, fibrillation. Then we have to talk about the subchondral bone status, marrow, and the osteochondral fragment is stable or unstable, and the associated finding within the joints. So in conclusion, osteochondral unit is one functional organ. So cartilage defect must be interpreted with subchondral plate and marrow. So bone marrow edema is a pattern, not a final diagnosis. Delamination, instability and collapse are management changing findings. So we have to report these carefully. So structural reporting improves communication with orthopedic colleague. So we have to report and we have to follow one structural pattern while reporting the osteochondral unit. Thank you.
Thank you, Dr. Prakash. You have completed before time. We have the time for the question answer.
That's okay. You're completed.
Okay. Now we are proceeding for the next lecture. Dr. Girish is the Director, MSK Radiology, Fellowship Director of MSK Radiology, Professor and a Vice Chair Department of the Radiology, Deputy Editor, and
AIUM Germany. He is working in the University of the North Carolina, USA. He is the well-known MSc ultrasonography radiologist even in India, and is frequently giving the lecture about the MSc ultrasonography. Achievements are the National Research Innovator Award, Multiple Excellence in the Teaching Awards. He has the many publications and presentation. So I invite Dr. Girish to start.
Thank you very much. The audiovisual, if you can just flip. Thanks a lot. So today my topic is on meniscal imaging findings that changes management. Pretty much everything changes management, but I will focus on things that are maybe surgical, and emphasis on meniscal root tears and extrusion. As usual, right, we will start off with a little bit of anatomy. Apologies to those who already know this well enough. But this is the medial meniscus. It goes all the way to the edge of the tibial plateau. The key point is for you to understand that the anterior horn lines the anterior edge of the tibial plateau. It's slightly different on the lateral meniscus. It bends forward a little bit or backwards and is in close proximity to and often overlapping with the ACL attachment site, the root of it, and we'll focus on that again. So this is the medial meniscus, this is the lateral meniscus. The collagen bundles are oriented longitudinal fashion, and radial fibers extend towards this free edge. The other thing you want to appreciate is what is called the free edge, which is the inner edge, and what is the periphery, which is the periphery as shown here. So these are the two things. Moving on to another part that you want to appreciate in the anatomy part of it is the peripheral versus the central portion of the meniscus. The peripheral zone, the red zone, is about 20 to 30% of the meniscus in the periphery, and this is often vascular. So if there is small tears, there are better chances to heal. Whereas in the avascular zone, which is on the inner side, there is poor healing of the tears. The way these things look, right, on the lateral meniscus, medial meniscus, and the body, especially those who are beginning your radiology career, you will notice that the anterior and posterior horn of lateral meniscus, similar size, whereas the posterior horn of the medial meniscus is twice the size of the anterior horn. The other thing is, if you were given an image alone, and you need to figure out whether it is lateral or medial, you will notice that the anterior border of the anterior horn of the medial meniscus lines the anterior border of the tibia, whereas here the anterior border of the tibia is far, far anterior to the anterior border of the lateral meniscus. And that is kind of why I highlighted the anatomy of the medial meniscus when we were looking at that. Moving on to the meniscal roots. Okay, so these are the attachments. Meniscus attaches by anterior root and posterior root, and there are anterior and posterior roots for both meniscus. Anterior root of the medial meniscus lies in the mid portion of the anterior tibial plateau, which is here. Anterior horn of the lateral meniscus actually overlaps with the attachment site of the ACL, and it has got some imaging interpretative issues with that, because any signal change in the ACL will carry itself to the anterior horn of the lateral meniscus. So we should not overcall tears just because there is high signal there. Then you look at the posterior side. The posterior horn of the medial meniscus is just anterior to the PCL, and the posterior root of the medial meniscus is just anterior to the PCL, and the posterior root of the lateral meniscus anterior to the posterior root of the medial meniscus. So here is what I was highlighting. This is the ACL. There is slight high signal in the anterior portion of the anterior root of the lateral meniscus, and that signal sometimes is usual and it's okay. You just have to look very carefully. Is there really a tear, or is this just the signal carried over by the ACL crossover fibers? Here is what the ACL is. This is the anterior horn of the lateral meniscus. This is the intermeniscal ligament. I can hear the lecture from the next conference. That's so interesting. So this is the posterior root, right? The posterior root, there is always going to be something just anterior to the PCL in this area. So if absence of that is what you're looking for, the ghost sign or whatever. And this is the posterior horn of the medial meniscus attaching in this particular location. Normal areas. This is the posterior horn here, posterior root here, and this is the PCL. This is the posterior root of the lateral meniscus. So how to read meniscal tear? So how I read meniscal tears? Everybody reads it slightly differently, so I'll just mention how I look for it. First of all, identify where is it? What part of the anatomy? Is it the anterior horn, body, posterior horn? And then is it the inner side or the outer side, like the free edge or the peripheral portion, or is it involving the roots? So like the anterior or posterior root. And the last one is, of course, the meniscocapsular issues. And we will talk about that, the ramp and the Risberg options. These are the tears at the meniscus capsule attachment site. And then once we figure out where the anatomy is, then we'd like to see if we can define a shape to this. Sometimes you cannot. So these are horizontal, longitudinal, radial, complex, and macerated. If there is a displaced fragment, that is critical, because that is sometimes very useful to know, because that can lock the knee and it makes a change in management. What type of displaced fragment are we dealing with? Bucket handle tear, flipped meniscus, flap tear, or displaced fragment itself? Generally, the arthroscopic criteria for management includes less than or equal to 4 millimeters from the meniscocapsular junction, a tear that is easy to repair. I'm talking specifically about repair, not resectability. Tears about at least 1 centimeter in length, they will go for it. Tears more than 50% of the meniscal thickness, and this is very much dependent upon the surgeon as well, and the intact intermeniscal segment. So types and shapes of the meniscal tears, and again, it's really for the residents here. Longitudinal tear. What is a longitudinal tear? This is a vertical or a longitudinal tear along the long axis of the meniscus. It's kind of vertically oriented, as you see here. Horizontal tear is horizontally oriented in this fashion, as you see in this place. That is a horizontal tear. A horizontal tear starting off from the superior articular surface can raise a flap, and that is called the horizontal flap tear. More on that a little later. The inner edge tear is the radial tear that you see here. Slightly displaced radial tear is a parrot beak tear. Okay, so let's look at the displaced side of things. A longitudinal tear, when it completes itself and flips medially, becomes a bucket handle tear. A horizontal tear, when it gets a little bigger and flips outside, either inside or outside, this one is flipping inside, is a flap tear. A radial tear, which displaces itself a little bit more, is a parrot beak or a displaced radial tear. You don't need to know the names, but as long as you appreciate that there is displacement in the meniscus, that is useful for management. Okay, longitudinal or vertical tears. So this is a longitudinally oriented tear that you see here. That is how it will be looking like in the meniscus, in the posterior horn of the medial meniscus. These are often associated with ACL tears, whether they are longitudinal tears of the medial or lateral meniscus. A bucket handle tear, as I mentioned, is a flipped longitudinal tear and often presents as double PCL sign, which is a flipped portion of the medial meniscus anterior to the PCL. It cannot go any further because the ACL attachment stops that. That's why you see those double PCL sign quite often. So this is a bucket handle tear of the medial meniscus with a double PCL sign. Moving on to horizontal tears. This is the horizontally oriented tear. This is how you will look at it. Some people will even call this a little bit of a horizontal oblique tear. Now remember, as a basic rule, the tear of the meniscus should involve either the superior articular surface or the inferior articular surface. It doesn't matter too much what is happening at the peripheral portion, but a tear should involve either of these two and should be seen at least in 2 consequent images, just to increase the specificity. So a horizontal tear, if continuing to the periphery, can lead to a meniscal cyst or a parameniscal cyst. Larger on the medial side. This is a horizontal tear of the lateral meniscus with a parameniscal cyst here. Post contrast, this is how it is looking. It can be septated, lobulated. It can be huge, these tears. This is the ultrasound example of a tear with a cyst. A displaced horizontal tear is a flap tear. So this is a horizontal tear which is flipped in the gutter between the medial collateral ligament and the medial tibial plateau. So this is a displaced flap tear. A radial tab is oriented along the short axis of the meniscus. So this is the radial tear located along the short axis of the meniscus, extending towards the periphery. This is how it will look like on the axial sequence. And when you cut through that, you will see the blunting of the inner edge of the meniscus. In this case, it happens to be more on the anterior horn side. In terms of meniscal root tear, let's look at that in a couple more minutes. Meniscal posterior root, right? So posterior root, as we know, is anterior to the PCL, posterior cruciate ligament. A meniscus converts the vertical load into a circumferential hoop stress. That's kind of how it works, spreading the contact pressure across the tibial plateau instead of focusing or concentrating on the cartilage. So when the root tear detaches from the anchoring point that generates the hoop tension, the meniscal body can no longer do that function. So it resists the circumferential load. So extrusion of the meniscus is a part of this whole process where there is a visible sign of this hoop tension has already failed. The body has physically migrated away from the tibial plateau. So a root tear plus significant extrusion, so you got to give importance to both, behaves like almost total meniscectomy. The meniscus has lost most of its function. So these are some things that they want to fix if they can. So here is a complete root tear. There is a root tear that should be coming down here. There's no root, and then it is getting over to the posterior horn of the medial meniscus. That is the defect that you will see in arthroscopy. And this is the axial view where you can see a defect here at the posterior horn root junction. So in terms of meniscal extrusion, extrusion is defined as how much the meniscal body is extruding from, say, the tibial plateau. If you were to measure the tibial plateau, this measurement is extrusion. And about 3 millimeters is usually the cutoff. There is no measurement. 2 to 3 millimeters or so. It gets significant enough that these things can now start creating, osteoarthritis changes and so on. So there are some predictable markers based on these things. Now, these extrusions are not just related to root tears. They can be related to radial tears, degenerative disease, discoid meniscus, and sometimes ligamentous laxity as well. So I was trying to focus on this extrusion part, and I was trying to relate that to the meniscal root tear, but it can also happen in its absence too. And the extrusion that becomes significant is anywhere about 2 millimeters or so, maybe 3 millimeters and so on. So if it is a root tear and extrusion, it's a big deal. So medial root tears are associated with medial femoral condyle cartilage defects in a significant proportion of cases, 67%. Extrusion of more than 3 millimeters at the time of root repair predicts a worse outcome unless concurrent malalignment issues are corrected. So the bottom line is when extrusion is more than 3 millimeters, which accompanies a root tear, repair alone is unlikely to normalize the meniscal position. It helps. And some surgeons will plan for meniscal centralization procedure and correction of varus alignment rather than repair in isolation. So there's some changes in management. Talk to your surgeon because everywhere they deal with this slightly differently. I'm just trying to highlight that these are some things that you want to push for in your understanding so that you can relate this to your surgeons. And it's too busy, but what it says is that they were trying to look at this study, looked at those cases who had a significant extrusion and the meniscal root tears, and they said most of these, about 30% of these went for TKA in about 5 years, and about 78% of them had OA changes. So that was about meniscal root tear and extrusion. In a complex tear, it is basically tear of a horizontal and an oblique. If I can't define it as a horizontal or a vertical tear, I go down the complex route, and if there is volume loss, and then I will call it as macerated tear. This is the displaced posterior horn of lateral meniscus along the anterior aspect of the anterior horn of the lateral meniscus, and this is called the double delta sign as you see here. In terms of pitfalls, remember there is signal change here, but as long as it doesn't get to the superior inferior articular surface, this is not a tear. This is the meniscal ramp lesion. We call it a ramp lesion. Surgeons, at least in our place, just call it a meniscal tear. We are sometimes right only about 50% of these cases. This is the meniscocapsular junction tear of the posterior horn of the medial meniscus. These are the two. This is the ligament of Humphreys. This is the ligament of Risberg. And the Risberg will continue to go about 4 or 5 images post PCL before it attaches to the posterior horn of the lateral meniscus. If it goes beyond that, then it is stripping itself off the posterior horn of the lateral meniscus, and that is called the Risberg rip. The one thing you want to be careful about with the intermeniscal ligament is, note I told you the anterior horn of the lateral meniscus comes a little bit more deeper. So there will always be a gap and there will be increased signal here. That should not be construed as a tear of the anterior horn. Always identify the intermeniscal ligament. Here is a tear and a blunting of the body of the medial meniscus. Now the question is, don't overcall tears of the inner edge. Fraying is fine. They don't usually do much about this anyway, but if it's really a tear, then it's fine. Okay, in conclusion, find where is it, what type is it, what is the displaced fragment, which is what we talked about, right? And in terms of meniscal root tears, just appreciate that more than 3 mm of extrusion is significant, and a root tear with meniscal extrusion needs meniscal centralization apart from meniscal root tear fixing, and a root tear needs to be fixed, and it's quite an important finding for you to appreciate and report. Thank you very much.
Thank you, Dr. Girish, for the simplification of the tears of the menisci. I'm inviting Dr. King Kenneth. He is from Hong Kong. He is a consultant and honorary associated professor in the North District and the Prince Wales Hospital, Hong Kong. And his areas of interest are sports spine, DCT, tumor, novel techniques, and the MSc intervention. Please.
Thank you very much. Okay. Apologies for this. We're just going to change to a different adapter. If it's not working, would you mind the media team? I think I did upload the file, so we could use that one instead. Yeah, apologies for the delay. The bottom one. The direct is not working, I don't think. So shall we use the laptop? Number 11.
Yeah. Oh, sorry.
No, number 11, yeah. Well, thank you for having me. So it's an absolute pleasure to be here. So thank you for the invite. And it's lovely to be in India. So it's my first time here, and I'm just absolutely joyous to be part of this very warm and welcoming community. So we've had 2 excellent talks from Prakash and also Girish talking about the cartilage as well as the meniscus. So I'm going to move on to the ACL, in particularly the ACL graft. looking at the MR appearance of the postoperative graft. And we're going to focus on the concept of graft maturation. So why is that important? And I think from my experience, it can cause a bit of diagnostic anxiety amongst colleagues who are not as experienced or they don't see in many cases. And often they fall into this classic trap of overcalling pathology in the ACL graft purely because it looks hyper-intense. But I think it's very important to understand that the MR appearance of these grafts is highly dependent on multiple factors. And I think once we know what is actually causing the underpinning the signal change, if you understand the process, then you have a better chance to differentiate what is actually expected process and what's actually genuine pathology. So I think we'll all be quite happy to come across this case. If that's sitting on your reporting pile, you look at that. So, nice and dark, it looks like it's posterior to the Bowman set line, so can go off for early lunch, okay? But life is not always that perfect. More often we see cases like this, okay? It looks hyper intense, it looks a bit ill-defined, and then we're scratching our head thinking, is this actually pathological? Should I be calling this a partial tear, or is this mucoid change, or even worse, impending graft failure? So I'm just trying to convince you that by understanding that the features are highly dependent on the timing of the graft, the type of the graft, and also patient factors such as have they been a bit naughty, have they been going back to return to play a bit too prematurely, has there been recent injury? So all those will actually contribute to the appearance. And it's only by knowing these factors and having that in our armory that we can make a correct diagnosis. So this is the content of my talk. I think before we understand the underpinning MR appearance, we need to understand what is been put in. So I'm going to highlight some of the surgical variations or graft types and also the particular MR characteristics. So not all grafts, they don't look all the same on MR. They have different idiosyncrasy and characteristics. And after that, I'm going to walk through what is the expected maturation timeline. So that's along the concept of ligamentization of the tendon. I'm going to go through the timeline and the sequential temporal MR changes. Then, after looking at the underlying process, then we're going to tackle some of the high yield problems that's associated with the graft itself. It is a crash course of 15 minutes, so I'm not going to have time to go through all the extra graft issues such as arthrofibrosis or prosthesis failure. So we'll be focusing on the graft itself. And finally, just some tips, hopefully, that will be useful for your daily interpretation. So let's move on and see what the surgeons actually put into these patients. Okay, so the majority is overwhelmingly autograft. Okay, and that's because they're widely available, it's from the same patient, and also they do perform better in the long term compared to allograft. So you can imagine allograft is donated from cadaver, they have to undergo gamma radiation, so and they're not live tissue. So I think it's understandable that they don't perform as well. And out of the autograft, there are different types. So we can harvest it, for example, from the bone, the patellar tendon bone. Okay, so patellar tendon. You can also harvest it quite commonly from the hamstring. So that will be the semitendinous and also the gracilis. And not as common will be the quadricep patellar bone graft. Okay. And this is just an illustration showing different types in vitro. So you can see they're all varying between 10 to 12 millimeters, so mimicking or mirroring the native dimension of ACL. And they have different lengths and different appearances. For example, the hamstring graft, they normally take the two tendons and then they fold it back on themselves to increase strength. And therefore, in MR, you may expect a more kind of band-like appearance with some interleaving fluid signal, which I will go into more details later on, because that's one of the pitfalls. So yeah, we've gone through that. So as I mentioned before, different grafts, they actually behave differently, and therefore they result in different MR appearances. And this is just a table to summarize some of those. So if we look at the, so on top of here, I've got the various graft types, okay, and then I've got some of the parameters here. So by looking at the peak hyperintensity time, what we're talking about is when the graft actually becomes most hypertense. And that actually follows a very distinct ligamentization process, which I'll go through in the next slide. But you can expect for a patellar tendon and a hamstring tendon graft, so they typically, the peak signal intensity will be reached at about 6 months' time. Whereas now we know that for quadricep graft, it actually peaks a bit earlier. So you can be as early as 3 months. But then interestingly, when it returns to normal dark signal, it is actually also the quadricep graft that actually has a fairly rapid decrease in signal compared to the rest. But in general, the bone patellar tendon graft will have one of the fastest normalization signal intensity. For the hamstring, however, there's one particular feature that we have to be aware of, as I mentioned before, is it is very common to see some linear fluid cleft, and that's because you're having insinuating fluid in between the various strands of the graft itself. And you shouldn't really expect to see that in a patellar tendon graft, or there will be minimal of those changes in a quadricep graft. And just an illustration to the slide that we saw in the beginning. So here actually, if this is actually within 6 months, or within a year of appearance, and understanding that this is actually a hamstring graft and not the other graft, then you might be okay to actually call this expected finding for a hamstring graft. And after about 2 years, then you can see that that signal has actually disappeared. I've mentioned about the return to normal dark signal. A little bit more about the tunnel appearances. So for any graft with a bone block, so they actually incorporate into the native bone itself, and therefore that forms a very nice seal to the tendon, to the tunnel. And therefore we expect less chance of a ganglion formation or fluid accumulation or tunnel widening in those grafts with a bone plug. But more commonly with a hamstring graft, they do not have bone plugs, and therefore you are allowed to have a minimal layer of fluid surrounding a graft within the tunnel. So just beware not to call that abnormal. So now let's address the underlying biological process and the concept of ligamentarization in these grafts. So it is a temporal change. So at the beginning, once we harvested the graft and put it in the patient, it looks quite natively dark. As you can see here, it's maintained its fibrillar appearance, and that's because it's actually still, the native structure of the tendon itself. And then after a while, it goes through a vascular necrosis, so there's actually no neovascularization just yet at the beginning within 6 weeks. Following 6 weeks to about 3 months' time, then we are starting to get neovascularization. That's when now we're getting some fluid accumulation in the extracellular interstitial space, now causing the graft to look a little bit swollen and also a little bit more hyper intense. As we go down the timeline, so at about 6 months' time, then now we are getting, once we've established a blood supply, then we are now getting the cellular proliferation. So it becomes synovialized, and also we're getting fibroblasts coming to coat and to proliferate around the graft. And that's when you see not just signal intensity change or hyperintensity change, but also the caliber of the graft might look even more swollen, just because it's becoming more cellular. And once it's peaked, then normally we expect the change then slowly normalize to approaching the native graft. So at 1 year, you will still expect to see a little bit of swelling and very, very minimal signal change. But certainly by about 2 years, then you expect in any type of graft to have returned to a more native ACL looking state. And you will also see the striation and the orientation of the fibers to be in line with your graft, and that's because it's partly contributed by the mechanical stress. And combining that, just this is the reference for a native graft, so you can see between the two, they look reasonably comparable. So by understanding the timeline of change and the signal intensity change, once you know what is expected at normal, then now we're better equipped to be able to call out the genuine pathology. Now, there's been some scoring system trying to propose of a semi-quantitative way to evaluate these grafts. Again, it's totally dependent on the post-op timing, the graft type, and then patient characteristics. One of the scores is called a Figueroa score. So they basically broke it down into looking at the integration of the graft. So that's between the graft itself and the bone tunnel interface. So if there's any fluid, then you will score it a 1, and if it's negative, no fluid, then you score it 2. And then you're looking at the intrinsic signal pattern of the graph itself and whether it looks like it's completely ligamentized. So if you have a total score of 2, so then, for example, if there's fluid along the tendon bone interface and it looks very, very hyper intense, then you'll have a low score. That means that there's poor maturation. And conversely, if there's a high score, then it's becoming more adequately maturated or matured. But just to note that these scores is still more confined in the academic setting, so looking at the progression of the graph maturation, but it's currently have a limited clinical correlation and prognostic factors. So let's move on to a checklist. So once we understand the concept of ligamentation, then we can actually start looking at some real cases. So first of all, we need to understand the malalignment, or the alignment rather, of the graph and what's expected, what's normal. So here you can see on the blue dotted line that represents a Brimmen's line, and we expect a normal graph to sit just behind or posterior to this line at the tibial entry. So this is normal. Whereas in here on the right, we can see abnormally, the graph is actually sitting way behind the Brimmen's line. It's too posterior. And what that would correlate to or correspond to is that there will be laxity and insufficiency. Conversely, if it's actually lying too anterior, so in this case, or you have fibers that's anterior to the Brimmen's line, especially on the joint level, then that is prone to impingement. So you can appreciate that the femoral condyle here is going to be impinging and impacting on the anterior aspect of the graph. You can see the associated signal change here, and that is pathological. And that you can see that, appreciate that that's very, very focal compared to the normal signal change that we've seen that is more homogeneous and involving along the whole tendon ligament. This is important to note because that might then progress to partial tear and fraying, as is seen in this case. You can see here that the graph is now much, much thinner, probably definitely not 10 or 12 millimeter as we saw in those graph photos. And look, the signal change is exclusively in the mid portion and the impinged portion as well. You can see that the tunnel is now anteriorized. Graph rupture is normally not too tricky to diagnose. You see a blatant discontinuation of the fibers, and sometimes you can even see the stump that's a bit entrapped and flipped over on the anterior side. And that could be a traumatic event, and also it could be due to a more chronic process, so repeat impingement, causing thinning and then ultimately rupture. Partial graft tear is a little bit more tricky, so that's one of the things I want to focus a little bit on. So here we've got a hamstring graft. You can see again this very clear, smooth fluid collapse signal running parallel in the center of the graft. So this is about 12 months in post-op. So this will still be considered as normal for this particular type of graft. But what you notice here is that the anterior aspect of the graft around the tibial entry here is frayed, okay? And here, just a slide a little bit more laterally, you can see that the tendon, in fact, has partially torn, while the more posterior bundle is still well and intact. And this is usually related to impingement, as I've demonstrated before. Here is a rarer presentation where the partial tear is actually now involving the posterior aspect of the graft itself. And you can see there's actually an underlying background mucoid change that could be contributing to the posterior impingement and also partial tear. And graft ganglion and mucoid change, again, this is still an intact graft. So you can see that it's still continuous. There's no breakage of the graft as such, and it's seen as high intensity. Now it's important, again, the timing is crucial here. So we don't expect to see this in the first 6 or even 12 months of post-op. So if you see that, then it shouldn't really be classified as mucoid. But if, of course, this persists after 2 years post-op, then we can be quite definitive to call this a mucoid change. And on the right here, you can see that the tunnel is now filled with fluid signal component here, and the tunnel is expanded as well, so this is a graft ganglion. So on its own, the mucoid change is not definitively linked to impending graft failure, but also you can appreciate that because of the caliber change, it's fatter, it's more swollen, then there could be secondary impingement involved. So I'm coming to a bit short of time, so I'm just got another 2 slides. So in real life, we don't just see one pathology. You know, we see a mixture of all these changes. So in this case, it'll be tricky. So again, timing is crucial. If we're talking about a patient that is 6 months post-op, then my focus wouldn't be on the graph itself or the graph signal hyperintensity itself, because I'm expecting 6 months post-op, the graph is going to be swollen. Then I'll shift my focus on the other aspect. For example, I'm looking at the tunnel here. Why is there such a large cystic component that shouldn't be there for in 6 months' time? Whereas if this is 3 or 4 years post-op, then there could be a simple ganglion cyst. But if it's 6 months, then the graph is failing, right? And also the graph here is much thinner. So again, I wouldn't expect that at all, regardless of timing. That is not expected. That's too thin. And you can also see that the tunnel itself is widening. So if this is actually 2 or 3 years post-op, looking at the graph now, that will be my focus, because then I expect the graph to be hypo-intense. Then immediately my focus will shift on primarily on the graph and looking whether there's impending failure. I've mentioned that some of the topics I'm unable to cover, but plenty of online resources to cover that for us. So very briefly, for pearls and pitfalls. So I've highlighted some of the graft-specific variation in terms of its selection and also the MR appearance. That the bone, patellar tendon bone graft has the fastest rate to full ligamentization. Beware for hamstring tendon graft that you can get a fluid cleft that's very thin and smooth. That is normal, and they are more commonly associated with widening of the tunnel and fluid within the tunnel because they don't have a bone plug. Quadriceps, I've touched on about the slightly different signal intensity change. And in terms of differentiating between partial tear and ligamentization, it's always important to refer back to the clinical context. And also, I think if there is any degree of thinning and if the signal change is too focal, and most importantly, approaching fluid signal, and the key is incompatible with what you're expecting for that time or that graft type, then you have to raise a suspicion of partial tear. And the rule of thumb is if you see high intensity of the graft after 2 years post-op, then you have to consider that as abnormal until you can figure out if there's anything else going on. So to take home, the context itself dictates the signal change, as I've touched upon before about the timing, the graft type. Have to be careful, look at the graph itself and also beyond the graph if patients are presenting with new symptoms. And also we have to adopt appropriate wordings. So what I encourage my trainees, for example, in my local hospital is not to overcall, not to call these partial tears. Right. For example, if it's 6 months post-op and you see asymptomatic hyperintense graft and a bit of fluid in the tunnel, I would conclude that as a graft and a time-appropriate post-op appearances. So with that, I conclude my talk. So thank you very much for your attention. Thanks.
Thank you, Dr.
It was a really amazing lecture, and now we move on to our next lecture, which is going to be on small joints, big impact, anatomy, biomechanics, systemic disease. So to deliver this lecture, I call upon Dr. Christine Chung. We heard her yesterday. She's the professor and chair of radiology at UCSD, and she's also the current president of the ISS.
Just wait a moment to get our talk loaded. Number 12, yeah, that's it. Great. Okay, we'll go ahead and get started. I will admit that I had unintentionally made this talk for a 25-minute talk, so you're going to get the slimmed down version. Luckily, I looked to see it was actually 15 minutes. And so we'll go ahead and begin our time together. So as we consider small joints, it really is true that they're overlooked in size and outsized in impact. So we think about symptomatology in these small articulations and pathology that seems very mild but can be debilitating. And similar to the points that I made yesterday when we were talking about osteoarthritis, this is ubiquitous. Almost everybody has had some sort of injury, ache, pain issue with one of the small articulations. And so given our time limitations today, we're going to focus on turf toe first MTP. And I know there was a lecture on this yesterday. Unfortunately, I missed it. So hopefully it will be complementary and reinforce and augment this very complex anatomy and biomechanics. We'll focus specifically on something in metatarsalgia that we see every single day when we're reading images. And the final will be the temporomandibular joint, which I'm not sure how many of you end up interpreting TMJ, but it strikes fear into the heart of the radiologist. Nobody wants to own it. The neuroradiologists don't want it. The bone radiologists don't want it, but this is an amazing articulation that I think hopefully after today you'll fall in love with it and you'll want to read all of those when you get home. So let's first begin with turf toe and the first MTP. So as you're thinking about something really simple, taking a step, jumping, running, these things that we take for granted, the amount of force that's transmitted across the forefoot and specifically the first MTP is really insane and hard to believe. So as you look at long axis of the forefoot here and then short axis moving sequential images, findings here are very, very subtle, but very symptomatic. So as you look, this is a beautiful image showing you the sesamoids at the plantar aspect of the articulation, subtle altered signal intensity in the subcutaneous tissues, and then looking at the short axis images, you're seeing something really subtle here. So there's the skin marker, great toe is clearly the area that's symptomatic, and here you're seeing altered morphology, signal intensity, and again at the medial aspect of that first MTP. Let's move into the sagittal imaging plane, and we're going to review the anatomy after we look at this case. But here, coming to your sesamoid, sesamoid has a ligament that comes back and attaches to the metatarsal and has a ligament that then moves forward and attaches to the phalangeal base. So here, look, high-grade partial tearing, near full thickness, few of the fibers still remaining, and then look at the other sesamoid. You should have a nice, thick, robust ligament extending from sesamoid to base phalanx. And you may think, how symptomatic could this be? Extremely symptomatic, and for professional high-performance athletes, career-ending, because they simply can't have this motion at the first MTP. So think about standing up on your toes. What happens? The metatarsal head is driven down on the plantar articular surface here, or plantar capsular surface. Here's your sesamoid. Now remember, there's a ligament extending from the sesamoid to the metatarsal and from the sesamoid to the phalanx. So in this position, you drive that metatarsal head into the capsular structures, and imagine the force that is loaded at that sesamoid to phalangeal ligament. This is the area that we see the most failure, and those partial tears, high-grade partial tears involving one or both sesamoids, again, becomes really debilitating as we consider, this motion that we have of pushing forward from the forefoot. So not to cause anyone to be disheartened, but as you consider the plantar plate complex, it is complex. There are 15 structures that actually contribute to the plantar mechanism, but let's make this simple and let's divide it into 3 areas. So if we look at this, we're going to have a sesamoid complex, we're going to have capsular structures, and then we're going to have musculotendinous system. So we're going to make this really simple so that you're not memorizing things, but rather really thinking about it in that way. Here, what we've done is taken the metatarsophalangeal joint, we've resected the capsule, you're looking down on the metatarsal head, pulled the capsule back, and here's the proximal phalanx. There are your two sesamoids. So when you think about the lesser metatarsophalangeal joints 2 through 5, you think about a very robust, thick plantar plate, fibrous, black, thick. At the first MTP, this is probably the most insignificant structure. Very thin, this plantar plate, paralleling the capsule, but the large, robust structures, intersesamoid ligaments and ligaments extending from sesamoid to phalanx, from sesamoid to metatarsal. Here are your two sesamoids. Here's the intersesamoid ligament. And as we consider then, again, two sesamoids, intersesamoid ligament, this wispy structure right here outlined, that's the plantar plate. So at the first MTP, this is a minor player. Now on the sagittal imaging plane, there's your sesamoid, big, thick, robust, sesamoid to phalangeal ligament, thick sesamoid to metatarsal ligament. Here it is with an illustration again. So you see the plantar plate proper is not the most important thing here. Those other robust, big, thick ligaments are really what's supporting that plantar complex. And so there, you're done with the sesamoid system. That's 5 or 6 structures out of the way. The musculotendinous system, also kind of easy once we think about it in a very basic way. So each of the sesamoids lives in one of the heads of the flexor hallucis. You've got the flexor hallucis brevis, rather, medial and lateral heads, the longest here coming along the plantar surface, and then you've got an abductor and an adductor. Okay? Now you're done with the musculotendinous system. Okay? And as we think about this, look, here you go, an illustration showing the muscles intact. Here you can see you've got your abductor, your adductor. Here's your brevis. That's holding the two heads of the sesamoids there, and then the longest passing along the plantar aspect of the MTP. These images show those same things, your sesamoids, right? Remember, those are living in the heads of the flexor hallucis brevis. The longest is passing along the plantar surface, and an abductor and an adductor. Okay, so brevis, longest, abductor, adductor. And now the musculotendinous system is also complete. So those 15 structures, if you break them down into the different areas, become much easier to bookkeep and to understand as you're working through the case proper. So now let's apply this similar to what we saw in our first case. I like to start at this very plantar long axis image. Here are your two sesamoids, and at the medial sesamoid, you see altered signal intensity. That's verified as you look at the sagittals. There's that medial sesamoid, altered signal within it. So we know we're going to look closely at the muscle and, of course, at those ligamentous stabilizing structures. You remember that the sesamoids live in the heads of the flexor hallucis brevis, right? So here's the medial head. And then as we move to look at those really robust supporting structures, we should see a nice thick sesamoid to phalangeal ligament. We're not seeing that there. So altered signal in the bone. We have that sesamoid to phalangeal abnormality as well as some edema within the muscle. So we're seeing again all of these areas of abnormality based on looking at a systematic approach to the anatomy and applying standard rules of MR as we consider it. Okay. Again, this looks like it shouldn't be a very symptomatic injury, but can be debilitating as we think about our high performance athletes. Okay. So with regard to metatarsalgia, we talked about the mechanics of that plantar plate complex, getting up on the toes, that metatarsal head really stressing plantar capsule. As we think about foot alignment, painful foot in general, we really want to think about, again, the biomechanics and the drivers behind what we're seeing. So this is what our clinicians look like. I'm showing you a nice looking foot with beautiful toenail polish here. I mean, this is probably their best case as they look at patients coming in with foot pain. But as you look at the alignment here, we can all make the diagnosis based on looking here, right? Hallux valgus alignment, something we see every single day. And so as you look at our forefoot images here, and remember, of course, we're going to make this diagnosis on weight-bearing views. The hallux valgus, we often see degenerative changes at the first MTP, but the thing sometimes that we overlook is the fact that mechanically, with the hallux valgus, the great toe places mass effect on the second toe. So it's like constantly pushing on that second metatarsophalangeal articulation, and we can see the mass effect here. See the slight lateral deviation of the second ray. Okay, so keep that in mind. Now, as you consider how we make this diagnosis, weight-bearing view, draw a line along the long axis of the proximal phalanx as well as the long axis of the metatarsal. That angle in this case measures 30 degrees. If it's greater than 15, we know that that qualifies for hallux valgus alignment. Now, as you're looking at the hallux valgus, you also could look at the intermetatarsal angle. That should be 10 degrees or less. And it's always nice to take a look at the relationship of the forefoot with respect to the midfoot. In this case, you also have metatarsus primus varus. That is to say that the first metatarsal angle to the medial cuneiform is greater than 25. So if we were going to repair this, we may want to deal both with the changes at the first MTP as well as the changes at the tarsometatarsal junction. Idea here again that you have to go downstream and upstream in order to really take care of what the driving factor is with respect to the degenerative changes and the alignment pattern happening distally. Okay, so often the surgeons will cheat a little bit because they want one insertion and they just want to take care of things distally, and that will change the aesthetic alignment, but it does place the patient in a situation where the hallux valgus will recur. So we've talked about the hallux valgus. Look what happens with the chronic mass effect of the hallux valgus on the second. This is something that we see quite commonly. It's a capsulitis at the second MTP, and the foot specialists in the United States, we have both foot and ankle specialists as well as folks who just look at feet and don't have an MD but have a doctor of podiatry, it's called there. So they call it predislocation syndrome. The chronic inflammatory change at the capsule makes those supporting structures lax, and you start to see changes in alignment at the second MTP. So not only do you have the degenerative change of the hallux valgus, but now you start to affect the second, and ultimately that can move to third, fourth, and fifth. So the biomechanics here again, they win out. It's chronic, it's that chronic pressure. It's not something that's happening acutely. And in an exaggerated situation, it can look something like this. Hallux valgus, chronic pressure at the second with that second metatarsal really coming up and over, resulting in a crossover deformity. And so this is how they fix this. Proper fixation, looking at the tarsometatarsal junction. So they fix the metatarsus primus varus via an osteotomy. They shave the medial head, medial eminence shaving. They actually go ahead and repair the second with a resection arthroplasty and a capsular repair. So if we were to address these things earlier before we have the predislocation syndrome resulting in the crossover, much better situation for the patient. And in our last less than 2 minutes, I heard the big bell go off, so we'll move through the temporomandibular joint fairly quickly. So look here, here's your condyle. So that is sitting in the condylar fossa. The arrow here is showing you the disc. This is the condylar eminence. This articulation is amazing. This is an articulation that is meant to dislocate. Think about closed mouth to open mouth. The articulation completely dislocates. So in closed mouth position, the back, the posterior margin of the disc, should be at the 12 o'clock position of the condyle. You see it's displaced anteriorly here. Now, when we open, this is closed mouth on top, open mouth in the bottom. When we open the mouth, the condyle should glide forward and it should engage. It should be just underneath that dot, which is at the condylar eminence, and the disc should capture. So in this case, you see with open mouth, we don't have full excursion and the disc doesn't capture, it just gets pushed more forward. So this was a dislocated anterior disc in closed mouth position, limited excursion, no capture of the disc, and persistent dislocation of that disc with open mouth. Okay, if that was too fast and doesn't make sense, wait, I'm going to show you a few more images in just a moment. Okay, so there's condylar fossa. That's the movement that we see. One more example here. Closed mouth position. There's the condyle. There's condylar eminence. Again, we see the disc displaced anteriorly. Closed mouth. Open the mouth. Here in this case, look at the position of the condyle. It actually moves full opening to the condylar eminence and the disc captures. See, there's that little disc between condyle and eminence. Okay? So disc displacement in closed mouth position, capture in open mouth position, which then looks normal. Okay. Now, very complicated anatomy here. We're not going to go through all of that, but look what happens with opening of the mouth. The condyle glides forward and captures the disc. That's what should happen. Okay. And so I'll show you these just to really outline closed mouth position, condyle, disc 12 o'clock position, open mouth, condyle glides forward, captures the disc, and there you see condylar eminence. That's what should happen. Okay. Abnormal side, look here, displaced disc in closed mouth position. That disc should be at the 12 o'clock position. Open mouth, we capture, but not completely forward. Now, the trick with these from open to closed mouth position, did the patient really open their mouth fully, or did they only open it partially? So, that should be reflected in your report. And again here, similar to what we saw previously, disc displaced anteriorly in closed mouth position. In open mouth position, we don't have full excursion. We don't have the condyle engage the eminence, and the disc is still displaced. Not uncommon because the disc is sitting there and doesn't allow you to fully open your mouth. Okay. So there it is, just a little bit closer up, seeing that displaced disc, no recapture as you open the mouth. Okay. So take home points here really. The key in all these small articulations is to know the anatomy, to have a basic idea of biomechanics and commonly encountered pathology, and to understand really how ubiquitous, how many people suffer from small joint pain and injury. So hopefully that was helpful, and specifically for the TMJ, I hope it inspired you to go home and learn about and read more cases with TMJ pathology. So thank you very much for your time. This is my last lecture here. It's been a fantastic meeting, so congratulations again to Ankur and Rishi and to the societies. Really amazing quality of work and such a warm and welcoming group in all. So thank you so much for having me.
And we should also say thank you so much for delivering such wonderful lectures and clarifying all the concepts for us. Thank you so much.
Dr. Raj Chari, he's a consultant sports and musculoskeletal radiologist, Oxford University Hospital and Oxford Musculoskeletal Radiology. He's delivered the lecture on ankle, midfoot and imaging fibrosis, tunnel pathology and the subtle difference injuries. Thank you.
Thank you very much for the introduction and for this opportunity to talk. After that screaming last night at the Gerber, I didn't think I had voice to give a talk, but let's see how we go. So my topic is this, that we look at various fibrosis tunnels around the foot and ankle area, and we also look at some Lisfranc injuries. So in my talk today, we look at what the fibrosis tunnels are. We look at imaging, ultrasound, MRI, CT mainly. We will recognize some pathology, some common, some uncommon, and we will always correlate all these things with clinical parameters. Otherwise, imaging means nothing. So what are fibrosis tunnels? These are rigid tunnels, similar to your carpal tunnel. So there's bone on one side and there's fibrous structure on the other, either a ligament or a retinaculum that holds the important things like ligaments, important things like tendons, nerves, and muscles. And because of that kind of tight stricture, you can have stenosing tenosynovitis, compression, instability, so on and so forth. Around the foot and ankle area, we have several tunnels. Tarsal tunnel is a big one. Peroneal tendon tendons also go through a couple of retinacular forming tunnels. There is the flexor hallucis longus, as it dives into the foot, has its own little tunnel. There's anterior compartment, and there's a little cuboid tunnel as well. So you can use mainly ultrasound and MRI scan to evaluate these. Ultrasound is brilliant. It's dynamic. It allows you for intervention where necessary. MRI is fantastic with its resolution. You can see all the tendons, nerves, and bone-related problems very, very nicely. When there is inflammation, you can also see reactive osteitis. That's why MR adds a lot of value. CT, last but not the least, when it comes to trauma, which happens quite a lot around the ankle, CT can be very, very useful as well. Starting with the posterior tibial nerve that passes through the tarsal tunnel, various different things can cause a problem. Ganglions mainly from the subtalar joint, varicosities from the vessels, venous engorgement, accessory muscles can cause a problem, inflammation, and often degenerative changes. So tarsal tunnel is in the posteromedial aspect. The first big tendon is the tibialis posterior. Then we have the Tom, Dick, and Harry. So flexor digitorum longus, and then you have the neurovascular bundle, and then the flexor hallucis longus is slightly deep, but along the same line. And then what covers that is the retinaculum. Okay, that's how it becomes a fibroosseous tunnel. When you look on MRI scan, this is what it looks like. And then you have tibialis posterior, you have flexor hallucis longus, and then FHLs is slightly deeper while it goes and takes its own separate route compared to the other tendons. And you have the nerve slightly deep and the vessels on top. Ultrasound, sorry, slightly a magged up image there. I've just put the arrow while I took these images. The tibialis posterior sits very snug with the bone and very adjacent to the retinaculum. As we move, then we have the flexor hallucis longus, quite next to tibialis posterior. Very rarely you have a problem. Usually it's the tibialis posterior, much smaller in size. And then as we progress, we have the vessel, and then you have the tibial nerve, and then you have the flexor hallucis longus deep below. So we look at some cases, okay? So this is an example of ultrasound and MRI scan. Happens to be my wife's foot. So you can clearly see some anechoic abnormality within the tarsal tunnel, sitting right next to the tibial nerve. And put the Doppler, it confirms that these are vessels and not potential space occupying lesions. When we did the MRI scan, it obviously confirmed that the ganglion cyst is by far the commonest cause for causing a tarsal tunnel syndrome. Now I can fairly confidently say there are two things that get on my wife's nerves. That one is a ganglion cyst, the other one is obviously me. So the other cause that can happen is peripheral nerve sheath tumor. They're fairly common in that area. You can see there is the hypoechogenic lesion. Looks very similar to the ganglion cyst, but there is some internal structure to it. And then you can clearly see it is sitting right next to the tibial nerve. So it was a peripheral nerve sheath tumor, again causing tarsal tunnel syndrome. Here is an example of the thickening of the retinaculum. This is a previous injury of the retinaculum where it's thickened and scarred. And you can also see how there's venous engorgement in that area. So you can say clearly that there is increased pressure in the tarsal tunnel. That's an example of a hindfoot valgus, the significant degenerative change. When you have all the degenerative change and you have altered alignment, you can clearly see how the structures have displayed, completely splayed from one another, tibialis posterior and the flexor hallucis, and the neurovascular bundle is medial to the flexor hallucis longus, so there's increased pressure in the tarsal tunnel. So this was an example of a case where we saw significant posterior osteophyte formation from the degenerative change of the subtalar and ankle joint, which is sitting against the tibial nerve and causing nuisance. And this is another example kindly given to me by a colleague from Abu Dhabi. We included in the publication, where you see, you guys see this quite a lot, significant thickening of the tibial nerve, increasing the pressure within the tarsal tunnel with a case of leprosy. This we see quite a lot, tibialis posterior tendon being knackered, tendinosis, dysfunction, with flat foot, for example. That's the typical appearance with or without interstitial tearing. And you see lots of fluid around the tendon. When that happens, again, that takes more space within the tarsal tunnel, and that can cause tarsal tunnel syndrome. Moving on to the other tunnel system, which is on the posterolateral aspect, which is peroneal tendon tunnel. There are two tendons, as you all probably know, and they also have two retinaculae. They can also have tendinosis, tear, or they can have subluxation or dislocation. So here you have the two tendons, the peroneus brevis, B for brie, sits close to the bone, and you have the longus going right next to it. And the retinaculum that we all know, just right behind the genu, is the superficial retinaculum. And then as it goes forwards, there's another retinaculum which has two bands and separates the two tendons. Beyond that, the tendons take their own course. So again, you can see how you could have stenosing tenosynovitis. Again, this is how the tendon looks normally sitting within that retinaculum. So here it is, the tibialis, the peroneus brevis and longus tendons, as they come together, they curve around. The brevis then goes and sits next to the bone, and then often when they make that turn, it's almost inseparable. They're together, but you can clearly see two tendons separately, and then you can see the retinaculum nicely with the tendons sitting right next to them. And as we go, then we can start seeing them separate, and then clearly separate, and the longus goes under the cuboid, brevis goes forwards. So here there is a case of a trauma. Okay, you can clearly see there is a fracture. There's a slither of bone. So here that was an avulsion fracture of the retinaculum. It's great. What's another important thing is that you always look at anything given in trauma in your bone windows and soft tissue windows, and you can clearly see the peroneal tendon is stuck. If surgical colleagues go and put a suture through that, that's not a good news. Okay, that's another example of bulbous thickening of the peroneus longus tendon. But as we go south, you can see there is no tendon, and the bulbous thickening of the tendon is right up there. That's an example of peroneus longus complete tearing, degenerative tearing. This is another case of trauma. You can see there's a calcaneal fracture. There's one of my favorite teaching points. When you do ankle, definitely make sure look at the soft tissue window. Clearly see the peroneal tendon is dislocated. Okay, that's an important finding for us to pick up and report to our colleagues. So this is an example. This guy was a runner. He hadn't run for 5 years, believe it or not, because of severe pain. So then I did a dynamic imaging. You see, there is peroneus longus here. Peroneus brevis is split into two bundles. See what happens. There is internal subluxation of the tendon. The tendon rolls within. So as it happened, the foot and ankle MDT was going on in my department. I went and spoke to them. Come on, I'll show you something here. And they come and they wouldn't believe me, obviously. And then they said, why don't you put some local anesthetic and see what happens? I just put some bupivacaine, and that guy ran after a very, very long time. And they came back to me and told me that. Otherwise, I wouldn't know. So that's an example of internal subluxation. You can have internal subluxation or external subluxation, including dislocation of the peroneal tendons. Okay, let's come on to that. Sorry. Okay. Clearly, you see there is synovial proliferation within the joint and along the surrounding tendons, significant disease load. The two peroneal tendons are going through, and you can clearly see how the retinaculum is completely destroyed. The whole area is studded with this is an example of tenosynovial giant cell tumor of the ankle and that of the peroneal tendon compartment. Here is an example. I think we saw the same case earlier. So earlier I showed you the tarsal tunnel area, but look at the lateral compartment. When you have a valgus deformity, look at the tendons carefully. There could be discrepancy between the bone and tendon anatomy. It's completely dislocated here. So the retinaculum is completely gone. So that's very, very important to pick these things up. So there are some variants, as one would know. There is a peroneus quartus here, and then there is a peroneus tertius in that area. Moving on to the flexor hallucis longus tunnel, which is a tunnel right under the cestus tachyon tali. we can see a couple of abnormalities that can potentially happen in that area. Here, the tendon that comes down and goes right under the cistern tachyantale, and that's where you have that little tunnel formation, and that's the normal appearance of the tendon. Tendon always sits together. But what we also should know, it's not unusual to see fluid, because we know that there's a physiological connection between the ankle joint and the flexor hallucis longus. So that should always be taken with caution, and you look at what's going on in the ankle. If there's abnormality in the ankle, have very high threshold to call FHL problems. Having said that, again, go back to the same case. You see some fluid within the flexor hallucis longus there. Again, I want to look at the ankle. It doesn't look very happy. Probably this is to do with the ankle rather than FHL itself. That's an example of for me to demonstrate that how FHL can be connected to the joint. Here clearly you see the synovial chondromatosis, and then the little bodies have gone along the flexor hallucis longus, which we see quite a lot. Even the tenosynovial giant cell tumor can do this. Quite common in footballers and ballet dancers who tiptoe quite a lot, the posterior impingement of the ankle joint with presence of os trigonum, or you could have stiada process, and typically involves inflammation where the PTFL attaches, and what that does, it causes reactive tenosynovitis of the flexor hallucis longus tendon before it enters its own fibroosseous tunnel. Here you have I don't know why I put this here, but this is supposed to be in my peroneal section. What's happening here is you see the significant osteitis. The peroneal tubercle should not be that prominent. Okay, so and you can also see that both the tendons are not very happy at all. This is a surgical case of peroneal tenosynovitis or tendinosis. That's because of prominent the peroneal tubercle. You can inject all you want, you will just knacker the tendon. This is a proper surgical case. Moving on to the compartment anteriorly, extensor compartment. There you have Tom, Harry, and Dick. Now tibialis anterior is the main tendon. Then you have the hallucis longus. Then you have the neurovascular bundle, which is deep peroneal, and then you have the last tendon, which is the flexor digitorum, which splits as it goes along, and you have a very broad retinaculum anteriorly, like you see there. Okay, the three tendons sitting there, the neurovascular bundle deep there. Ultrasound, same thing. The big tendon that you see medially is the tibialis anterior. Then you have the flexor hallucis, and then you have the digitorum right there. Okay. So we look at some cases. Here you see that the tibialis anterior is significantly thickened with internal signal change, and this was a case of tibialis anterior tendinosis. This is one of my rare cases. What I usually find in my clinical practice is tibialis anterior tendinosis of tenosynovitis. It's a lot more distal. You see them quite a lot in the midfoot. Almost they present as tumor cases sometimes. So that you should be mindful of. This is another case where the tibialis anterior is significantly thickened, and you see carefully, it's thickened because it's bulbous expansion before it enters the retinaculum, and it's already torn. Okay, this is a representative image because I forgot to save the image that I saw about 10 days or 12 days ago, or before I left. There was significant thickening of the retinaculum in a person who had a skiing injury. Now that's my family skiing. We ski quite a lot, and that's ski boot. There's no way you would sustain an ankle injury with ski boot on, because that's how they're made. But maybe his ski boot was loose or whatever. They didn't have a fracture, but then the force vector would have gone through the retinaculum and then they're sheared, and that can potentially happen. And this is a very rare case. That's an example of an osteochondroma, also called as a Travers disease of the tibial plafond. What that's doing is pushing the structures forwards and again causing the extensor compartment syndrome. Here is a case of an osteochondroma, and that is also causing same thing with a bursa formation this time. Okay, and this is another rare case where there's an osteoma causing significant increased pressure in the extensor compartment. That's an aneurysm of the dorsalis pedis. Again, it's just an abnormality within the extensor compartment. That's an example of a slipped tibial plate, a plate of the total ankle replacement, again pushing on the deep peroneal nerve, causing significant neurology. Last is the cuboid tunnel, where you have the FHL going through. Again, I've told you it's not abnormal to see some fluid in beg your pardon. Cuboid tunnel is the peroneus longus. Okay, you can clearly see in this case the peroneus longus as it curves forms that tunnel, but you have that significant edema within the os. That's the POPS, painful os peroneal syndrome. Okay, some less common lesions. I think I've quite a lot to cover here. I won't take your time. I will just move on. I think I've shown quite a lot of these already. I'll go to my last topic, because I've been asked to cover the Lisfranc. Lisfranc has got nothing to do with the fibrosis tunnel. It's as if I joined this photo. I've got nothing to do with this beige women just because I was wearing beige yesterday. Anyway, Lisfranc ligament. There are 3 ligaments: the dorsal, proper, and the plantar. Plantar has 2 bands going into the base of second and third metatarsal. What's important is this kind of hat kind of configuration of the second metatarsal. That's why the injuries happen. And then the dorsal band you can see, that's normal. And then you have the proper Lisfranc band, you can clearly see there. And then plantar, slightly difficult to find. You can see 1 band there and the second band going in there. You can also appreciate that band there. And this is just a subtle injury of Lisfranc, just a grade 1 injury to the Lisfranc ligament. The alignment is maintained. But here it's not so. The alignment is altered. You can see the lines that we draw are moved, and there was an avulsion fracture of the attachment of the Lisfranc ligament area. And here it's similar but a lot more serious. There is now avulsion of the plantar attachment. You can clearly see the fractures of the base there, and that was fixed accordingly. And that you should also be very careful and look at the fractures on the other side of the Lisfranc ligament, and you see there is some bone fragment in there. The interosseous ligament is also gone. This is a lot worse example where alignment is completely gone, and that needs potentially fixing. Now, imaging pearls: assess, trace, look, and correlate. Okay, assess everything that's given to you. Trace everything up and down. Tibialis anterior is a typical example. You look for other things like accessory structures we've seen, and you correlate with the site of maximal symptoms. Know your anatomy, know your imaging modalities, recognize all these imaging entrapment patterns, and put a structured report. The next MSS is in Kolkata by Team Kolkata, Srijita, and everybody else. Please be there if you can. Thank you very much.
Thank you, Dr. Sally. That was a wonderful lecture. We move on to the next lecture, which is on whole body imaging, challenging gold standards in unraveling systemic malignancies. And to deliver this lecture, we have Dr. Jairaj Kovidraj sir coming over. He works at the Apollo Hospital in Chennai and has been the past president of the Musculoskeletal Society India.
Thank you very much, Dr. Joshita, for introducing me to this wonderful audience. It's packed today, the last day of the session, and still we have everybody so interested in what we have to say. So without much ado, I go ahead and thanks for all the AMS faculty and everybody, the ISS people who have come here today, and we are really honored to have you here with us and make this an enriching experience. So the topic that I'm going to cover today is the whole body MR imaging, which has been now given a different kind of importance. So in today's world, especially in oncology, we ought to look at certain things. Why is it so important? Well, you are looking at the entire body of the human system. And what are the modalities we have on hand as radiologists, and the indications for doing this whole body MRI, not only as oncology applications, but also to identify several other systemic diseases within the patient. And then we look at the clinical applications with some cases. So cancer is a leading cause of global mortality, and we all understand that, but many categories of cancer are unattended. Established single cancer comprehensive scan methods are available, but for all this we need to have a robust, reliable screening program, and to get to the diagnosis of cancer much early. There are certain individuals in society who are predisposed to multiple cancers, what you call as multiple cancer syndromes, and for them, the whole body imaging would be a very good screening tool. We all start working towards it, and when we have such wonderful modalities on hand, we have the PET-CT, the PET-MR, the whole body MRI has been given a very big importance because it is non-invasive method of non-ionizing technique that we have, which would give us the answers. So in cancer staging and response assessment, PET-CT and PET-MR is most often used. It also defines some of the metabolic and anatomic information of the tumors, and repeated scans needed for follow-up for treatment response. Over here, the ionizing radiation that the patient is repeatedly subjected to and cumulatively increases over time might go beyond the expected thresholds. So that is why there is an increasing risk of radiation from these ionizing radiation modalities that we have in hand. By and large, whole body MRI has been preferred as a one-step comprehensive assessment of looking at all the multiple organs, and not only the organ systems alone, but also particularly with reference to the musculoskeletal, and especially in primary bone tumors and systemic manifestations of myeloma, sarcoma, lymphoma, and the multiplicity of lesions can be picked up, especially in metastatic disease from other primary areas. So it is emerging as a cancer screening method in genetically predisposed in cancer averse patient. We have certain kind of patients who are asymptomatic, normal, but within their head they feel that they have cancer. And very many years ago, as I started my career, we had a lot of people coming and asking, can you see something in me? Can you do a whole body scan? And that is what they want. But today we have the option of doing this whole body MRI and coming to some thing. So standardize the protocol of MRI. We recommend that it is basically an unenhanced MRI scan, because you don't really have to do any preparation for that. The basic T1, T2 and stir sequences, which will relate to the anatomy, characterize the lesions and locate the problem very easily. And the T1 weighted Dixon technique of relative fat fraction imaging would give you all the answers. And a division weighted imaging at multiple B values will give you a good amount of information about the tissue cellularity, and which indicates the malignancy with impeded diffusion of that area and out. So the duration of the entire thing would be 45 to 50 minutes if you go through all these techniques to attend to the entire body. So we have to prepare the patient much beforehand and tell them that this is how you have to be, and quite now keep very still for during the process of the imaging. So in oncology, we use it for staging, restaging, treatment response monitoring, and the detection of recurrence. The multiple cancer detection and screening programs would also be a part of the whole body imaging. Over the years, there have been many articles that have started looking at population screening for cancer, particularly not necessarily for musculoskeletal cancers, but for the other cancers that we have on hand. And people were subjected to this particular study by one Dr. Padhani in 2026. He's given this particular thing, that if you have a general population and use it as a general screening method, only about 1 to 2% of the cancers that are available can be detected by the whole body MRI. So using the time that is provided for the patient on your scanner and the value that we get out of doing a whole body MRI, would it be justified in doing a whole body MRI screening method for cancer, was the big question. And American College of Radiology has clearly stated that in 2025 that whole body MRI is not really recommended for the detection of cancer, but still a lot of longitudinal studies are needed to see whether it is really, really important. So we have tailored it down to the screening of people with high risk of cancer. So these could be older adults. So you tailor down the indications. In an increasing geriatric population, this can be quite a big number. those with risk factors who have been chronic smokers, excessive alcohol consumption, oncoviruses infection, and then specific occupational exposures or genetic predisposition to cancer. They sometimes will also have the additional features, the clinical features is so important here, unexplained weight loss, constitutional complaints, or persistent and progressive pain in any part of the body system. So then these are the high-risk individuals in which you can do the scan and probably get positive answers. So what are the advantages that we have? It's a single session evaluation, a one-step assessment, and does not involve any radiation at all. Assessment of the disease burden can be judged and evaluated. Improved treatment planning is also performed, and it's beneficial for patients who need repeat examinations. For example, people who are on follow-up of a treatment that is going on, so the treatment response, especially in the pediatric and the young adults, we have to keep them off the ionizing radiation cumulative effects. So the limitations that we can think of is the cost and availability. We really still have to go forward on that, and looking at the false positives and false negatives, these are yet to be outlined and defined. There are many areas that are blind spots in the whole body MRI. We have to look closely. We need more longitudinal studies, need for standardized protocols. Now that's something that everybody is attending to. In fact, in the previous lecture, the European Society of Skeletal Radiology has been insisting that we have standardized protocols to follow the same kind of imaging to get to the actual results, which are reliable and reproducible. So the sensitivity is high, but the specificity is low. And so especially we have to think of cancer screening and cancer detection, cancer staging, treatment response. Whole body MRI will have certain limitations. We are still not able to differentiate infection, inflammation, and some of the benign systemic tumors. And nowadays, with molecular genetics coming up, looking at P53 and PIK3 mutations, we might have to include that in the diagnostic armamentarium of whole body MRI. To cover all these points, I have a few cases which the first one is a 78-year-old male, known case of multiple myeloma. And in myeloma, the gold standard is whole body MRI imaging. And after this chemotherapy that he's had over several years, he doesn't have any symptoms, but on regular follow-up, we have done the whole body MRI. And these were the type of images that we have to deal with, apart from looking at the entire skeleton as well as the lesions that were seen. Can we have the pointer? Oh yeah. We can see that these have to be looked closely at, particularly in the L4 vertebrae, and you can see them also in the iliac bone as well as in the upper end of the femur, just next to the lesser trochanter. And with these various sequences, we've come to a conclusion. The entire thing takes around 30 to 35 minutes in our scanner. This is dependent on the time availability of your schedule. And you can see that this particular images have given us an idea. This is especially the DWIBs. You can see that the increased signal intensity in this area is telling that this particular lesion is quite quiescent. It is not changed over the previous scan, and the zoomed up areas will also tell us where the lesion is at C3. You can see that particular hypointense signal. The presence of left cervical lymphadenopathy in the same manner over a period of years has clearly showed that it is not an active lesion. So compared with the previous PET-CT scan, the whole body MRI gives us the idea that this is a stable multiple myeloma with no interval change. So that's the value that we are not subjected the patient to another ionizing radiation by doing repeated PET-CT or repeated, we have particular nuclear medicine isotopes which are specific for multiple myeloma, but we opted to do the whole body MRI. Here's the example of a pediatric case in which a 12-year-old, not wanting to have subjected to any ionizing radiation, we did the whole body MRI and compared it with the PET CT, because during the course of the treatment, they need to be seen every 3 months. 3 months, 6 months, 1 year, like that it goes on till we achieve a full complete remission. And in this case, we have seen that the lesions have been stable and not increasing or showing any new fresh lesions which can be picked up. These are the old ones that was seen in 18 March, and a similar kind of thing done with a non-contrast whole body MRI. So there is no evidence of active disease anywhere else in the body, so we considered that this patient is in remission. Now we go to another case, that is a 12-year-old male, a child with Hodgkin's, and people with Hodgkin's lymphoma also need a constant repeat evaluation of their disease processes under treatment. And since the prior MRI done 6 months ago, there were no significant changes, we have done the next MRI, which is the whole body MRI, and we find that again the lesions that were seen earlier are not very well seen now, and this is saying that the Hodgkin's lymphoma is in remission. So we found this as a very useful tool to apply to pediatric population, and thereby we were able to get a good amount of information, reassure the patient, and continue with their follow-up. So we go on to the next case. I think these are all stable cases. It is useful, especially in primary bone tumors, which we haven't yet in our hospital started using for primary bone tumors. Whole body imaging, this is a borrowed slide. A comprehensive single visit staging, nodal and skip lesions can be detected, and extraskeletal disease screening can be also done in a whole body MRI, as is evident here. And here's yet another case that was given to me, courtesy Dr. Rajesh, and these are lesions that were compared to the previous PET CT, and we followed them up and found that there is no evidence of additional metastasis. It's a primary bone tumor restricted locally, and the treatment was also beneficial for the patient. Over here is yet another case where a similar kind of a case, but we have a soft tissue deposit seen in the opposite side, and so the staging is also possible with a whole body MRI. Yet another case where a right knee osteosarcoma was there of the right femur, and the whole body MRI detected lesions in the lung, which was then again checked out with a CT of the chest, and thereby the patient was identified to have lesions and staged properly. So we go on to the high sensitivity for detection of lesions in bone marrow, liver, and soft tissues. The whole body MRI is very useful. It's helpful in diagnosis and staging of primary bone tumors, and then of course useful in preventive health screening as a multi-cancer tool. Asymptomatic patients seeking in the preventive health assessments focused on overall well-being can also be subjected to a whole body MRI. A standard MRI protocol is much needed for optimal cancer screening, and the concept of OncoRads with a 5-category approach has been defined in this human paper by Dr. Padani in 2026. These are the things just like the BIRAD score and the other RAD scores that we have, OncoRads 1, 2, 3 and 4, as is evident here, and is to be followed whenever we report, especially for malignancies, whole body MRI, the OncoRad score would be a useful indicator. So there are some benefits and there are some deterrents. And of the deterrents, I wish to emphasize that there can be an overdiagnosis and overtreatment. Many false positives and incidental findings can cause an increased patient anxiety. And after all this, are we justified in using whole body MRI as a screening tool? So this would be the future directions where AI assisted interpretation, quantitative imaging biomarkers can be fused with the results. Hybrid imaging advances, whole body MRI could still become a multi-cancer detection tool in future with further longitudinal studies and can be included as a preventive health screening program. So in conclusion, These are the basic key take-home points that I'd like to say. Whole body MRI gives you the benefit of not having an ionizing radiation to the patient, not subjecting them to repeated examinations. But in whole body MRI, you can do it any number of times. It also is a one-step assessment of the entire body and particularly the skeletal system with a high spatial resolution. And it is beneficial for certain categories of people. As of today, the screening program is not advisable, and so we have to take the recommendations of the American College of Radiology and just not use it, only use it judiciously for high-risk individuals. So thank you very much.
Thank you, Dr. Jairaj, for the excellent information. May I call Dr. Nizar for the next lecture regarding the emergencies in MSK radiology. Dr. Nizar is the Professor of Intervention MSK Radiology, Faculty of Medicine, PSU, Saudi Arabia, and areas of interest is intervention and musculoskeletal radiology. Major achievement is like over 60 plus international publications and author of 3 reference books. Please, sir.
Thank you, Mr. Chairman, for the introduction, and Mr. Chairman, and thank you for the AMS for the invitation, and thank you everybody for sticking around in this busy morning session. I feel very humbled coming to speak after such great distinguished speakers. I hope I rise to the occasion. I'll be talking about something very basic, which is musculoskeletal emergency, but rest assured, basic does not mean less important. Most litigations happen with these basic cases. Medical legal cases, as you all know, come with musculoskeletal emergencies, as in other emergencies in the body. By the end of the list, we'll be able to recognize any life and limb-threatening MSK emergency, choose the correct imaging modality, interpret the emergency radiograph, avoid the diagnostic pitfalls, and report the findings in a language simple to the clinician and as well to the patient as well. We'll be taking 11 stops through this journey. I'll be giving you an introduction, the missed fractures, the tendon and ligament injuries, soft tissue emergencies, bone and joint infections, as well as spinal emergencies, going through pediatric emergencies, vascular emergencies, and emergency ultrasound. So stick around, so be quick blast through this talk. So musculoskeletal emergency can happen and account for a large of emergency cases in the emergency room. Many true emergencies happen, such as necrotizing fasciitis, coda equina, and compartment syndrome, and have a very narrow window for you to interpret and to conduct your message to the referring physician before irreversible damage happens. So radiologist is frequently the first clinician to recognize the emergency before the team knows about it. So MSK imaging is most among the sources of misdiagnosis and litigations, as I mentioned before. So the pearl is treat every occult MSK complaint as an emergency until proven otherwise. The cost of a repeat MRI is sometimes trivial next to a missed coda equina, for example. And the pitfall is assuming a normal radiograph excludes emergency, and it doesn't sometimes. Many nights are due to missed emergency radiographs. So we're going through all the modalities quickly. Radiographs take seconds to be done, and it's good for fractures and dislocation screening and alignment. However, it's insensitive for occult fracture. On the other hand, CT takes only minutes. It's good for complex pre-planning operation and gas detection, but it has limited soft tissue marrow contrast resolution. MRI will take you a little bit longer, up to an hour. It's good for occult fractures, infection and coda equina syndrome, and tendon ruptures, but its time availability and cost are quite high. Ultrasound, on the other hand, is real time. Very good for tendon rupture, abscess, effusion, and Doppler, as well as foreign body detection. However, as you all know, it's operator dependent and limited bone penetration. So we'll talk quickly about missed fractures. Occult hip fractures is the most common to happen, especially in elderly patients, such as this example here of a 60-year-old female fell off the stairs with severe hip pain. Radiograph shows absolutely nothing. Do an capability of an MRI, which is next door in our department. We did it, and we found this extensive bone marrow edema, which is an occult fracture. So again, another option is CT, but CT sometimes will not detect it as well. So a patient who cannot bear weight after a fall with a normal X-ray, try to get an MRI before discharge, at least in this admission. Scaphoid fractures was another thing that we always look at, and remember the Galula's arch. The Galula's arch are sometimes that we need to see them aligning very well. If they're not aligning well, or the patient still has pain at this anatomical sniff box, treat it as a fracture. Either do more imaging or stabilize, put in a splint and repeat imaging, or get a CT scan or MRI. The other worrisome thing is the lunate and perilunate dislocation that can happen with a Fuchs injury following a stretch hand. So get lateral views and make sure that the capitate is aligning. Lisfranc fracture, Dr. Raj went through the Lisfranc fracture and ligaments extensively. However, one of the things that I'd like to elaborate is the sign that we see, the lines that we go through. These are very basic lines. The first metatarsal bone has to align with the medial cuneiform, and the second metatarsal line has to align with the mid cuneiform bone, and the fourth metatarsal bone has to align with the cuboid. So this is an example of a Lisfranc fracture dislocation, extensive. Notice these tiny fractures that sometimes you can see only on the AP view, and these are consistent with a tiny avulsed fracture that you may sometimes just say it's a trivial fracture, but it's actually a very heavily bad fracture, Lisfranc fracture, and cause for high litigations. Talar neck fracture and posterior dislocations are one of the other occult fractures that you want to look for. With talar neck fractures, you see that the talus does not sit symmetrically in the ankle mortise, and there's a fracture through the neck. This is not an occult fracture, however, it's a devastating fracture that you don't want to miss and you want to describe extensively. One of the occult fractures is posterior dislocation with the light bulb sign, which is a very nice here. You don't think there's a dislocation. If you don't get this Y view or tangential view, then you will not detect that there is an actually posterior dislocation. And this patient is a very young patient, like 25 years old, who had seizures. And with seizures, as you all know, we get the posterior dislocation. So history should light a light bulb sign in your head, as well you get the light bulb sign on the radiograph. We're moving on now to tendon and ligament emergencies. The quadriceps and patellar tendon rupture can happen with extensor tendon rupture mechanism failure. The patella is dislocated high in patella baja, not baja, which I used to say in my first year residency. Then my supervisor said, baja, you idiot. So I kept keeping the torch with my residents saying, it's not baja, it's baja. So, it suggests quadriceps rupture. Patella alta, when it's going high, and it suggests patellar tendon rupture. And ultrasound is fast, dynamic, gets the diagnosis done quickly. MRI, of course, is better to evaluate other problems, and always report the gap in millimeters so the clinician knows how fast he should go in or out to surgery. And measure the state of the tendon, and missing a partial thickness tear because the tendon looks continuous on a single view is not good. So this is an example of here. You can see the patellar tendon is gone, and this is the quadriceps tendon is gone. You can confirm by MRI, quadriceps tendon rupture, patella. Anybody? Yeah, baja. And on the other hand, this is patella alta, where the patella is going up high, and patellar tendon is completely ruptured and gone. Achilles and tendon rupture, distal biceps tendon and pectoralis major tendon rupture can happen, and this is an example of a pectoralis major tendon rupture, the sternal head. We see them a lot in patients who are bodybuilders using a lot of steroids to buff up. Suddenly, when they're doing the chest press, the tendon just flips and cuts off. See it on MRI very nicely, the rupture of the sternal head of the biceps tendon. And it's very gruesome when you see it on clinically. There's a dip in the pectoralis major muscle. So if they're looking for bodybuilding, my advice to them is always stop using the steroids, just buff up while doing your hard work. Now, Achilles tendon rupture, you can see on a plain radiograph that there's a lot of edema or hypodensity in the plain radiograph. An ultrasound done shows a gap in the Achilles tendon, which is consistent with a complete rupture of the Achilles tendon, and MRI confirms rupture of the Achilles tendon. Ruptures of the long head of the biceps tendon, with the long head of biceps tendon at the elbow region connects to the radial tuberosity. So you can see that there is discontinuity of the biceps tendon distally away from the radial tuberosity, confirmed with MRI. Soft tissue emergencies, the most common is necrotizing fasciitis, and it is one of those, call the physician, don't wait to send the report because it's life-threatening condition. You can see the bubbles of gas in this patient who had a for cosmetic reason butt lift, and 2 days later had this necrotizing fasciitis. So surgery for something cosmetic and very not necessarily resulted in a very, very devastating condition of necrotizing fasciitis. You can see the bubbles of gas and emerging abscess happening in the gluteus muscle. And pyomyositis, abscess, and Morel-Laville lesions can happen. And in this case here, we have a patient with septic arthritis, collection confirmed with ultrasound to be in the hip joint, as well as myositis in the gluteus muscles and in the posterior muscle compartment. Morel-Laville lesion is a degloving lesion, and it usually happens in the thigh surrounding the hip joint, the greater trochanter, and as you all know, it's a degloving lesion. You can see a cystic lesion that happened due to the avulsion that happens. Compartment syndrome usually happens with previous fracture or a significant trauma to the limb, such as in the radius ulna or in the tibia and fibula, and is another emergency that requires quick fasciotomy and to save the limb. And sometimes you should, the clinician should not wait for the MRI to happen, so just in case it will lose the limb. Patients who are having poorly controlled diabetes is another issue where we can get diabetic myonecrosis. This diagnosis is on the rise and it causes severe limb pain. So diabetes, as in any other small or medium vessel disease, will get the vessels thrombosed. Similar to MI, you get a muscle infarction, which happens usually in the thigh, and is diagnosed clinically but confirmed with MRI as muscle edema and infarct of the muscle. Bone and joint infection, as you all know, septic arthritis versus acute osteomyelitis. Septic arthritis occurs in hours and destroys the joint, whereas in osteomyelitis it takes days. In septic arthritis, there's a joint effusion, and in acute osteomyelitis, there's marrow T1 hyperintensity and stir hyperintensity. Adjacent to is periarticular edema, whereas in osteomyelitis, there's a cortical breach. Best sequence is post-contrast fat sat, and in acute osteomyelitis, we are now using, as you all know, diffusion weighted images and contrast images. This is a case of septic arthritis of a very weird position to have septic arthritis in the symphysis pubis, extending into the muscles, causing pyomyositis. So, waiting for the MRI sometimes in this case is probably advisable because it's an unusual case. But usually in other situations, best way to diagnose septic arthritis, as you all know, is to put a needle in it under ultrasound guidance, send it for culture sensitivity, start the patient on antibiotic empirically, and then wait for the results of the culture sensitivity. Spinal emergencies, the most common, as you all know, is the Code-Equina syndrome, which we're compressing on the fecal sac, and getting an MRI is very important. The clinical triad of saddle anesthesia, bladder, bowel dysfunction, and bilateral leg symptoms happen. MRI without contrast is usually sufficient. CT is not the way to go, just to say because it's quick and easy. No, MRI is the way to go. and you have to measure the degree of the thecal sac compression and call the on-call spine surgeon immediately when you see it. Epidural abscesses and tuberculosis in these parts of the country, including Saudi Arabia, is endemic as well. And this is what you see. It's not quite the biggest emergency, but it's one of the things that you want to report if you see cord compression and cord signal abnormalities associated with the epidural abscess, discitis, and Pott's disease. Pediatric emergencies are different bones, different rules. One of them, as we just seen, is the septic arthritis in the hip joint, for example. And these patients are usually irritable, not weight-bearing, and ultrasound is the way to go because there is no radiation and it gets you the diagnosis quickly. Slipped capital femoral epiphysis. Anybody knows this line? The line here called is? Yes, correct, Klein line. So it should intersect. If it's not intersecting, then it's highly suggestive of slipped capital femoral epiphysis. Next step is to get frog leg views. And look at the patients. They're usually teenagers or 13 or 14-year-old who are obese who get this. So look at the other clues in the films. Battered child syndrome or syndrome X is one of the child abuse cases when you look for the rib heel fracture, the corner fracture, and the unusual periosteal reaction. Just 1 minute, please. Vascular emergencies, when you get pseudoaneurysms and the pseudoaneurysm causes a hematoma and usually associated with a fracture. The musculoskeletal radiologist is one of the first guys to detect these because they are looking at bones and then they're looking at other things in the emergency department. So the other is the catastrophe is posterior knee dislocation, and these cases can be easily missed on the AP view if you don't get a cross-table lateral view, and the cross-table lateral view. This is the picture that you see. You immediately go and get a Doppler to make sure there is no compromise on the popliteal vessels. So emergency ultrasound is the fastest tool in the department. It can do joint aspiration, detect foreign bodies, can do tendon ruptures, muscle tears, but there's a pitfall zone in the deep structures. And so the scan can be done immediately, dynamically, bilaterally to compare sides. However, the reporting of a tendon as intact on a single static image can get you into trouble. So sometimes it's best to report and recommend MRI if clinically feasible. So emergency reporting, the last few slides, 5 habits on the report that has to get acted on. The state of the final diagnosis first. Quantify, don't hedge. Name the next step on your imaging. Phone the critical findings. And finally, document the call. I put it in the report that I contacted Dr. So-and-so at the time and date. Thank you very much.
Thank you, Dr. That was a really wonderful lecture. And we move on to the next lecture, which is musculoskeletal diseases in people living with HIV. And to deliver that lecture, I call upon Dr. Nataya to come over and speak on her experience with this topic.
Okay, and thank you for having me here, and just a great pleasure and honor to be here and sharing with you the case and the situation of people living with HIV. And I have no disclosure regarding to this talk. And this talk, I will show you the overview of current status of this disease and show you some representative case, both infectious and non-infectious condition. So we just start recognize HIV infection in the year in 1980, and the disease was dreadful, fatal, but it changed a lot when we have antiretroviral drugs. So after the treatment, it changed the disease from dreadful disease to controllable disease and reduced mortality. And with this, this is the prediction of this disease within next 20 years. We will have less new cases, have less death rate, but we have people living more because they can survive. And so right now, it's estimated that roughly about 40 million of people living with HIV, and most of them can access to antiretroviral drug. So with this treatment, the successful treatment let them survive from opportunistic infection and live longer. How can they live longer? This is the life expectancy of people living with HIV. In some area, like in the Caribbean, is approach 70 years. Or in some North America, is comparable to normal population. So this is how they live longer, and with their physiological change, is not just only immunocompromised, but is immune dysregulation. So it can trigger autoinflammation, chronic inflammation. Certainly it's risk of opportunistic infection, but it also causes some aging, treatments, or HIV-related musculoskeletal disease, including osteonecrosis, some autoimmune disease, or some muscles or bone weakening. So when we look at the problem regarding to musculoskeletal problem, avascular necrosis is one of the leading cause. Certainly, we still have infection and inflammatory arthritis. And when you look at rheumatoid disease, they have 3 times higher incidence of inflammatory disease, joint disease, and seronegative arthropathy is the leading cause. And this is the data from my department looking over 20 years, looking at the distribution of infectious disease. Certainly, bacterial infection is one of the most common findings. And when you have declining of immune status or CD4 count, you have more atypical infection. But it's interesting that tuberculosis is one of the most common disease because it's relatively sensitive to CD4 decrease, and it can occur in moderate to severe immunocompromised status. So it's one of the major problems in HIV infection. So let's look at some example of bacterial infection. This is a man who has like a moderate level of immune status. It's the typical findings of septic arthritis, narrowing of this joint space, pararticular abscess. So typical like any other general population. But for the patient who has lower CD4 count, this is nocardiosis. And we have osteomyelitis with destruction of bone, periosteitis. And on MRI, you can see disseminated extensive pyomyositis and abscess everywhere. So this is a kind of severe infectious. In very severe immunocompromised host, like in this lady who has only 2 cells. So this is a heterogeneous signal abnormality within muscles and showing some nodular enhancement in paraspinal muscles. And this is the biopsy. When we see fungal myositis, fungal is everywhere within muscle cells, but no inflammatory response because there's no cells to respond to this infectious disease. With the same, quite similar preclinical presentation, this man has chronic proximal muscle weakness for 3 months, but actually he has very good treatment with antiretroviral drug, and his CD4 count is high. So this turned out to be a treatment related. We have biopsy proven that it's a toxic myopathy. We believe it is the toxics from antiretroviral drug. So you can see abnormal muscle signal but this muscle is atrophy with fatty infiltration. So it can have similar pattern depending on the immune status. Let's move forward to this case. He has a maternal transmitted HIV infection with T cell quite low, and we found multiple osteolytic lesion in his bones. And clinical presentation first is because he has high fever and leg pain, so it's suspicious for osteomyelitis. But if we look around, we can see multiple signs of bone destruction as well as soft tissue around the orbit. So this turned out to be Burkitt lymphoma. In HIV infection, it's not just only you have predisposing to infection, but T cell also eat cancer cell. So you may have HIV AS-defining malignancy, which is Kaposi sarcoma, or some aggressive type of lymphoma, including Burkitt lymphoma. Or the patients may predisposing to some of cancer because it's related to the risk factor, like smoking or viral infection. So lung cancer, anal cancer, or hepatocellular carcinoma tend to have high incidence in this population. Let's look at this case. She's a lady who has Hodgkin lymphoma, and PET CT was done as the lymphoma staging. So he has FDG avid in bones and also lymph nodes. So you can see the lesions in bones and lymph nodes. So biopsy of bones shows granulomatous infection, but lymph nodes show Hodgkin lymphoma. So you can have coexisted cancer and infection, which is quite difficult in looking at clinical manifestation. So when in doubt or whatever, do biopsy in several sites might show you this condition. So let's move forward to the next case. He has CD4 count very low, has severe pain of extremity, while he has serious pneumonia. As you can see, infiltration everywhere in his lung. And this is bone scan. Show you a Tremtech sign, which is typical for periosteitis, and this is hypertrophic osteoarthropathy. So keep in mind that patients with HIV tend to have chronic and serious pneumonia. So they can have other musculoskeletal disease, like is this a secondary aspect of HIV? So this is another kind that you have to looking at. And this is another one about HIV, that you have T cell quite low. This is the first diagnosis of HIV. He presents with fever, abdominal pain, and weight loss, and you can see lymph nodes, necrotic lymph node everywhere. So this proven to be disseminated tuberculosis. We start treat him by giving antiretroviral drug and anti-tuberculosis drug. He gained weight. His CD4 count improved, but 5 months later, he presented with tenosynovitis of the ankle. Whether this is failure of treatment or whether it's something else, we can call this immune red constitution inflammation syndrome, which is restoration of immune system during the action of some alkyl pathogens. And TB and fungus is a key finding because it's sensitive to T cell lymphocyte. So we continue treating him with the same regimen, and this is 2 months later, can get improved. So just keep in mind that during the treatment, this doesn't mean that you have failure of treatment, but this is a normal general reaction of immune response. What is the future challenge in this population? Let's get back to our septic arthritis case. He has improvement, and then he has total hip arthroplasty within the age of 36. Another case came with CD4 count quite low and avascular necrosis of bilateral hip. And finally, he get bilateral hip paralysis in 36 years old. So avascular necrosis can occur like hundreds times higher than general population in affected people, and it is affected young people. The cause is still not known, but it's mainly related to HIV because it's caused inflammatory response over there. It can have because of hypocoagulability, because multiple organ failure, and retroviral duct itself. And the situation right now for meta-analysis, they still have good outcome. They have comparable complication rate, which is from matched population. But anyway, surgical procedure is recommended when you can have controlled disease, which can have CD4 count roughly about 500 or no antiretroviral detection. So I have take-home message. So just keep in mind that you may have people living with HIV coming to you in any ages, any patterns, and they're living longer. This can cause the leading cause certainly infectious disease, which have wide range of organisms, but it also can have non-infectious condition, and osteonecrosis is one of the leading cause. Remember that the patient is on treatment, so you may have complications from the drug itself, and reconstitution syndrome is one of the typical findings in this population. So thank you very much for your attention, and I'm happy to take questions.
Thank you so much. That was a really wonderful collection of cases and very well presented. Thank you so much. Are there any questions from the audience? The fact members are waiting. If there are some questions, we can take them. Otherwise, everybody's hungry and we can move on to lunch. Okay, can we have the faculty for a group picture here, please? I think we'll move on to lunch.
Thank you very much. Thank you. Thank you so much for sharing. No, it's always a pleasure to be here. Yeah, good to be here.
I want to see so I can see my notes.
Okay. Just click right.
Just get them to put my presentation on. Can you get them to load my presentation here? Pinto. Clinton.
Okay. Your first session, right?
Yeah, but can you find my presentation?
Yeah, just cover.
Just first he has to find my presentation.
मतलब उनको वो करना है ना प्री प्रेजेंटेशन मतलब प्रेजेंटेशन भी दिखेगा वो भी दिखेगा नेक्स्ट वीक है ना
Yeah, this is what I want, but can you show me my presentation?
just a second.
This is not mine.
Which one is yours, sir?
This one.
A very good afternoon to all of you. So we have a few audience and we have a very interesting speaker. Dr. Clinton Pinto, he is from Auckland, a fine musculoskeletal radiologist with interest in musculoskeletal oncology, sports imaging, rheumatology. And when we recently met, he himself proposed that he would like to talk on something that he feels needs to be addressed and is close to his heart, and that is related to mentorship and teaching. And even I'm more keen to hear his talk. So what he's going to talk about is mentorship in musculoskeletal radiology, how to be a better mentor and how to be a better mentee. Dr. Clinton Pinto. And the chairperson is here, sorry, a little bit. And I invite Dr. Kavita Vaishnav to please come on the stage and chair the session.
Can you bring the first slide up, please? Thank you. Okay. Tēnā koutou katoa, and thank you for the warm welcome to Ahmedabad. And I'm grateful to Dr. Drushia and Ankur for their kind invitation and for balancing such deep science with such a stellar social program. And while mentoring, sorry, I'm just going to try and sort out my slides here. Sorry, so while mentoring might seem like an unusual and unconventional topic for a radiology congress, I feel it's vital because we spend our careers obsessing over diagnostic precision in the smallest pixels, yet the true longevity of our specialty is not found in our workstations or on our scanners. It lives in the lineage of expertise we pass down. So today we're going to explore both sides of that coin, the art of intentional mentoring and the mastery of being a mentee. My mentor, Dr. Dave Geller, once told me, Clinton, we are hardwired for stories. Be a storyteller. So today I want to share my clinical career through the lens of mentorship, exploring its profound impact on both the individual and our profession. This talk is actually a tribute to my many mentors who shaped me. So to kick things off, a quick show of hands. How many of you are mentors? And how many are mentees? Okay, so whether you're a mentor or a mentee, or ideally both, let's look at how we maximize these relationships. I have no personal disclosures aside from my digital mentee helping me polish the slides. Mentoring in medicine takes many forms, each serving a unique purpose. So beyond the formal and particularly the informal relationships that we're going to talk about today, which include peer mentorship, support among similar stage colleagues, typically residents, near-peer guidance, which is bridging the trainee to consultant gap, and identity-focused mentorship, which is where there is specific challenges through shared backgrounds like gender or ethnicity. As a senior registrar in Auckland, I confided in my mentor, Dr. Bert de Straka, about my desire to specialise in MSK radiology. He immediately suggested the Netherlands, and then I expressed concern about the language barrier. He said that everyone spoke English, so no problem. And that very same day, he contacted his colleague and friend, Professor Hans Bloom. Months later at RSNA, Bert arranged for me to meet Professor Bloom, and despite a packed schedule, he quietly attended my small non-MSK talk. Afterwards, over a beer, he dropped the ultimate career changer. So Clinton, would you like to come to Holland? And that single invitation launched a 2-year fellowship in Leiden, paving the way for a 20-year career as an MSK radiologist and a specialist in bone and soft tissue tumour imaging in New Zealand. Beyond that, it has allowed me to cultivate this legacy, guiding the next generation of radiologists. The impact of these two incredible Dutchmen on my career is immeasurable. What began as informal mentorship has evolved into a lifelong friendship. Of course, you don't have to be a charming Dutchman to be a great mentor. We'll explore the yin and yang of these relationships, how to be a better mentor, how to choose the right one, and how to become a stellar mentee. True mentorship at its heart has no agenda except the development and betterment of the mentee. That's it, period. In the opening chapter of Homer's Odyssey, now brought to us on the big screen thanks to Christopher Nolan, the the goddess Athena disguises herself as Mentor, a trusted old friend of Odysseus, who has been lost since his conquest of Troy. And Mentor approaches Odysseus' son, Telemachus, encouraging him to embark on a journey to find out if his father is still alive. In ensuing episodes, Mentor provides the guidance, encouragement, and support that Odysseus needs to persevere. The mentor-mentee relationship is a genuine bond between two individuals, developed instinctively and entirely free of pressure. Its sole purpose is to guide and support the mentee, exactly as the original mentor did for Telemachus. Why bother becoming a mentor? Mentorship is the gift of unveiling the hidden power and potential within someone else. We use our own experiences, the mistakes, the triumphs, and the wisdom to help a junior colleague truly thrive and reach their peak. There are three core pillars to my why. First, legacy. I was mentored incredibly well. Passing that on is not just a choice, it's a fundamental responsibility rooted in our 2,400-year-old Hippocratic Oath. Second, humanity. Sharing knowledge is an essential human quality. We build the next generation who will in turn do the same for those who follow. And third, future-proofing. Great mentorship protects our specialty. The active interplay between mentor and mentee keeps things dynamic and fresh. Beneficence, acting solely for the good of another, is the bedrock of mentorship. My lifelong mentors, including Bert and Hans, never sought anything from me. Their singular goal was my growth as a physician and a person. This complete absence of mental self-interest is the only true place to start. In the mid-80s, 5 frustrated Auckland medical students rejected rigid didactic teaching in favour of the mortuary. There they found a wealth of cases and a legendary mentor in Professor Tim Kohlmeyer, a devotee of medical history and the Oslerian ethic. They dubbed themselves the Breakfast Club, a nod to both their early starts and the rebellious students in the contemporary film. Born in Ceylon, now Sri Lanka, to the burgher community, Tim trained as a surgeon under the philosophy of Sir William Osler. Relocating to New Zealand in 1972 with his doctor wife Mary Ann, he retrained as a forensic pathologist. He subsequently played a vital role in high-stakes cases, most notably the 1979 Mount Erebus disaster. Tim's background matters because he, like us, is a product of his time and upbringing and was enriched by his own mentors. Mentorship is not a single knowledge exchange. It is a filtered, refined, and distilled source of cross-generational wisdom. That is its true superpower. The Breakfast Club grew to about 20 students who traded formal lectures for independent post-mortem learning, yet consistently aced their exams. And it became a hub for peer and near-peer mentorship where seniors naturally guided the juniors. My initiation, however, was more of a hostage situation. When I tried to leave my first autopsy, Tim literally tied me to a mortuary tap to keep me captive. I was hooked, attending hundreds of autopsies and becoming a proud flag bearer for the club. Sir William Osler remained Tim's most influential lifelong mentor despite them never meeting, proving that mentorship does not always require proximity. This also illustrates a fundamental reality. One can be both a mentor and a mentee at the same time. These roles don't compete, they complement and elevate each other. Tim's influence was transformative. Beyond guiding my first publication as a junior med student and shaping my strongly patient-centric clinical approach, he nurtured the curiosity that led me to radiology and championed me through every transition, even actively encouraging a detour into history at Cambridge. When I arrived in Leiden, the Netherlands, for my MSK fellowship, Wim Olbermann, a respected senior colleague with an international reputation, was not exactly a hugger. Initially skeptical of a non-Dutch speaking Kiwi kid taking a spot from a local, he eventually saw my hunger to learn and finally took me under his wing. He taught me the bone biopsies and radiofrequency techniques that helped define my career. Thereafter, whenever I faced a difficult case, I'd ask myself, what would Wim do? We even collaborated on complex spinal procedures across 18,000 kilometers, and in turn I passed his techniques to my own juniors. My guru Thich Nhat Hanh illuminated, we are the continuation of our parents, ancestors, and teachers. Though Wim has passed, he lives on in me, not just in me, but in the countless trainees he shaped. Mentorship, I have learned, transcends both distance and death. For the budding mentees here, I hope you see what a force for good mentorship can be, not just for your career, but for your life. With informal mentorship, it all happens organically. Just bring your true self. Mentorship is a two-way street that fosters mutual satisfaction and commitment. Mentors find fulfillment and rejuvenation by developing the next generation and being reverse educated. Yet true mentorship isn't just about utilizing a mentee's tech savviness. It's about valuing their fresh perspective on MSK radiology, medicine, and the wider world. To stay relevant, we must remain teachable. So what does good look like? It's a partnership that supports both the individual and their career. Informal mentorship is ideally suited to a subspecialty like MSK radiology. We have a relatively small global community, an exceptionally steep learning curve, and a vital need to pass deep expertise directly to the next generation. Mentorship thrives at the intersection of three core attributes. First, competence. Clinical mastery makes you a mentor worth following. Second, confidence. The psychological security to teach without ego and share your vast knowledge freely. And finally, commitment. The selfless investment of your most valuable asset, time, into the long-term development of your mentee. When these three align, mentorship moves from simple supervision to a transformative partnership. I believe these 5 qualities define a great mentor, and while each is valuable, I want to highlight one crucial distinction. A good mentor is a good listener, but a great mentor is a great listener. They don't just listen to you, they intently hear and value the voices of everyone around them. So choosing a mentor requires a balance between serendipity and intention. While you may stumble upon a great guide by chance or destiny, as in my case, it's completely fine to be deliberate. Informal mentorship is, after all, a personal choice. But rather than choosing prominent names, prioritize colleagues whom you genuinely respect, those who are available, experienced, and relevant to your own goals. Dr. Aditi Bunker, an internationally renowned academic at Heidelberg University, notes that sometimes overcoming fear to reach out can lead to something meaningful. Or if it's an empathetic person who is simply too stretched for time, they might recommend someone else suitable. As she puts it, if you don't ask, you'll never know. Thereafter, approach the initial engagement as a trial period, align on expectations early, and feel empowered to politely move on if it's not the right fit. Career mentorship is not one size fits all. As your goals evolve, you need different guides for different seasons. So for research, seek an academic mentor who understands the grant and peer review labyrinth. Or for technical mastery, you need an MSK interventionist to pass down tactile, hands-on wisdom, your own Wim Oberman. Do not look for a single lifesaver, rather build your own personal board of directors. Digital connectivity already allows us to mentor across continents seamlessly. So what is the logical next step? Your very own AI mentor. I asked ChatGPT to take on that role, and of course it was more than obliging. Each to their own, I suppose. But while algorithms offer immediate data, they lack the lived clinical wisdom, shared professional lineage, and above all, the empathy that only a human colleague can currently provide. Selecting a mentor is a form of professional risk management. Stay alert for potential red flags. Avoid ego-driven personas. Humility is vital. An unchecked sense of self leaves zero room for your growth. And shun hypocritical conduct. Mentorship demands integrity. If their daily actions contradict their counsel, they are a supervisor to navigate, not a mentor to emulate. Let's define the rules. While a coach talks to you, a mentor speaks with you. The relationship must be reciprocal and mentee-driven. My high school friend, James Gibson, a top corporate lawyer, captures the essentials. The mission, Define your goals early. Why are we here? And small things matter. Professionalism, boundaries, and organisation are non-negotiable. Establish these on day one. And without these guardrails, the partnership will fail. To dive deeper, I recommend this article from our ESSR colleagues. Like our focus today, they highlight mentoring as an invaluable asset. Additionally, the ESSR guide, Creating an Educational Structured Report, bridges the gap between daily guidance and formal evaluations. Sorry, this is a 20-minute talk, or? Okay, sorry. Otherwise, Okay, anyway, I encourage everyone to support the juniors as well, because there's immense value in everyone getting involved. This APA guide provides the psychological framework to keep things structured, safe, and productive. So what then makes an outstanding mentee? You are the primary catalyst. Without your energy, the relationship withers. Propel progress by arriving prepared, setting the agenda, and completing tasks unprompted. Identify your own knowledge gaps, seek specific guidance, and accept feedback gracefully. Mentors provide the map, but you must hold the steering wheel. To explore the mentee perspective, I'd like to introduce Dr. Ethan Breinhorst. We met over a decade ago. Sorry, I'm a bit confused. Do I have... Is it okay? Okay, that's cool. Okay. No, so then I won't rush. Okay. So Dr. Ethan and I met over a decade ago when his family immigrated from South Africa to New Zealand. At 16, he had 0 medical connections, just a massive dream. I've since had the privilege of mentoring him through medical school, his marriage to Kindra, and now into fatherhood. I'm delighted that he is currently more than halfway through his radiology training. This is more than professional oversight. It's a lifelong connection that's enriching both our lives. Ethan likens our decade together to the art of bonsai. Every tree, every mentee is unique with its own roots, soil, and environment. Like the bonsai artists, a mentor role isn't to impose a design, but to nurture natural growth with gentleness and subtle direction. It is a deeply reciprocal journey where both the artist and the tree evolve together. When I asked Ethan to reflect, his response humbled me. He noted that we never followed a master plan. We simply stayed connected and honest. And to me, that's the heart of mentorship. It's not about dictating goals, rather acting as an ally, helping to clear the obstacles while ensuring the mentee stays entirely true to their own path. To improve as a mentor, focus on 2 deliberate practices. First, uninterrupted time. Carve out quiet, device-free space, because this signals absolute trust and builds respect. Second, the art of listening. Give your mentee the freedom to be heard fully without immediate reaction or judgment. This single shift transforms your meeting from 2 busy minds competing into shared moments of presence. Master these, and the results will speak for themselves. Mentorship, however, is not always smooth sailing. Sometimes the seas get quite rough. As mentors, we are charged with helping our mentees navigate the brutal trials of life. Right now, another mentee of mine, a dedicated radiology registrar, husband and father, is facing his final attempts at the Part 2 exams. If he doesn't pass, his more than 5-year dream of becoming a radiologist ends. The stakes couldn't be higher. In this moment, my role goes beyond exam technique. I must provide the emotional anchoring he needs to conquer his anxiety, silence his self-doubt, and find his path to success. And good things take time. Remember that mentorship is dynamic. Like a fine wine, our professional relationships develop and mature over many years, and this is a very good thing. Dr. Kathy Cram from Boston University defined 4 phases of mentorship. Initiation occurs in the first year as we build trust and set the rules of the game. Cultivation marks the 2 to 5 year period of maximum growth and support. And separation means transition as the mentee gains independence and intense guidance dissipates. Redefinition is the final phase where the relationship either naturally concludes or evolves into a lifelong friendship. Tim and Marianne Kohlmeyer, now in their late 70s, navigate life with remarkable vitality. despite significant challenges. They embody the redefinition stage of mentorship, where formal structures dissolve into genuine, enduring connection. And here's what redefinition looks like at the MSS, with Hans Bloom, his lovely wife Ava Yilpis, who has been with us here when we were in Jaipur. It turns out even world-class MSK radiologists have to start from scratch when learning to tie a Rajasthani turban. Beware, redefinition can lead to unpredictable outcomes. My mentee, Dr. Marcus Guman, is now my lifelong friend and my boss. In fact, he's the one who approved my leave to be here today. And as you can see, we take a pretty relaxed approach to MSK radiology in New Zealand. Marcus would argue that after a few years, it's just like riding a bike. In conclusion, never underestimate the power of high-quality, informal mentorship. Whether it arises by happenstance or destiny, it makes us better MSK radiologists. We're more rounded, more compassionate. Mentoring is a true extension of the gift of self. In our ever-troubled world, it is a veritable force for good. To close the loop, I invite you to participate in what I am calling the AMS and MSS Ahmedabad 2026 Mentorship Challenge. Sometime today, tonight, next week, or this year, find yourself a new mentor, or find yourself a new mentee. Finally, on behalf of AMSIG, the Australasian Musculoskeletal Interest Group, I warmly invite you all to our 2027 annual scientific meeting in Melbourne this May, the perfect excuse for a trip down under to Australia and New Zealand. Kia ora koutou. Thank you for your kind attention.
Thank you, sir. It was excellent talk, and hope we will learn something as a mentor and try to become a good mentee also, because radiology is a lifelong experience. We have to take some experience from our teacher. And nowadays you have mentioned the gift, that the listening, which I think nowadays the students or our residents, they have not that much good listener. So I think the good listening is a very good habit to become a good mentee as well as the good mentor. And communication as much we required. So being a mentor and mentee, the relationship and communications, which is very important to develop the relationship. So thank you, sir, once again. Now, I would like to invite our next speaker, Dr. Mihir Devzala. He is a professor and principal at GG College of Physiotherapy. And sir has done his BPT, MPT and PhD. And sir, areas of interest is sports and neurophysiotherapy. So, and sir has PG and PhD guide at our own Gujarat University. Welcome, sir.
Thank you so much. My topic of presentation is When Imaging Meets Rehabilitation, a Sports Physiotherapist Perspective. An MRI can identify a torn ACL in 30 minutes. Rehab determines whether the athlete safely returns to sports over the next 9 months. So there are two questions which comes in the mind. How many athletes have a completely normal MRI but persistent pain? And the second one is, how many have an abnormal MRI but no pain? So always it is advised that clinically one should correlate what has been diagnosed in imaging technique. So persistent pain, that might be a normal MRI also, ongoing discomfort might be there. Then comes rehabilitation. We give targeted exercises and therapy, progress monitoring, regular assessments and adjustments, and then safe return to the sports only when full function, pain-free range of motion and enough muscle strength is achieved. That's very basic I am talking about right now. So why this topic is important? So nowadays sports medicine is no longer divided into sports medicine expert, orthopedic surgeon or a radiologist. It's a team which works together to have a athlete on ground again with full force and full passion back to his sports. So first of all, whenever an injury happens, then it is investigations are to be done. There is a role of a radiologist, MRI, CT, whatever it is required. Then after the diagnosis is made, if conservative treatment or surgical treatment is required, an orthopedic surgeon or a sports medicine surgeon is required to treat the patient surgically or conservatively. Then comes a role of a sports physiotherapist. Then comes strength and conditioning coach. And then finally, if the physiotherapist and a conditioning coach gives a green nod, then the athlete will return to the sport unless and until he receives a full performance and full function back to the normal. So imaging diagnoses the tissue and rehabilitation restores the function, right? So imaging in sports rehabilitation. So what MRI says, for example, here in a ACL MRI of a left knee ACL injury, what MRI can say? Exactly what tissue is injured, location, severity, and associated injuries. But what, as a physiotherapist perspective, what we see is whether range of motion is there, whether enough muscle strength is there, whether psychologically the person is ready to come back to the sport again, whether full agility is there, and other perspective we see as a movement experts. So these are the two things, different things, where what radiology diagnosis and what we see as a physiotherapist. Even psychological readiness is very, very important for especially the sports person. Now, role of different imaging modalities. For example, as you all know only, but just let me say here as a part of the presentation, X-ray, usually bone injury, fracture alignments, MRI, gold standard for soft tissues, bone scan, early stress injury, ultrasound, dynamic muscle, tendon, ligament assessment, CT, complex fractures, stress fractures, DEXA, bone density in stress injuries. Every investigation answers a different clinical question, but a physiotherapist should know what is relevant and when. Now there is one example of impact of imaging. I'll take example of a hamstring strain. So in a grade 1 strain, early loading, initiate loading and running protocols within 7 to 10 days. Short-term recovery is there if it is a grade 1. Expect a full return to activity within 2 to 3 weeks. Grade 3 or more it is there, more injury is there. Protected loading. Utilize cautious protected loading and progressive strengthening exercises. Here, as it's grade 3, long-term recovery will be there, requires extended healing time with return in 8 to 12 weeks of time. So imaging helps in deciding the exercise dosage to the physiotherapist, sports physiotherapist, like when to start with the loading, how much loading, when to progress, when to stop, timeline, how much duration of rest is required, when to start what, and risk factors associated with particular condition. So imaging helps physiotherapists to decide all these 4 categories. Clinical decision making. First, imaging supports clinical reasoning, it does not replace it. So clinical reasoning is must as a part of a sports physiotherapist. First history we take, then definitely imaging comes, then comes clinical examination, diagnosis, rehabilitation. After rehab is over, functional testing is there where we see the performance level of an athlete, and then only return to sports is possible. So there is an example of ACL, structure versus function. So MRI findings include ACL complete tear, bone bruise, meniscus injury, cartilage injury, and MCL involvement. But as a physiotherapist assessment, which focuses fully on whether full extension can be achieved, swelling control is there or not, quadriceps activation is there or not, single leg balance athlete can achieve or not, hop symmetry, it is very, very important. It should be more than 90% so as to pass the athlete to the field again. Psychological readiness and movement quality, and of course strength. That is very, very important. So as a physiotherapist, if functional healing is achieved, 100% ready for the sports. And if structure healing is confirmed, still we cannot be sure enough that athlete can be ready to go back to the sports again. For example, if a ACL graft shows complete healing on MRI, but it does not guarantee that that athlete is ready to join back the sports again, because there might be a quadriceps weakness or some other issues, or movement is not fully achieved. Return to sports is not only MRI based. So why a normal scan doesn't always mean an athlete is ready to play? Because pain, strength, power, neuromuscular control, hop tests, psychological readiness, load tolerance, and sport specific skills are really required. So MRI assesses structural healing, but clinical assessment evaluates functional readiness. That's very important. So both should come at a time: healing, structural healing, as well as functional readiness by clinical assessments. So always clinically correlation is required with radiological findings. So when imaging and clinical findings differ, there are cases where this too might differ. For example, lumbar disc bulge is diagnosed in an MRI, but no pain on performance issue despite MRI findings. So here we need to observe. Movement dysfunction, normal MRI but severe knee. If I take an example of anterior knee pain, especially due to bad biomechanics or kinetic chain issues, there might be a dynamic valgus in a patient which could not be diagnosed on an MRI, dynamic valgus for example, but MRI shows completely normal. There might be a hip abductor weakness which might lead to anterior knee pain. So these are the criteria we need to compare clinically as well as with radiological findings. There are some asymptomatic findings also in a professional athlete with a shoulder, rotator cuff partial tear, but no symptoms. A tennis player, for example. Neuromuscular recovery is must. MRI shows healing, but poor mechanics increases re-injury risk. So these all factors are supposed to be considered with radiological findings. So radiology guides rehabilitation progression for sure. Just for an example, a ACL repair is done. Faster rehab is possible if there are no complications, and the rehab part will be delayed if some complications is noted. For example, MRI shows a complete normal graft and everything is normal, then we just tend to move in a faster pace as required. But MRI shows a complication like a cyclops lesion here as seen on the image, then definitely the recovery will be delayed, and there might be a possible surgery also in between. So definitely the rehab and all other joining back to the sports will be delayed for sure. And there will be loss of extension also because of this lesion or a complication. Radiology guides rehabilitation progression. For example, a stress fracture, if we take grade 1, walking is allowed, and grade 4, it might be delayed for sure. Evidence-based return to sport. Integrating radiology with objective functional testing for a safe return. Functional testing, which assesses strength, balance, agility, psychological readiness, evaluates mental preparedness for the sport, and medical clearance definitely obtained with the help of a orthopedic surgeon or a physician or a sports medicine expert to return to sport. Pain-free होना चाहिए, no swelling, range of motion and strength more than 90%, hop symmetry should be more than 90%, imaging as when required. The future of sports medicine imaging. Integration of imaging with biomechanics of human motion. Combining imaging data with biomechanical analysis. AI-assisted MRI interpretation using artificial intelligence to enhance MRI analysis. Wearable technology and motion analysis utilizing wearable device to track movement. Ultrasound guided rehabilitation. Employing ultrasound to guide physical therapy. Quantitative MRI and elastography measuring tissue properties with MRI techniques. Successful return to sport. Normal radiology findings, clinical reasoning that should match objective functional testing, and shared decision making with the team. These are the few examples, the same things what I told previously. Interactive discussion, like some questions. MRI abnormality treatment should should every MRI abnormality be treated? Not necessarily. Return with abnormality. Can athlete return with an abnormal MRI? So there might be some cases post rehab and post performance analysis by a movement expert. There might be some abnormal MRI findings post surgical treatment and post rehab. So that must not be the case that should stop the athlete to not join back the sports again. Failure despite normal findings. Can an athlete fail return to sport despite a normal MRI? Yes, there might be some clinical issues, there might be some biomechanical issues, there might be some strength issues for sure, despite of normal MRI findings. Healing versus recovery. Which is more important, MRI healing or functional recovery? Both are important, MRI healing and then definitely a functional healing to join back or return to the sports again. So the evidence based, a persistent MRI abnormalities. Persistent MRI abnormalities often remain after athlete becomes asymptomatic. 30 to 40% asymptomatic athlete abnormalities. For example, 30 to 40% athletes have imaging abnormalities like meniscal tears, after rotator cuff, pathologies, lumbar disc. Stronger predictors of success is strength, off performance, and psychological readiness are stronger predictors of success than MRI appearance alone. So both should be correlated for sure. Radiology as well as performance. So this is in short what we have discussed till now. Athletes return to play, injured athlete, structural damage, limited function, structural healing. Radiology identifies and treats the injury, functional recovery, rehabilitation improves movement and strength, sport-specific performance, training for sport-specific demands, returned athlete, structural healing should be there, functional recovery, sport-specific performance achieved again. Thank you so much. I would like to thank the organizing committee of this conference, Dr. Ankur sir and Dr. Drushi ma'am for inviting me here, and thank you so much again. Thank you.
We all understand it is extremely important to
Good afternoon,
see
everyone.
actually the
I'm
functional
Professor
improvement rather
Yong
than
Lu
just
from
MRI.
Beijing Hospital,
For the next
Shanghai
session,
Jiao Tong University.
we have a recorded talk of
Today, I will
Dr.
talk about
Yong Lu on
osteosarcopenia
osteosarcopenia.
and
He is
how
an
we
expert
use
from
imaging
China. Unfortunately, he
to
couldn't travel
check
because
bone
of the
and
visa
muscle
issues,
health.
but we have his recorded lecture for us on the
Osteosarcopenia means
osteosarcopenia.
weak bone plus lost muscle. It makes it senior fall and break bones easily, which is the top reason for old age disability. I will talk about basic knowledge, imaging tools, test markers, real clinical cases, and AI new technology today. Medicine speed up osteosarcopenia, aging, little exercise, not enough protein or vitamin D, long-term inflammation, and hormone changes. This picture shows the bad cycle. Less muscle holds bones and raises fracture risk. Good afternoon, everyone. I'm Professor Yong Lu from Beijing Hospital, Shanghai Jiao Tong University. Today, I will talk about osteosarcopenia and how we use imaging to check bone and muscle health. Osteosarcopenia means weak bone plus lost muscle. It makes it senior fall and break bones easily, which is the top reason for old age disability. I will talk about basic knowledge, imaging tools, test markers, real clinical cases, and AI new technology today. Medicine speed up osteosarcopenia, aging, little exercise, not enough protein or vitamin D, long-term inflammation, and hormone changes. This picture shows the bad cycle. Less muscle holds bones and raises fracture risk. Weak bone also make muscle fall off fat and lead to falls. Combined imaging help us do 4 important jobs. Find only hidden changes. Pick out high-risk seniors. Make personal treatment plans and check if treatment work over time. Osteoporosis happens when our body breaks down bone faster than it bones new bone, making bone inside loose and fragile. DEXA scan is the standard way to test bone strength. Doctors use one simple score to judge bone health: healthy bone, low bone mass, or osteoporosis. Small portable DEXA machine can test bedside patients easily. Sarcopenia is muscle loss as we grow old. It is caused by inflammation, lower hormone levels, and no regular movement. We follow 3 steps to diagnose it. Simple question, hand strength, and walking speed test. Then imaging to machine to measure muscle amounts. The MRI imaging clearly shows old people have much fat inside their muscle, unlike young adults. Bone and muscle send special signals to each other. Their balance breaks down when we age, which causes osteosarcopenia. The whole body, including gut and nerves, also takes part in this process. We also have some integrated imaging modalities. The first one is DEXA scan. DEXA almost has no radiation, cheap, fast, used widely in hospitals. It tracks both bone density and muscle mass. But it only takes flat imaging and cannot see fat inside muscle. Good afternoon, everyone. I'm Professor Yong Lu from Beijing Hospital, Shanghai Jiao Tong University. Diagnosis it. Simple question, hand strength and walking speed test. And imaging to machine to measure muscle amounts. The MRI imaging clearly shows old people have much fat inside their muscle, unlike young adults. Bone and muscle send special signals to each other. Their balance breaks down when we age, which causes osteosarcopenia. The whole body, including gut and nerves, also take part in this process. We also have some integrated imaging modalities. The first one is DEXA scan. DEXA almost has no radiation, cheap, fast, used widely in hospitals. It checks both bone density and muscle mass. But it only takes flat imaging and cannot see fat inside muscle. LCT takes 3D imaging to measure real bone quality and calculate how much fat is inside muscle. We started nearly 17,000 Chinese people and found QCT is better to check bone loss with age. But QCT has more radiation, higher cost, and not every hospital has this machine. MRI is no radiation at all. It is the best tool to check muscle fat. We use AI to automatically tell muscle and fat apart on MRI pictures. But MRI is very expensive and the scan takes a long time. Ultrasound has no radiation, easily to carry, and can be used beside the patient's beds. We judge muscle health by how bright the imaging looks. Weak point is tested result depend a lot on doctor's experience. At the end of this part is a simple table to compare all four tools for your quick references. We have two groups of markers, markers for bones and markers for muscles. For bones, we measure how much bone there is and check how tight the inside bone structure is. For muscles, we measure how big the muscle is and check how much fat grows inside the muscle. Now doctors do not only care about muscle and bone size. The quality of tissue is more important to predict falls and fractures. One study published in JAMA Cardiology used the normal chest and the abdominal CT scans to check patients before heart surgery. They split patients into 4 groups based on muscle size and bone strength. The long-term follow-up results tell us people with both weak bone and little muscle are 3 times more likely to pass away within 1 year after surgery. We can use daily CT scan to screen osteosarcopenia without extra radiation for patients. We built an AI model named UNET. It can automatically find bones, muscles, and fat on CT pictures. Calculate all test numbers quickly and save doctors lots of manual joining work. AI will change how we manage osteosarcopenia in 3 ways. At first, AI will finish image analysis automatically with stable and accurate test data. Second, build prediction models to tell how may fall and break bones in future. And third, combine all scan data together to give each patient fully personal medical plans. With AI, we can stop this disease early instead of treating serious problems after they happen. Here are 4 key takeaways. We must check bone and muscle together, never judge them separately. DEXA, QCT, and MRI form we set for imaging tools for different clinical needs. We need to test the bone tissue amount and the tissue quality to find high-risk patients. AI technology simplified imaging work and help us give more accurate medical care. Using combined imaging and standard test markers, let us treat seniorly early, reduce disability, and improve their quality of life. This is the end of my sharing. Thank you for listening.